Thank you, sir. And I now invite the chairpersons for the first session. Dr. Deepak Agarwal, neurosurgeon at AIMS, New Delhi, and Dr. Kundan Shifal, senior consultant in the Department of Radiation Oncology, RGCIRC.
As mentioned by Dr. Prem Sagar, so this is the first session is basically radiation oncology. And if we look at neuro malignancies as such, so radiation has definitely played a very vital role in the management of these malignancies, as well as in benign diseases also. So the first talk in this session is by a radiation oncologist. So our opening batsman, Dr. Praveen Elawat, he is consultant in the Department of Radiation Oncology at Rajiv Gandhi. And he would be speaking on the topic of radiotherapy for recurrent glioblastoma, evolving strategies and future direction. This is almost a very difficult entity to treat. So, Dr. Praveen.
Good morning. Thank you, ISNO, Delhi Neurological Society, Chairperson, and especially Dr. Prem Sagar for inviting me for this to present on this topic. So my topic is radiotherapy for recurrent glioblastomas. Essentially, that means the re-irradiation, because most patients would have had received radiation therapy in their first occurrence. So if in 21st century, the state-of-the-art treatment for newly diagnosed glioblastoma is surgery, which is the maximal safe surgery, followed by adjuvant radiotherapy to 60 gray in 30 fraction, along with concurrent temozolomide, and followed by 6 cycles of adjuvant temozolomide. And if available, tumor treating field also can be used. So this has been the mainstay of treatment since almost 20 years for newly diagnosed glioblastoma. But no matter how well you treat, what technique you use, what surgical technique, radiation technique you use, the survival is dismal. So this is the list of survival outcome from all major hospitals across India. You notice that these median survival in almost all the studies around 10 months. 10 to 13 months. Even the landmark trial by Stoop et al. Showed that the median survival is only around 13 months. So this bad is the prognosis. Before we go on for re-irradiation, let us look at what is the pattern of failure for glioblastoma. So this is the picture. On your left, you're seeing a radiation planning for a previous first course of radiation. In the center, you can see the surgical cavity and the enhancing wall. The red color is delineated as post-op bed, and then 1.5 centimeter margin circumferentially shown in blue color, and another 3 millimeter margin for the PTV. So patient has developed recurrence after few months, and the middle picture shows the recurrence, area of recurrence. So you notice that most of the recurrent part is in and around the previously irradiated area. And when you open up 95% isodose curve, you see the most of the almost 99% of the recurrent area is confined within the high dose previously irradiated region. So the point is most glioblastoma, they recur in the vicinity of previously located region. So now moving on to the recurrent glioblastoma, which is the topic. The first thing first, when you need to, whenever we see a recurrent, looks like recurrent image of glioblastoma, it is extremely important that we differentiate whether it is recurrence, truly recurrence, or it is radiation necrosis. I'm not going to detail at all, but it is extremely important that we we should not leave any stone unturned to find out that this is not a recurrence or this is not a necrosis. So the treatment options today, actually there is no standard of care treatment for recurrent glioblastoma. This is the list of possible available modalities. We have the repeat surgery, repeat radiation, also called re-irradiation, systemic therapy, and many of them will also require best supportive care. So this is a practical approach to recurrent high-grade glioma. When we see recurrent high-grade glioma, we basically see whether the first thing we see what is the performance status of the patient. It is good or poor. If the performance status is poor, we look at whether the symptoms or the performance status is caused by peritumoral edema or steroid toxicity. If yes, we can consider a trial of bevacizumab to reduce peritumoral edema, hoping that the symptoms will improve. But by and large, most patients will undergo best supportive care. If the performance status is not because of the edema or steroid toxicity, even then, because the patient has poor performance status, we will not be able to give any aggressive treatment. Most of the patients will end up having best supportive care only. But those who have good prognosis at the time of recurrence, we look at the pattern of disease. If the disease is local pattern, whether it is a recurrence or progression, first thing is to look for whether it can be resected almost completely. If it can be done, then surgical resection is the preferred treatment, followed by adjuvant treatment. It could be systemic therapy or it could be re-irradiation. If the surgical resection is not feasible or cannot be done to a near total extent, then there's no point doing the surgery. You can do surgery to gain symptomatic improvement, but it will not change overall survival. So in that case, systemic therapy, re-irradiation, or if available, alternating treatment field can be used. Those patients who has diffuse or multifocal recurrences, in those patients, local treatment is obviously not possible because the risk-reward ratio do not favor any treatment. So in those cases, and systemic therapy is often the only choice. So when we talk about re-irradiation for management of recurrent glioblastoma, best possible treatment today is repeat surgery. So this is the meta-analysis shows that if you do repeat surgery to a near total extent, you have a better survival to the hazard ratio of 0.72. On your right, you are seeing a graph which shows over last many years, surgical outcomes have improved, leading to a better survival. Starting from 2013-14 to 2018. So this is because of the advancement in surgery, neurological imaging, as well as adjuvant treatment given after surgery. Who are the best candidate for surgical resection? The best candidate are young patient with good performance status, having small tumor burden, having longer time to recurrence, and near total extent of surgical excision possible, and adjuvant treatment. Now coming to our topic, re-irradiation. This is repeat radiation. I remember when I was in post-graduation, the rule was once irradiated can never be irradiated. So this was the concept at that time. But today, if you look at our department, almost 1 in 10 patients is undergoing re-irradiation. This is all because of the advancement in techniques and our better understanding of tolerance doses to organs at risk. So what are the possible benefits of re-irradiation? One, then if you give re-irradiation, probably it will reduce corticosteroid use, either in terms of doses or duration. It may improve neurological symptoms, and in selected patient, it increases progression-free survival and possibly overall survival. Why re-irradiation was not done earlier? Even today, why is it so challenging? Because if you are given re-irradiation once to a radical dose anytime in the past, most likely adjacent tissues would have exhausted their radiation tolerance. an important thing about neurological organs at risk is once the recovery is much slower than any tissue outside brain. So the organs at risk, they do not forget their doses. Over a period of time, they tend to forget their doses, but it is a challenging to deliver again a tumoricidal doses. So the fear of exceeding dose tolerance to the healthy brain tissue and therefore the higher risk of severe side effects. So these are the various strategies for re-irradiation. We have the traditional, conventional fractionated radiotherapy. We do it by IMRT or IGRT. We also have stereotactic radiosurgery in single fraction. We also have fractionated stereotactic radiosurgery. We can combine radiation therapy with temozolomide. We can combine radiotherapy with bevacizumab. And today we also have another armamentarium called proton therapy. So I will be showing you results of these strategies. SRS for re-irradiation. So this is a list of all the previously done studies. The important thing about re-irradiation for recurrent glioblastoma is we do not have any prospective or randomized studies. All that we have is the retrospective series. Many of them are small size, small number of patients. So we do not have any concluding evidence about re-irradiation. So this is a list of retrospective studies on stereotactic radiosurgery for re-irradiation. You see the total dose delivered in one single fraction is ranged from 12 to 18 gray. Median survival is around 10 months with re-irradiation with stereotactic radiosurgery. When you look at the toxicity, it seems to be in a single digit or probably lower single digit. So toxicity is very well acceptable with stereotactic radiosurgery. Next is the hypofractionated stereotactic surgery. Hypofractionated stereotactic radiosurgery is rather delivering in a single fraction, you deliver it in 3 to 5 fractions. So various doses per fraction utilized so far is varies from 3 gray to 7 gray per fraction. If you look at the median overall survival, it again range around average of 10 months. Also, the toxicities, even with hypofractionated stereotactic surgery, is acceptable. Third is the re-irradiation with temozolomide, whether it is concurrent or adjuvant in any form. So this is the list of, again, all retrospective studies. You look at the median overall survival, it is again 10 months. But you notice that if you add temozolomide with re-irradiation, the hematological toxicities are high. So much so that almost one third, almost 40% of the patient end up having grade 3 or more hematological toxicity, especially thrombocytopenia. Also, if you add concurrent or adjuvant temozolomide with re-irradiation, you have more chances of radiation necrosis. It ranges from 7 to 8%, and histopathologically, it is proven in 4% of patients. Bevacizumab has been in talk. When you combine bevacizumab and re-irradiation, this is the results. Again, you see median survival has increased by 1 or 2 months. So this is all retrospective study. We have one prospective randomized control trial, phase 2 trial, which compared bevacizumab alone with bevacizumab plus radiation therapy. So you see, the progression-free survival is better if you add bevacizumab to re-irradiation. However, it does not change overall survival. Sub-analysis of this trial showed that bevacizumab and re-irradiation works better in those who have a good performance status, and if the re-irradiation is developed at first recurrence, rather second or third recurrence, and in those who have methylated, MGMT methylated tumors. So these are all the various strategies of re-irradiation. Radiation necrosis is a very extremely important late side effect of re-irradiation. On your left, you are seeing an exhaustive list of various studies which has shown the incidence of radiation necrosis. So as you see, radiation necrosis is actually quite significant. It is almost in the double figure. So symptomatic brain necrosis is a serious late consequence of re-radiation. Incidence varies from 0 to 24% at 1 year. If you deliver EQD2 of 100 to 110 gray, the chances of having radiation necrosis is around 10%. But if you increased EQD2 to more than 30 gray, cumulative means combined radiation dose from the first and the current radiation, the radiation necrosis increased to 25%. But the good thing about radiation necrosis is many of the time it will be seen on imaging only. Symptomatic radiation necrosis is lesser. So in clinical practice, to have an acceptable risk of radiation necrosis, or to keep it, let's suppose around 10%, 10% could be considered as an acceptable radiation necrosis, we need to deliver 15 to 16 gray in a single fraction using SRS. If you're doing a fractionated SRS, then the dose has to be restricted to 25 to 30 gray. A low risk ranging from 0.8 to 6% has been observed following re-radiation using conventionally fractionated radiation. Conventionally fractionated radiation means around 2 to 3 gray per fraction. Proton therapy has been a new weapon in radiation oncology. On your left, on your right, you're seeing radiation therapy dose distribution using IMRT. And on your left, you're seeing dose distribution because of proton therapy. Sorry, it's the other way around. So on your right, you see the proton therapy has delivered much lesser doses to surrounding organs at risk, hoping that it will reduce the side effects. So this is the only major study so far we have for proton therapy. It is an analysis of the multi-institutional proton collaborative groups registry published in 2020. You see, if you have delivered proton therapy for re-irradiation, the median PFS is around 13.9 months. It is slightly better than the historical series from SRS or conventional RT or fractionated SRS. Median overall survival is slightly better. We saw in our earlier slide that it varies around 10 months. It is now 14 months now. So coming to the patient selection for re-radiation, who are the patients who are suitable and who are the patients who are not suitable for re-radiation? So on your left, you are seeing patients who are good candidate for re-radiation. On right, who are not a candidate for re-radiation. So when you look at age, younger age, the younger the patient, the better he will tolerate radiation, re-radiation.
Sir, if you could conclude.
Yes, sir. But good performance status is against the good patients, good mental status, and we have longer time of progression-free survival. They do well. Site of recurrence, if you have distant recurrences, re-radiation works well. Target volume delineation has to be very limited and conservative. We will not give more than 3 to 5 millimeter margins. Often, the best supportive care could be the most common treatment option for recurrent glioblastoma. And the best strategy for recurrent glioblastoma today is clinical trial. So this is my concluding slide for re-radiation. There is a lack of prospective data on re-RT. All that we have is retrospective series. Suitable candidate for re-RT are younger patients with good performance status and at least 6-month interval from the first course of RT. We need to choose appropriate radiation technique according to tumor size and location. SRS given in one or few fraction can be recommended for small or moderate sized tumor. Fractionated SRS should be used in the doses of 1.8 to 3.5 Gauge per fraction for larger tumor. Consider bevacizumab for progression-free survival benefit. Thank you so much for hearing me. Yes, sir.
Yes. Radiation, and there is comparison between the two.
Okay, I mean, you are asking, sir, if patient is MGMT methylated patient, so which is better, the temozolomide or bevacizumab. So we do not have any direct head-on comparison, but considering that historical studies shows that temozolomide works better in MGMT methylated, it makes a case for temozolomide. But when you look at the evidences favor bevacizumab. It is not that the evidence favor bevacizumab, but there are no evidences, no prospective studies done for temozolomide. But we do not need any prospective study because it is a well proven in literature that MGMT methylated patients do very well with temozolomide. Also considering the safety profile of temozolomide should be a preferred agent. But if you have MGMT methylated and too much of peritoneal symptomatic edema, then bevacizumab is the drug of choice.
Thank you, Dr. Praveen. I think it was an excellent talk. And we now move on to
Thank you.
the next speaker, which is by Dr. Sushant Sahu. He is from SGPGI, and he'll be speaking on the principles of gamma knife. I would request all speakers to please stick to their times.
Thank you very much, chairpersons. So first of all, I would like to thank Professor Prem Sagar for inviting me to this scientific session on brain and spine oncology. So being a neurosurgeon, I'll not go into the details of gamma knife radiosurgery, which is beta, gamma knife, proton, JAP, and standard radiation oncology. So I believe that SRS, whatever mode we use, if you know the basics of SRS and the basics of tumor, probably that will help in determining how we use it. So rather than going into the details of how it works, I'll try to like correlate the clinical features, correlate the clinical scenario of the patient, and correlate the tumor biology and the tumor perspective along with the radiation for our better understanding how it works. Right in this era, ABM is and the gamma knife radiosurgery is considered as probably the best treatment for best modality and best adjunct for treating ABM, vestibular schwannoma, metastasis, meningioma, cavernous sinus lesion, and so many other lesions. But these are considered as one of the giving better result with gamma knife radiosurgery. In ABM, if you consider that is no doubt that if we the marginal dose is some 22 to 25 gray at 50% isodose, they have a very good outcome. As in this case, we are seeing at 12 months post-op, so the patient is having the volume reduction is seen almost 50%. At 2 years, it is 70%, and at 3 years, almost 90% volume reduction in majority of the cases if you target the feeding artery. But the question arises in ABM if the ABM is associated with aneurysms, because in ABM, I will not go into the details. It is already described in the literature. So many literature is there already that it is the standard is now SRS if surgery is not feasible, or surgery is at risk. So the question is if it is associated with aneurysms, because with increasing use of like DSA, we are finding more and more number of cases of AVM associated aneurysms. So whether we should go for embolization, go for SRS, or a combination. So there are two different concepts are there. If we embolize or if we suddenly absorb the AVM, then there is a high chance that the flow of the blood will be much and aneurysm may rupture. And the second concept is if we obliterate the AVM, then the flow related aneurysm must go. So to understand this, the basic concept is if where the aneurysm is, in some of them are flow unrelated, some are flow related on the feeding artery, and the distally or proximally, or some are in the intranidal. So the basic concept is if the flow is increases, so at times the vessel wall remodeling is not able to compensate the high flow and resulted in aneurysmal dilatation. So there are the literature is also showing that in majority of the cases the bleeding may be from the AVM, maybe from the aneurysm, but it is not getting very clear. And all these cases, gamma knife is also showing good result, and the follow-up is also having that the rebleed rate is significantly less in these kind of cases. But again, in which cases we should treat them with gamma knife radiosurgery alone, or in which cases we should first embolize those cases, followed by gamma knife radiosurgery. To answer this, in our series, we have included almost more than 50% of the cases. The 50 cases, and in majority of the cases we found that concurrent aneurysms do not the results do not differ than the AVM alone. So this is one case where we can appreciate, in addition to AVM, there is a distal flow-related aneurysm on the feeding vessel that is in the distal ACA. So we consider that we'll treat the aneurysm alone with gamma knife radiosurgery. 25 gray, 50% isodose were delivered to this case. It was a ruptured AVM, and after some 3 years, we found that the aneurysm is gone along with the vessel, along with the flow-related aneurysm and the entire AVM. So the conclusion is, if the feeding artery distal aneurysm is there, there is no need to obliterate with embolization. Gamma knife radiosurgery is sufficient in this case. However, if it is in the proximal part of the feeding artery, so the concept is we should obliterate it first, then followed by treating the AVM, so that the flow to the aneurysm should be dealt with first, and then the AVM, so that the chances of rebleed will reduce. As in this case, the flow-related proximal aneurysm we first embolize, then the nidus was treated with gamma knife radiosurgery. Another important concept which is less discussed with pregnancy and these kind of cases treated with gamma knife radiosurgery. A few of the patients we never consider, like in our young patient, what should be the many patients ask if the treatment is going on, whether they should go for pregnancy, because in many of the tumors there is increased blood flow, there is increased size of the tumor, and it has been documented in the literature many times. The patient may need urgent surgery. The same thing will happen with AVM also, because in this case the patient was treated with 25 gray, 50% isodose, and the AVM remains stable after 1 year. But at 19 months, patient was pregnant. At fourth month of pregnancy, patient has a rebleed in the AVM. So these kind of patients must be counseled that pregnancy has to be avoided till the aneurysmal nidus is completely obliterated and patient is stable for few years. Then only this can be planned, because AVM also behave in the similar way. So the concept of the tumor biology and the AVM biology should be considered during the treatment, as well as advising the patient in the follow-up. Next, another concept is veins and sinuses in gamma knife radiosurgery. This is a case of falcine meningioma, which was treated with 15 gray, 50% isodose. But after 12 months, patient has a significant peritumoral brain edema. There is a beautiful paper from AIIMS New Delhi also, where they have shown that the chances of peritumoral brain edema can be very high, as high as 30 to 40%. So in this case, how to deal with these cases, how to prevent in these cases? To answer this, in few years back, we have a concept that can the veins and the cortical veins and the sinuses be seen on the same image on MRI? So to answer this, we have a very good concept that we usually give a contrast dose of 0.1 millimole per kg body weight, where half of the dose is injected 1.5 ml per second. After a gap of 90 seconds, we inject the second half with 3 ml per second. This provided a very good differential enhancement of the tumor as well as the cortical veins and the sinuses. When these two can be incorporated into the gamma knife the suit, then we can delineate the tumor differentially and protecting the cortical veins and the sinuses. Cortical veins and the sinuses radiation dose is one of the factors for peritumoral brain edema, in addition to the tumor biology and other factors. So in these kind of cases, what as a radiation oncologist, if we can preserve those veins, then probably the chances of edema will reduce. And we have also compared in these kind of cases, if we deliver a dose to the tumor, then there is significant reduction to the scattered dose to the adjacent veins and the sinuses. So this is what we found in few of our patients when we compare how the radiation dose is there to the tumor as well as the adjacent cortical veins. So the radiation dose to the cortical veins and the sinuses significantly reduces when you use this kind of image directly on MR venogram. And this is what we published, and this is in the first phase we published this concept, and in the second phase it is still undergoing. Probably in another few months we'll be able to compare the radiation treatment on standard contrast MRI and comparison with these MR venogram images. Another concept is cystic vestibular sonoma. Everybody of us know that SRS is now considered as a very good modality for small size vestibular sonoma less than 3 centimeter, even if a Coos grade 4 sonoma without any mass effect. But in 2015, there is a landmark paper from Pittsburgh showing that cystic vestibular sonoma behave very nicely. In 1995, there was the first paper came that cystic vestibular sonoma also behave nicely with stereotactic radiosurgery. But to understand, all the cystic vestibular sonoma do not behave uniformly. To understand this, we analyze all these cases and define the cystic vestibular sonoma. This cyst volume is more than 30%. This can be further categorized as predominantly cystic or predominantly solid if the cystic volume is more than 50% or the solid volume is more than 50%. So this is our classification. This is the type 1 is a predominantly cystic single cyst vestibular sonoma. Type 2 are the predominantly solid cystic vestibular sonoma with a single cyst. Type 3 are the multicystic predominantly cystic vestibular sonoma, and type 4 are the multicystic, predominantly solid vestibular sonoma. So looking at the effect of gamma knife radiosurgery in these kind of cases, particularly for tumoral cystic vestibular sonoma, we include the entire cyst volume, the enhanced cyst volume in our treatment protocol, and we found that these patients behave very nicely, and almost after 9 months to 12 months, the cyst goes and only the solid portion is remaining, and the patient has, the rest is they behave as a solid vestibular sonoma. So this is another example of a type 2 cystic vestibular sonoma where the cyst is gone after almost 18 months and only the solid portion is remaining. They will follow the same pattern as the solid vestibular sonoma behaves following stereotactic radiosurgery. So this is another example of type 3 cystic vestibular sonoma, multicystic, and the multicystic usually they converted into a single cystic vestibular sonoma, and it will take a long time. So these kind of cases need to be followed for a longer time because they may take a long time to reduce for the reduction of the volume of the cyst, and further it will convert into a solid one, and this will follow the same pattern as that of the solid vestibular sonoma. So this is another case of a type 3B where it will take a long time to reduce for the reduction of the solid vestibular sonoma. So these kind of patients should be under strict follow-up. So this is what we conclude, that the cystic vestibular sonoma also respond well to gamma knife radiosurgery, but the response is not uniform. The single cyst have a better outcome than the multicystic vestibular sonoma. So the multicystic vestibular sonoma, if we are considering for gamma knife radiosurgery, one has to be extremely careful, and these patients need to be followed very regularly because they may have symptoms in between and they may require surgery. So what we consider nowadays, if the cystic vestibular sonoma comes to us, then we first analyze whether the patient is symptomatic. If the patient is symptomatic, then first choice is surgery. If the patient is not symptomatic, if it's a multicystic vestibular sonoma, still you offer surgery, and we try to preserve the vestibular, the facial nerve, and we leave some amount of tumor at the canal, and the rest of the solid vestibular sonoma can be irradiated with gamma knife radiosurgery. So next question is whether gamma knife radiosurgery works uniformly for large vestibular sonoma. The literature suggests that Coos grade 4 vestibular sonoma gamma knife radiosurgery works nicely, and the complication rate is significantly, it is low and it is under control. It is hardly 5% of the patient requires ventriculoperitoneal for hydrocephalus, and redo surgery rate is less than 10%. But the problem is that if the patient is already symptomatic, if there is tinnitus, so they may get aggravated to pseudoprogression. The overall rate of worsening and the new onset tinnitus is almost 6.8%. So in these kind of cases, surgery has advantage over gamma knife radiosurgery. So these kind of cases, surgery can be considered. The problem is all the Coos grade 4 vestibular sonoma are not uniform. So for a radiation oncologist, we will have to understand. So there can be, the patient can be asymptomatic. So probably this is the only subgroup where we can consider gamma knife radiosurgery or any modality of SRS which we have. But if the patient is symptomatic, if there is compression over the brainstem, if the patient is having hydrocephalus, if there is features of the lower cranial nerve, then patient definitely requires surgery. Now surgery is safe. We have multi-modalities neuromonitoring system with which we can preserve the facial nerve. And if you do a subtotal resection, following this subtotal resection, the small amount of tumor which is remaining, now many studies are showing this subtotal resection following gamma knife radiosurgery, they behave nicely and the tumor is remaining stable in the long-term follow-up, and the patient is also okay. In our series, in my personal series of over 350 cases of vestibular sonoma given gamma knife radiosurgery, only 12.42% are Coos grade 4 asymptomatic cases where we treated with 12 grade 50% isodose is the standard in these kind of cases, and those patients have remained stable, of which only 9.3% require surgery in the follow-up and 3 require hydrocephalus for ventriculoperitoneal shunt. But again, if the patient is symptomatic, in 52 cases, we offer surgery first, a facial nerve preservation surgery. Majority of the patients are doing well. There is no facial palsy. Facial palsy is happened in 2 out of 46 cases. And if the tumor is remaining, like in the first case, if the tumor is remaining only at the internal auditorium areas, this can be followed up. And if there is some growth is seen, then those can be taken up for gamma knife radiosurgery. In those cases, we can give 12 grade 50% isodose. In those cases, it is away from the brainstem. It is safe for gamma knife radiosurgery. And those patients are remaining stable for a long time, and they require long-term follow-up to look for the further growth of the tumor. So the real gray zone is if it is a Coos grade 4 vestibular sonoma, if it is behaving well, that is nice. But if there is tight posterior fossa, then you have to look for if the patient is developing any symptoms related to hydrocephalus, those patients may require surgery in the follow-up. So the aim is we need to integrate all our microsurgical skills and the radiosurgical approaches. So all these patients has to be like a combined decision should be taken with the neurosurgeon as well as the radiation oncologist. What should be the best for the patient? Now coming to skull-base lesion, few skull-base lesion behave very nicely to gamma knife radiosurgery, as in this case, it is a residual cavernous sinus hemangioma, they behave nicely. But all the cavernous sinus lesions do not behave uniformly to gamma knife radiosurgery. Only gamma knife radiosurgery, the outcome is very nicely seen in case of cavernous hemangioma. This is another case. But does it have clinical outcome? Because in these cases, all the cranial nerves are very adjacent to the cavernous sinus lesion. So we try to find out, we try to correlate what is the outcome in relation to the cranial nerves. As in this case, the patient only symptom was diplopia on right lateral gaze because the patient has a right lateral rectus pulse. So in this case, what we found that as the tumor gradually shrinks, the compression over the nerve goes and the patients and symptomatically improve. But this does not happen in all the cases because this concept we try to translate into tumor-related trigeminal neuralgia. Because in many of the cases, tumor-related trigeminal neuralgia, the tumor is compressing the fifth nerve. So the patient may ask gamma knife radiosurgery in those cases, but the outcome is not uniform. To understand this, what we have tried, we try to analyze these cases. In my personal series, we try to categorize them at the type 1 radiological response. If the tumor reduces in size, but the nerve is not seen. In type 2 radiological response, the tumor shrinks and additional portion of the fifth nerve is seen. And in type 3, tumor further reduces and the fifth nerve is completely free. To analyze all the three kind of responses, we found that in type 1 response, the outcome is the pain-free control rate is 55.5%. In type 2, it is 65.2%. In type 3, it is 77.7%. Again, the advantage is that in type 3 response, if the patient is not improving, then we can offer gamma knife radiosurgery as a pain relieving procedure. We can directly target the nerve with 80 to 85 gray, and the patient will have a very good the pain-free outcome in these kind of cases. So now coming to understand the different the physics behind gamma knife radiosurgery. I'll not go into the details of it because because I feel that the radiation oncologist and our radiation physicists they are more they have the better understanding than the neurosurgeon to understand this. But we try to analyze all these parameters, the tumor volume as well as all the gradients like the homogeneity index, and the conformity index. We have tried to analyze all these cases, whether all these are necessary to find out all these in tumors. They are not uniform in all these kind of tumors, because in case of pituitary adenoma, the tumor is just adjacent to the optic apparatus. Optic apparatus need to be protected with 8 gray outline or 8 or 9 gray outline. The cochlea need to be protected with 4 gray. In those kind of cases, all these parameters are not uniform. So these parameters may be very low, or they may be out of the range in case of pituitary adenoma, because non-functional pituitary adenoma may require 12 gray outline, and functional pituitary adenoma may require 24 gray for acromegaly, up to 25-26 gray for Cushing's disease. So these parameters may not fit into their range. At times the AVM may be irregular. So in AVM these may also differ. So these parameters are not fixed in gamma knife radiosurgery. However, they change from tumor to tumor. And if the tumor size is very small, the smallest collimeter which is available in gamma knife is 4 millimeter. So if the tumor is small, then of course all these parameters will change. So for a radiation oncologist and for a neurosurgeon, when we are planning the case in gamma knife radiosurgery, we should not be so dogmatic to find out all these parameters should be remain in within the range. They may be beyond the range, and this do not affect the clinical outcome, which we found in the analysis of almost over 450 cases in this series. And the clinical outcome will analyze in the second phase of this study. So another important factor in case of gamma knife radiosurgery.
Can now conclude.
Yes, sir. Just last 2 slides. So in gamma knife radiosurgery, we need to have a very good follow-up, because some of the benign tumor respond nicely. They will remain stable for a longer period, as in this case of the endolymphatic sac tumor. And almost after 5-7 years, the radiology show that there is reduction in the tumor size. However, in some of the cases, you may get surprised. Like in this case, we initially thought it to be a trigeminal sonoma treated with 12 gray outline. Patient remained stable for 7 years, 8 years, and on 9th year, the patient had an increase in the tumor size. Patient became symptomatic and initially refused surgery. And when we operate, to our surprise, this turned out to be a chondrosarcoma. So then we found out in literature, the indolent course of the chondrosarcoma is already described. So what we consider, we all got deceived that the indolent course of the chondrosarcoma, we considered it as the effect of gamma knife radiosurgery. So following SRS, and SRS is a very important adjunct for management of all these kind of cases. This can be considered as a primary modality of management. However, we need to understand all the surgical aspect of the tumor, the behavior of the tumor, then the tumor biology need to be understand. And it is a combined and it is a collaborative work of the neurosurgeon, the radiation oncologist, and the radiation physicist. If we can understand better the radiation aspect as well as the tumor aspect, then probably we can give the better outcome for the patient. Thank you very much.
Dr. Sahu, for that exhaustive, nice presentation. Any questions? We can take one question. So I have a question for you. As in the previous talk, we had for recurrent gliomas, as radiosurgery, either in multiple doses or as a single fraction. So in your institution, what is the dose you give if you give for recurrent GBMs?
Sir, recurrent GBM, personally, I have very less experience with gamma knife radiosurgery. So I know there is a good series is coming from AIMS, but personally, I have a very limited idea on recurrent glioma.
Because we give usually around 15 to 80 grays, 18 grays.
Yes.
And
That also we do. Around 20 gray, we keep it around 20 gray. And again, for recurrent glioma, what you consider, because the tumor cavity may be there, you may have a nodule at one point, but still some part of the cavity is enhancing. That also need to be discussed.
Another discussion point, whether we treat the T2 hyperintensity,
Yes.
or we treat only the contrast.
Only the contrast, because for high grade glioma, it is contrast enhancing, that we believe. So recently also I have one patient where we treat the nodule as well as the cystic cavity, but still under follow-up. So I have limited actually data on this. Still. Secondary metastasis? Yes, sir. Metastasis data, still it is under follow, but still you consider if it is, I think Dr. Deepak can answer to this also, 1, 2, 3 or 4 metastasis, I am very comfortable. But for multiple metastasis, they may behave in a different way.
The number one indication for gamma knife in the world.
Yes.
And in US and Western countries, the unlimited 40, 50 metastasis
Yes.
also they treat in single session in the same patient.
The advantage, I think, is the sharp fall in the the dose, scattered dose. Gamma knife has the beautiful role is that there is a sharp fall in the scattered dose. So we can treat as many lesions as possible.
Correct.
Unless and until it is very close to the optic nerve or something we need to protect. Otherwise, it is quite easy with gamma knife. Single sitting we can give.
It is available fractionated, but for if the metastases are multiple and small, single
Then-
sitting is preferred.
Single sitting is better, I think. So in this, because sharp dose fall is there. Thank you, sir.
Thank you, Dr. Sahu.
Thank you,
so
sir.
much. Now I would invite our organizer, Professor Prem Sagar.
Good morning, everybody. So, Dr. Sushant, after the very nice talk of Dr. Sushant Sahu, he has got a lot experience in gamma knife. So, we have got the cyber knife last year only. So, we don't have that much experience. And our cases are all oncology cases, benign as well as malignant. And we do it, I'm thankful to my radiation oncology team, we do it with them. Dr. Munish Garola, Dr. Parveen, Dr. Sarthak. So before the advent of this cyber knife or the radiation oncology, neurosurgeon used to take out the total tumor and particularly benign tumors because reoperation and recurrence was a problem. So this was a patient who has been operated before advent. This is total tumor removal, but however, there was a lot of morbidity. So and the patient was drowsy, a lot of morbid conditions. But with the advent of hysterectomy radiosurgery, function perfect surgery has become more common and not the picture perfect surgery, which was the principle before the advent of this. And remove as much as possible, but while preserving all functions, radial can be treated by SRT later on. So John Adler he's a neurosurgeon and radiation oncologist, and he was the chief of both departments at the Stanford University School of Medicine, who invented cyber knife in 1990, and he fitted lightweight LINAC at the tip of the industrial robot for the precision delivery of the radiation. So this is radiation S8 latest model which we have bought, and this is the collimator stand and the couch.
And these are the two the X-ray machines which are fitted with the ceiling, which keep track of the target, so there is no movement for the precision delivery. And here the patient who is head is fixed with the mask with the table, and this is a console room where we keep track of the patient and the movement of the robot. And we will take few of the clinical cases because we don't have a large series. 22 years female complained of headache, and she had a large meningioma, which is encroaching on the suprasellar cistern and also invading the tentorial margin. The patient was operated, the partial tumor was, subtotal tumor was removed, and to keep the preservation of all the functioning nerves. And then the patient underwent CyberKnife, 21 grain, 3 fractions. And there's another patient, 35-year-old working female, operated for pituitary fossa meningioma in 2021. At that time, when she came, she had no PLPR, and the right eye had 6/6 vision. However, and after the first surgery, she did not receive any radiation because this was grade 1 tumor. But when she came, she had visual deterioration in the right eye also for 2 months. And we got the MRI done, which showed the large tumor which is filling whole of the pituitary fossa. So she underwent de-exploration with the purpose that we might take out more of the tumor so that we can irradiate leftover later on. But only partial decomposition was possible because tumor was inseparable, all matted with the optic apparatus. Biopsy was again meningioma grade 1. She underwent CyberKnife 25 grade 5 fractions. Vision improved after CyberKnife. And another patient, 39-year-old female, complained of headache, meningioma, the convexity meningioma, easy to take it out, but later, unfortunately, she had a grade 2 meningioma. So because the chances of recurrence, she underwent another CyberKnife, 21 grain, 3 fractions. 46-year-old male from Jamaica, West Indies. He had visual diminution in right eye and headache. Underwent craniotomy in October 2021 for craniopharyngioma in the competition at the University Hospital, Kingston, Jamaica. And this was the MRI at that time. This was radiologically diagnosed as the craniopharyngioma cystic as well as solid. And at that time his vision improved. Biopsy was inconclusive because a small tiny bit was removed. Vision deteriorated again. After a few years, he came to Delhi for SRT, and he did not want to get repeat surgery done. The block and slides were received from Jamaica, and we did the review, and it was again inconclusive. So the tumor board we presented, and they said we need to have a biopsy for the irradiation. So he underwent re-exploration RGCI, and this was the tumor at the time of surgery, and the tumor was all behind the optic nerves and below the optic chiasma. So we explored all possible corridors into third ventricle through lamina terminalis, but no tumor seen. Biopsy again was inconclusive, but we decided to give CyberKnife 25 gray in 5 fractions. Another patient, 50 years male, complained of vertigo, difficulty in hearing. And this is a small, this is a medium-sized CP angle tumor or post-operative small residual tumor which underwent CyberKnife 18 grade 3 fractions. And another patient who was admitted for surgery, unfortunately his platelets were very low, so he could not undergo surgery, and it has to be irradiated by CyberKnife, 25 gray 5 fractions. This is a case of a small tumor from Nepal, and she wanted some treatment, not the follow-up. So she underwent CyberKnife 14 grain single fractions. And this is an unfortunate patient, 60-year-old lady with large CP angle tumor. She underwent operation 3 times and CyberKnife twice. And when she came, this was the tumor, and first surgery, the tumor was the same size in 2018. And we operated in 21, and this is post-operative. But unfortunately, the size grew again. This was a rapidly growing tumor, and she underwent CyberKnife in other institution because at that time we did not have CyberKnife. 18 grade 3 fractions. So this is post-CyberKnife, there is central necrosis. But after the CyberKnife, also the solid part grew. So she underwent again surgery, and this is the post-surgery. And then again, it started growing. So she underwent second CyberKnife, 30 grade fine fraction. Now she is doing fine. And the patient of the trigeminuralgia, V1, V2 division, classical. And the patient had a vascular compression, but never did not give consent for surgery. So he underwent CyberKnife 57 grade, single fraction. and there was a pain relief. The Barrow Neurological Institute grade was from 4 to 3A. That means some pain which was not adequately controlled by medication before CyberKnife, and now no pain on medication, and medication also reduced 25%. 56-year female, known case of RCC, renal cell carcinoma, headache and weakness in the left hand. She had 2 lesions, one in the right side at the hand knuckle, other was in the right and left frontal, and both we did CyberKnife. On the right one, it was 27 gray in 3 fractions. The left one, single dose, 20 gray. And she came to follow up. This is post-op, post CyberKnife, and she's doing fine 18 months after. This is another patient, known case of CA breast, presented with imbalance in gait. On examination, overwork was positive. Brain MRI showed solitary brain metastasis in the pontine region. This is a cystic lesion, large. So we put a ZD frame and took the patient to CT, and the CT and MRI were fused, and we extrapolated the coordinates, and under local anesthesia we did a burr hole, and this is the xanthogenic fluid removed from the pontine lesion, and residual tumor was biopsied, bits and pieces, and it came out to be secondaries from the breast. And this is a pre-op and post-op, post-biopsy MRI. She underwent CyberKnife. And this is the pre-CyberKnife and post-CyberKnife, almost complete resolution of the tumor. 52-year male, operated right frontal astrocytoma, grade 4, post-RC radiation and chemotherapy. He started having weakness in both legs, operated, and we found there's a lesion, intermedullary lesion at D11. He underwent surgery, and it came out to be GBM. So he received CyberKnife 25 gray in 5 fractions. So, I mean, we will not go in detail about the use of CyberKnife or the histotactic radiation over the conventional radiation because of this toxicity. So that's why whenever feasible, it is better to do histotactic radiation than conventional. However, all cases are not indicated. So with the gamma knife and CyberKnife, the only difference remains the gamma knife because the head goes into the helmet. So this is the radiation comes in the 100-degree, but CyberKnife, the robot can move all around the patient head and the whole body. So it delivers radiation 360 degrees. And I mean, the quality-wise, both are fine, are the same overall results. But however, because of single fraction in gamma knife, but while CyberKnife, you can fractionate it. However, there's a problem with CyberKnife. They say in the gamma knife, you can do all the treatment in a single day. But CyberKnife, you cannot do same day. It has to be done on second day or third day because the quality assurance checks which are done by physicist and by computer. That's JAPSEC. Unfortunately, JAPEX person is not available here to give the talk. But this is JAPEX, which only one machine is available in India. And I saw one machine in Germany. And there, the beauty of this machine is there's a line all around. So the surgeon, the doctor can go beyond that line. But in CyberKnife, you cannot enter inside the room. But this also can treat only the brain as the gamma knife. However, the CyberKnife can treat all the body organ tumors, including a spine. So it can treat lung, primary or second or metastasis, liver, HCC and metastasis, pancreatic tumors, prostatic, because all are being used in our hospital. So when we do all this histotactic radiation, when there is a comorbidity, surgery is not possible, or there is old age, patient is not willing for surgery, and the tumor has been partially removed, or there is a recurrence, or the chances of recurrences. So claustrophobia is not that much, but the patient is masked. Sometimes the patient may have some claustrophobia. There may be brain edema. There may be radiation necrosis. And occasionally, one of the patients, we saw the focal hair loss, which is not very common, histotactic radiation. This was the patient who has large secondaries, and this radiation was given. There's a focal hair loss, which improved. So in conclusion, CyberKnife is same for brain and spine lesions. When it is a residual tumor, it is a recurrent tumor, surgery is not possible. So we in our hospital, we have done about 100 cases and in the various indications. And so and the overall follow-up is not more than 1 year. So it is not possible to find out how many patients are doing well. Thank you very much.
Thank you, sir, for that very nice overview. I just want to add that, the potential for any machine is quite a lot. And obviously, the caseload can be improved multiple times. For example, at AIMS, we have 7 linear accelerators, one gamma knife machine, and the linear accelerators are running 24 into 7 because of the waiting list. Even then, for GBM, the waiting time is 2 to 3 months minimum. You can imagine the load on the institute. And we then give gamma knife to these patients because gamma knife, the waiting time is less. So for any institute, whatever you have, I think even Rajiv Gandhi is quite overloaded in terms of the caseload. So there is a huge potential for cyber knife in the other tumors also, besides obviously the brain, and that is the beauty of it. The other amazing thing is that it took a neurosurgeon actually, John the Adler,
Yes.
to invent CyberKnife as well as Zapex. And Zapex, the beauty of Zapex, it's a mini linear accelerator which does not require a bunker. So there is no shielding required. That's because it's self-shielded. So I think that decreases the cost of installation because the bunker itself, what I understand, cost around $1 million to $2 million to create. So that cost is immediately discounted for. So I think that can be a huge cost saving when we start using these kind of equipment in a regular practice.
Yeah, thank you very much. Because in gamma knife, you require replacement of the source, right?
Yes.
Every few years.
Every 3-4 years.
So unless you have two gamma knife, then it is difficult. I mean, your work is stand still at that time. Okay, thank you very much.
I think next speaker is online. So are we connected?
Yes, I'm there.
Yeah. Good morning, Dr. Jalali.
Morning.
So the next talk is by Dr. Rakesh Jalali, and we all know him very well. He's a renowned neuro radiation oncologist. Presently, he is basically medical director and senior consultant at Apollo Chennai Proton Center, and he's known for his many decades of research work, which are basically not only research work, but they have translated into a clinical practice and had made an impact on how we treat these patients. So he would be speaking on the role of proton therapy in brain and spine oncology. Thank you.
Thank you very much. Good morning, everyone. I'd like to begin by thanking Dr. Ishwar Prem Sagar to ask me to participate in this very nice meeting. And I apologize that I could not be there in person, but I'm grateful that he allowed me to share some of our experiences with proton therapy in CNS tumors online. So thanks very much. We all know the physics of proton therapy, which makes it attractive to some extent, and it has got this remarkable ability of delivering ionization radiation after a finite length, depending upon the density and energy, and deposit all its energy and translate into what is called a Bragg peak. And William Bragg got the Nobel Prize of it after it. And then there's a remarkable, what I call a waterfall, with literally no dose whatsoever. And this was the advantage because there is practically no exit dose, very little dose to the surrounding tissues as compared to conventional radiation. And obviously, there were several advantages. But we also realized that it is not so simple. There are uncertainties where the Bragg peak is there. It is fraught with complexities of the putting up the infrastructure, the physics behind it, the different energies were not there. The original proton therapy had a lot of scatter, and we had to put collimators and apertures on it, and therefore it was limited to very few centers in the world. It quite changed with the modern times, and that is why there is almost like a renaissance of proton therapy throughout the world, including in our region. This is the Proteus 235 cyclotron that we have here from IBA Belgium, and it is probably one of the state of the art. We have 3 rooms, 2 gantries, and 1 fixed room with energy of 70 to 235 with all the capability of image guidance, and more importantly, what is called the modern proton therapy. And we always say there is a proton and there is a proton, and you have to realize that the modern proton therapy employs a very small kind of a pencil beam, which is 3 millimeter, and the spot size is very important. The whole target is divided into thousands of layers, and in a very nice manner, depending upon the energy and the depth of the target that you want to treat, that we treat point by point, line by line, layer by layer, and kind of sculpt the doses and take the advantage of the beam path length, the advantage of the Bragg peak, and get very nice conformity. Even in large tumors, the greatness about the proton as compared to wonderful talks earlier on gamma knife and cyber knife is that size is not the criteria. In fact, a very small size, there can be a slightly more lateral penumbra in protons, not very particularly applicable or more attractive for a small AVM or for a small brain met. But as soon as the target size exceeds 1 to 1.5 to 2 centimeters, there is an amazing level of magnitude of benefit as compared to any form of high precision photon delivery therapy. So this is the advantage. Of course, it can treat the entire body, not necessarily the brain. These are some of the advantages. This is a spinal tumor. This is the classic technology at the moment, what we call VMAT. We also have a very nice elegant tomotherapy, and that also give a very nice distribution. And then, but when you do the proton therapy, you can see fantastic dose distribution, even a very large target, as you can see, complete sparing of the rectum, bladder, the femoral heads, the surrounding tissues, and we all are aware what amazing distributions you get in craniospinal axis radiation, practically no doses to the thyroid, to the facial structure, to the heart, kidney, liver, gonads, bones, which are absolutely important for the long-term survivorship of these children. At the same time, however, we realize that the setup is pretty expensive, only about 15 times more. The maintenance is much more expensive. The electricity, on top of it, the throughput is half, and you need much more manpower, physicist, radiation oncologist, and also the rigor that is needed because there's fair amount of uncertainty. You have to be very, very careful when you institute the proton therapy in your setup. However, there is a great potential in pediatric cancers, and there is quite a bit of data emerging on neurocognitive decline, endocrine, vision, stroke, fertility, and there's a just plethora of all the indications, including brain tumors and other sites where we can exploit it. And the American Society of Radiation Oncologists, ASTRO, gives model policies every few years. These are the latest policies last year. And they say a large majority of the central nervous system tumors, not only the melanomas and the classic indications of skull-based tumors like chordoma chondrosarcomas, they in fact say malignant and benign primary CN tumors, excluding, of course, the glioblastomas, those who are treated with curative intent and with potential for long-term prognosis and primary spinal cord tumors or even metastasis, and of course the CSI. So these are the indications of CNS. But if you look at the pediatric cancers, any pediatric cancers, they even say pediatric and AYA population up to 39 years of age, wherever you want to give radiation, and a significant proportion of them belong to the CNS tumor category, should be considered for proton if there is affordability and accessibility. As I mentioned, when we started in 2018 and 19, we quickly realized that it is a very, very intense, rigor-driven, physician-centric process. So we instituted what we call proton peer review process. We start our day early morning, what we call an ISO-center meeting. The room is also called ISO-center. That the group of people in our team, both the radiation oncologist, medical physicist, and the therapist, we meet for about 45 minutes to an hour, and we go through every single contour, every single plan, every single adaptive. It has to be counter peer reviewed, unless otherwise it won't go to the mosaic for the treatment. There's a fair amount of learning that we have acquired over the last 5-7 years. Our first ever pediatric patient, the first ever patient was a pediatric patient. Fortunately, it was in 1st January 2019, was Dr. Dev Pujari's patient, was a craniopharyngioma, got a fair bit of publicity as well. We published in Neurology India, and of course, now we have a series on craniopharyngiomas. And this child is growing up in a very nice young man, and that was the first ever patient that was treated in South Asia. We have 17 investigator-initiated clinical trials in our center, all done on a prospective databases. Every single patient of proton is in a clinical database, IRB approved. One of the first series was on adolescent and young adults called Rapper Protocol, and we published in JCO's Global Oncology, primarily to show us the initial experience of these patients, but also realized the challenges that they face coming all the way to Chennai. And we quickly realized there is hardly an SOP on pediatric anesthesia. So about anytime about between 8 to 10% of the patients. I think yesterday we treated 9 kids on under sedation. There was hardly an SOP. So we are blessed to have a dedicated pediatric anesthesiologist team. And we also published a couple of papers on it, that what are the SOPs to do. And then, of course, you do the other things. There's a movie, there's an animation film. We do a lot of artwork, and our team engages with these young kids, try to not to do anesthesia, but if they do have to treat, then of course we have all the processes in place. We are close to actually now 2,000 odd patients treated in the last 5.5 years. The minimum child is 9 years, the maximum is 91 years. The neurological tumors constitute a fair chunk of this population, but interestingly, as compared to other cancers, the pediatric cancers constitute only about 2 to 5%. The pediatric and AYA population is about a quarter of our patients. And that's how the proton center should be, because all pediatric tumors and cancers should benefit from the technology. As I mentioned, we have 3 rooms, 2 gantries. We are pretty busy now, 16 hours. Yesterday, we treated 64 patients, and the uptime is pretty good, more than 99%. And series of articles throughout the international literature. We have discussed the characterization, performance evaluation, very interesting paper in BGR about the ambient neutron contamination, which is practically extremely low, which was the challenge erstwhile in the previous scatter technology of protons. Quite a bit of shift in the technology as to how we deliver proton therapy, and now there is practically absolutely no worry on that account as well. I briefly touch upon some of the tumors in the next few minutes. The classic chordomas, we have treated about 70, 80 odd patients, and chordomas, I truly believe, should all be treated with proton, and not only me, there's an international consensus. We should try to avoid SRS, SRT. We know they are discontiguous tumors. They can have all over the planes, and the target volume is fairly large, and they are quite dose dependent. And these are our tier 1, tier 2, tier 3 doses. Tiers where we go 76 EQD2 and 33 fractions. And these are the dose constraint, and the initial experience is very good. It also, we quickly realized that many times the patients are just being referred chordoma, especially if they are recurrent, or even if are per primum and there's a fair amount of residual disease, and then there's thought that proton therapy will take care. But it is not the case at all. We are blessed to again have a fantastic skull-based neurosurgery and head and neck team, now led by Dr. Ari Chako, but previously with Dr. Rupesh Kumar and Siddharth Ghosh. And about 20 to 25% of the patients actually who are referred to us undergo resurgery, because the optic brainstem compression and the optic apparatus compression is absolutely critical, such that we cannot give the optimal doses. And there are the way, wherever we have compromised, we have seen late recurrences in these patients. So this is very important. And this led to, we think, and many people have told us, a very important contribution to the chordoma literature was published, I think, about a couple of months ago in ARO, which is an important journal from Astro, from the Red Journal group of people. And interestingly, you will see both Rupesh Kumar and Ari Chako have been acknowledged, because it is really a teamwork. And as I mentioned, in the few patients that we have not done well were the ones there was a dosimetric compromise because of lack of surgery, and there was not adequate decompression from the brainstem as well as the optic apparatus. From the sacral tumors, especially sacral chondrosarcomas, practically we don't need to operate upon them. There's an excellent response with proton therapy. They also need very high doses. We do not do routine, because they take time for over a period of time to show some responses. And we do Steven perfusion as an imaging biomarker to monitor the response for these tumors. I mentioned craniopharyngioma. This is our modest series, which was published in World Neurosurgery a few months ago. And as was shown in the gamma knife, you have to be very careful in the cystic component. And we do weekly MRIs for all these patients. And this is part of the package that we, for the patient, so you don't have to pay extra. And what I have realized, that which I have not seen in photon so much, that over in the next 6 months to a year, there's a significant decrease in the cystic component as well. So far in this relatively small series, our data is extremely encouraging, with local control of exceeding is about 100%. But clearly we need much more time and much more follow-up to have long-term confidence of these tumors as well. Medulloblastoma, classic indication of of proton, because significantly all these side effects will be low, the dose to the cochlea, dose to the heart, and so on and so forth. We were told don't treat craniospinal in the first 6 months. Our third patient was a craniospinal cases. We have actually now, not by purpose, not or by design, but just by somehow, we are now the international leaders on CSI. I've treated more than 160 patients of CSI. We have been told it's one of the largest series from one single center, and only about 5.5 years. Series of articles again. This was our first experience in radiation oncology, very intense physics appraisal in clinical oncology. We did some in Python scripting on the dose gradient of these cases. And on medulloblastomas, we published a few months ago also our series as per the risk categorization, again doing extremely well. Intracranial germ cell tumor, whenever you have to treat both germinomas, you can spare a bit of normal tissue. Again, they have exceedingly very good long-term outcome. This is just one child doing extremely well academically, and you have to follow up these patients on a long-term basis. Second, cancers with IMPT, not with the scatter technology of proton, is practically zero, and that's a great advantage of proton as compared to any conventional photon therapy for long-term potential survivors. Hypothalamic pituitary axis, significantly less endocrine deficits. Pediatric ependymomas, the 3-year cutoff no longer holds true with modern radiation, both in the photon as well as, of course, if you have the image-guided intensity modulated proton therapy. The pediatric PFA ependymomas, now we start treating at about 10 months to a year. Of course, surgery is very important for these cases, but also ATRTs, some of the medulloblastomas, some of the ETMRs, again 1.5, 2 years, you can actually deliver with quite a good quality of proton therapy. And again, ependymoma is a mixed cohort of recurrent cases, and this paper is it's in review at the moment, as well as we also give craniospinal if they have 1Q gain at the time of recurrence, but PFA has been a little bit encouraging as compared to the other category. Some of the low-grade gliomas, the chiasmatic hypothalamic gliomas, but also these difficult located cervicomedullary pilocytic astrocytomas. We do not treat GBMs in routine, but oligodendrogliomas, IDH mutant, especially if they do not have CDKN code deletion, and the IDH grade 2, grade 3 astrocytomas, I have seen some of the better responses than I used to see in the photon, and there is also some very good clinical profile. Sparing hippocampus is very important. We have published series of articles on it. As I mentioned, proton therapy also in low-grade gliomas. Vestibular schwannoma, we have 3 protocols. If they are very small, then we do cyberknife. Actually, we have a cyberknife as well here in Chennai, less than 1 centimeter to 12 millimeters. But the moment they are more than 15 millimeters to 18 millimeters, we give 3 to 5 fractions with IMPT proton. And if they are largish, sometimes they are not amenable for surgery. This is 25 in 5 with IMPT, done very well, as you would expect, central hypointensity after some time. But if they are very large, 2.5, 3, 3.5, 4 centimeter, elderly, medically inoperable, you give conventional IMPT proton, and they are also doing very well. Finally, some of difficult cases of skull-based meningiomas, especially when they have large tumor target volume, and sometimes you can see also a very good indication of optic nerve sheath meningiomas. And I had a couple of patients actually from Chandigarh, from the PGI center, which we have treated from the optic nerve sheath meningiomas with fractionated with very encouraging. And finally, these complex NF2 meningiomas, in this paper manuscript is also under review. Multiple tumors we see sometimes, they're all over the place with vestibular schwannomas. Conventionally, you cannot treat them. And with IMPT in one isocenter, you can treat them quite generously and to treat the entire dura, especially if some of them are grade 2, grade 3. And there is also good data coming up combining immunotherapy with high-grade meningiomas. And I'm particularly excited of combining proton therapy with immunotherapy. We published all the data on together. And glioblastoma, as I mentioned, we don't treat routinely, but if there is a favorable case, good resection, and we try to look the immunoangle part of it, because there was some preliminary data from MD Anderson that lymphopenia, which was a problem of radiation induced, not only in GBM, but also in esophagus large field radiation, but also in glioblastoma. This was again published a few months ago in Neuro Oncology Advances. We compared with the IMRT tomotherapy, the case controlled matched cohort, and it seems there is some benefit in the PFS and also the fatigue and other things, because the lymphopenia is significantly lesser because you irradiate significantly lesser tissues. Cost is a very, very important issue. I think Dr. Deepak touched upon it very appropriately. And we all realize whether it is a government setup or private setup, we are all, and fortunately, the democratization of proton and also the reduced section of the footprint and also the emerging data, the cost is also coming down. But also, if you look at the health technology assessment, although the proton is more costly at the beginning, both to the healthcare administrator, but also to the patient. In pediatric cancers in particular, in medulloblastoma, there is a series of articles using Marco models, but also in left-sided breast cancer, head and neck, and lung cancer. Eventually, because of the IQ preservation, reduced hormonal deficits and contribution to the society, even in the US, where the cost is actually 5 to 6 times more than we treat in India, it seems that it is eventually cost effective after 10 to 15 years. And this also has to be borne in mind. With that, I'd like to thank our amazing leadership, but also the members of my neuro-oncology cancer management team, industry, care and clinical coordinators, all the research secretariat, national international colleagues, but most importantly, today to Dr. Ishwar Prem Sagar, our chairpersons, and all of you for your patient listening. Thank you very much.
Thank you, Dr. Jalali. I think we have a few questions for you. Dr. Prem Sagar.
Morning, Dr. Jalali.
Good morning.
Very much. It was very nice and our pleasure to listen to you. Your talk was very elucidating and very imparting to knowledge. Now there are many questions actually because of lack of time. I will ask only one question. One, we get lot many cases of sacral tumors, as you said, sacral chordomas, and you have shown one of the patient, and you said the proton has got very good results. Now, if the tumor is restricted below S2, this is easy to operate, but if it goes above, it is very difficult.
Yes.
So, I just wanted to know, what are the prognosis after proton therapy if it is involving whole of the sacral?
It's excellent, actually, particularly for chondrosarcomas more than chordomas. And not only our experience has been very encouraging, but also internationally, most of the people now think that, as you mentioned, above S2, you could just take a biopsy, confirm it is a chondrosarcoma, and treat directly with proton therapy and sometimes even with carbon therapy if you have. And the 5 year and even 7 year long-term local control and outcome exceeds 80 to 85%. And there is an international consensus building upon it. And there is also some improvement in the clinical profile, especially if it takes some time. It takes typically about 3 to 6 months for them to respond, both from neurological. Pain is a very important issue, as you know, and occasionally in bladder and bowel as well. So particularly for sacral chondrosarcomas, there is a uniform consensus that they don't need a surgical resection. They can be directly treated with proton therapy after biopsy.
But chordoma doesn't have that good
Chordoma
prognosis.
is not as good, of course,
Okay.
and that you have to be careful. Skull-based chordoma, I showed you the data, but also the C2 chordoma that we see sometimes is very difficult. There's a beautiful conjunction has to be done with the neurosurgical and skull-based surgery team. Also, to keep in mind that if you keep a cage or a metal, which we don't like in proton, and that close kind of a collaboration is very, very important for the success of your program.
Yeah, good morning, sir.
Morning.
It's a nice talk as usual. So only one question is that for vestibular schwannoma, why you have a protocol of like depending on size?
The reason is we can treat with very small size also, but I briefly mentioned. Interestingly, when you have a very small target, 4 millimeter, 5 millimeter, 8 millimeter, proton is actually worse than a cyber knife or a gamma knife or even a LINAC because of the lateral penumbra on the pencil beam. So therefore, we prefer a cyber knife treatment in those cases. But whenever the target volume is more than 10, 12 millimeters, then of course they are equal, but more than 15 millimeters, there is an exponential logarithmic superiority of IMPT over any form of photon.
Dr. Jalili,
Yes,
good
please.
morning. There's a question, two questions for you. One is, in pediatric patients, what is the youngest patient you have treated? And secondly, when we talk about pediatric tumors like medulloblastoma, ependymoma, vis-a-vis standard radiotherapy with craniospinal radiation, does the overall outcome or the progression-free outcome really change between proton beam and conventional radiotherapy?
Both very excellent questions. The youngest child we have treated is 9 months. It was a posterior fossa ependymoma. We wanted actually to wait till 1 year. As you know, the chemotherapy is not really very good in those cases. And it had EZIP actually. Both the ME3 loss was there, it was clearly at PFA. And we observed, but unfortunately the patient worsened. We had to reoperate and then we have to give the proton. This child is still doing very well after 2.5 years so far, but fingers crossed. But we have also treated 1.5, 2 years routinely now, less than 3 years of age, particularly PFAs and also the ATRTs and the ETMRs. These are the three indications. For other tumors, even in cranios, and sometimes we try to observe, of course, till 5 or 6 years of age. And low-grade gliomas, of course, we observe for quite some time. So that is one advantage. There is unequivocal, fantastic advantage in the quality of life, preservation of neurological function in all the childhood tumors, which everyone, there is no debate, which you accept. As far as the local control and survival is concerned, there is actually not too much difference, obviously, because the doses are same. Although in medulloblastomas, ATRT, ETMR, and also some of the ependymomas, there is a trend towards improved survival also. And primarily, it is because you are able to deliver the radiation early on. And some of the other cases, you delay them or you are not able to give the proper doses. Some of the medullos, group 3s, for example, they need carboplatin. And the conventional radiation is no way you can, it's very with a lot of difficulty. So because of the limitation of the normal tissue toxicity, you can actually push, and the timelines are maintained as per the protocols. The EURA protocol for ATRT is very intense with stem cell rescue, but with the proton therapy, you can do it beautifully. And therefore, if you look at, there's no randomized trial, of course, but if you look at the case control studies of the cooperative groups from the children's oncology group, Europe, and also whatever little data we have, there is a trend for improved survival also in these patients. And as far as the preservation of function is there, of course, there is no debate at all.
Thank you, Dr. Jalali. I think before concluding this session, the last question. There is no doubt about the role of protons in pediatrics as well as the malignancies you elucidated. My question is regarding metastatic brain lesions, especially now in the era of mutation positive lung cancers and the breast cancers where there's a long survival. So what do you see? What's the role of proton in these situations and as well as in multiple metastasis?
Sure. So we have not been so gung-ho about brain mets again, because I go clearly, this proton peer review process, actually for every patient of proton we treat, I have to say no to at least 4 of the patients, because there is a lot of, Dr. Deepak was also saying people come, there's a lot of hype also on it. And one of them is brain mets, because you can treat it very nicely with CyberKnife, Gamma Knife, or with a conventional LINAC. Why do you want to relatively expensive treatment? Having said that, about 3 years ago, we have modified our payment package of proton therapy for 3 to 5 fractions to only about 7 to 7.5 lakhs, which is not like 25 to 30 lakhs otherwise. So that has pushed some of the patients, and the only indications are post-op cavity, because post-op cavity is a nightmare for all the conventional radiation. Everyone knows. HER2 positive, because they tend to be more. TNBC is more difficult, but not the favorable lung and all that, as you mentioned, that we can observe or you can treat very nicely. So essentially, if they are largest tumors, well, I should say target, because it can be just a tumor bed cavity. Multiple metastasis, you could treat proton, but the conventional SRS you don't need. And the final indication for the last 1.5 years, we are now inundated with requests, is for leptomeningeal metastasis. The randomized trial from Memorial Sloan Kettering, which came into ASCO plenary, published in JCO. So we are actually analyzing the data of about 20, 25 patients, which we have already treated on LMD, primarily from breast, but also from lung, an odd case from kidney, from colon. And there is an advantage, but we don't give 1310 because they are toxic. I tend to give them 35 to 40 grade, slightly more gentler fractionation. We have to stop osimertinib in some of these cases, give only 80 milligram, not 160 milligrams. So we are working on the exact protocol, trying to fine tune what we have learned from the Sloan Kettering trial. So this is what I can say about the brain metastasis. LMD, of course, there's no doubt. The post-op cavities, multiple large, but you don't have to chase every single small met, which you can treat with conventional radiation.
Thank you, Dr. Jalali. Thanks for a nice presentation. So with this, I think we can conclude this session, sir.
Thank you, chairpersons, and I thank all the speakers. Once all, a very good morning. So I now hand over the stage to Dr. Kaviraj. He'll be moderating an interactive panel discussion on medulloblastoma.
Thank you, Dr. Anjali. Good morning, everyone. So I am Dr. Kaviraj. I am today here to moderate a panel. We will be discussing medulloblastoma cases in this panel discussion. And I'll be calling our panelists, Dr. Divyajyoti Mahakul, is an assistant professor in neurosurgery at GB Pant Hospital. Dr. Swati Mahajan, she is neuropathologist at Medanta Institute. Dr. Anjali Pahoja, our pediatric radiation oncologist. Dr. Rakesh Oberoi, our neuro radiologist from our same institute, and Dr. Payal Malhotra, our pediatric medical oncologist. Please have a seat. Thanks all the panelists for coming here. So our first case is a pediatric male patient, 3-year male. His dull aching occipital headache, which was radiating to neck with difficulty in vomiting, walking and vomiting for 1 month. So basically he presented to us with signs, symptoms of raised ICP and Vermean ataxia. There was no family history, no of cancers. Developmental milestones were appropriate for age. The patient was completely vaccinated. So, Dr. Divya, what is most common age group of medulloblastomas you encounter?
Basically, medulloblastomas have kind of a bimodal sort of distribution, with there's a kind of a typical case, a toddler, a boy child, and that's in the same age group, like 4 to 7, and then second peak occurs in around in the early part of the second decade, around uh, 12 to 15 kind of thing. That's kind of a bimodal distribution that we find in the pediatric age group.
So is there any difference with respect to age and different posterior fossa tumor presentations?
Yes, I mean, over here, the another differential would be ependymoma that I would think of. Then, since it's clinically it's a posterior fossa tumor, you can think of cerebral astrocytoma as well. But again, it's the age group a bit on the higher side. It's around 8, 9, 7, 8 kind of a thing. But patient at this age group, 3, 4, I'd go for medulloblastoma or ependymoma.
Okay. So here is the preoperative MRI reports. So Dr. Oberoi, sir, I'll ask you to just describe the radiology.
This is a T2-weighted sagittal, axial, and coronal images. It's showing a midline heterogeneous intensity tumor, which some of the cystic areas within, and pressure effect on the fourth ventricle.
So, sir, what are the classical features of medulloblastoma on MRI?
Medulloblastoma on MRI, classical features are their location in the child. They are usually midline position, or they can be lateral position. On T1, usually they have a iso or hypointense in signal. Even better, they are usually hypo or isointense in signal, and they have a very heterogeneous intensity on T2 in the value because of the cystic areas or hemorrhage. They shows a variable and heterogeneous enhancement. Only some of the tumor they shows a very less enhancement. On MRI spectroscopy, they may show say on MR diffusion, they show say restricted diffusion.
And sir, as there were some differential clinically, so how do we differentiate on the basis of radiology from other midline posterior fossa tumors of this age group?
Ectoblastoma usually on CT, they are usually hyperdense as compared to other tumors.
Okay.
While on MRI, they usually shows a restricted diffusion. And or MRI spectroscopy, they shows the increase in protein peak and decrease in the NAP.
Okay, sir. And so, with respect to brainstem, they arise from this. Do we have a clear plane from the brainstem or not in these patients? Sir, with respect to brainstem, can we predict the resectability? Do we find a clear plane in MRI findings? So again, patient was planned for surgery, and as we all know, that patient usually undergoes standard midline suboccipital craniotomy. Dr. Divya, so there are two approaches which are described: televelar approach versus transvermian approach. What is your take on these two?
Definitely, a televalent approach will be the first one. You need to use the natural corridor. Do not transgress the normal parenchyma. The transvermian has its own side effects in the post-op, mutism and all that, which actually affects the patient in the long run. So definitely, televalent approach would be the go-to. Plus, it's a favorable kind of. See, the SAS MRI, if you can go back to, it's I don't think it's a more of a kind of a bad slope over there, and you can definitely go through the televelar one.
Very good. And Dr. Divya, what since it's a pediatric age group, what are the specific restraints in pediatric age group? When do we operate these large tumors in pediatric age group?
Specific restraints?
Yes, like blood loss and all.
Definitely. Blood loss, since these are mostly vascular tumors, blood loss is one of the things that you need to take into account. But unlike other pediatric tumors like the choroid plexus tumors and all, plus the interventricular meningiomas, where at times I go for a pre-op embolization. Once I find some kind of flow voids in the MRI, pre-op MRI, I do go for embolization with some liquid embolic agents like NBCA. But medulloblastoma has its supply from pica, but they're not high enough that you need to have, you find those flow voids that need to be embolized pre-op. But again, other surgical techniques, so the hemostasis needs to be taken care of while operating such patients.
Okay. And is there any experience regarding embolization of these this kind of patients? Your personal
No,
experience?
not for medulloblastoma actually. I have embolized couple of patients for choroid plexus tumors.
Yeah.
But again, one criteria is you need to have those flow voids over there, plus interventricular meningiomas as well. But no, not in case of medulloblastoma yet.
Even we don't see any studies for embolization of such
not
tumor
yet.
because they are likely intra-axial.
Actually, there's a big vessel that supplies pica is a big vessel, but the tumor feeders are actually the size of the feeders are mostly less than 1 mm. It's very difficult to take the microcatheter and go up to that and selectively embolize those feeders over there.
Dr. Divya, there was hydrocephalus also with this patient. His main presentation was due to raised ICP secondary to hydrocephalus. So what is the standard guideline for tackling hydrocephalus in such patients?
This patient was conscious oriented. So definitely I'll make every possible attempt to avoid shunt for this patient. I'll start with the decongestants, take up the patient, interop. I'll go for a ventricular drain and keep the ventricular drain. Basically in intraoperative, if I can find the fourth ventricle, the inlet and outlet, I can see the aqueduct, CSF trickling down, and you can see going through the outlet. Then I'll definitely give a chance to avoid ventricular peritoneal shunt, keep the EVD in the post-op for around 5 days and see how the patient behaves. And if it doesn't still requires, then I'll convert it into a shunt. Otherwise, I'm better off removing the.
So you will take the consent on pre-op only, and you will decide it intraoperatively whether this patient will go for shunt or not, depending on the extent of resection.
Specifically for this sort of patients who are conscious oriented at time of presentation.
Okay. So here's the post-op CT. We again put the shunt intraoperatively, and same time resection was done. So this is the histopathology report which we got from the pathology department. I think Dr. Swati can explain it more. Yes, yes.
So these are the photomicrographs. The first micrograph shows like a tumor, very cellular tumor. It is a bluish looking tumor. And the second photograph on the right, we can see like the the cells are small round blue cells tumor arranged in form of fascicles, sweeping fascicles, and they have moderate eosinophilic cytoplasm, and they have a high NC ratio. In the third photograph, we can see that there are some rosette formation also, and these tumors generally have I can't see in this photograph, but they generally have increased mitotic activity and the apoptotic bodies. So this look like a small round blood cell tumor, like an embryonal looking tumor. The next slide.
So it's IHC markers.
These are the immunohistochemistry markers, and first the to identify the lineage of the tumors, we do the synaptophysin, which shows that it is a neuroectodermal tumor, and further the beta catenin, GAB, and YAP are generally the tumors which help to identify which molecular subgroup this tumor belongs. Beta catenin is negative; it has a membranous positive. Beta catenin nuclear positivity is considered the a positive tumor. Here it is a beta catenin is negative. GAB and YAP1 are also negative. Negative. P53 also wild type, as we can't see any nuclear positivity. Ki67 is very high, greater than 80%. Beta catenin is positive in Wnt activated tumors, whereas GAB and YAP are associated with SHH activated group tumors. Here all the three are negative, so the classification will be, the histomorphology was as of a classical medulloblastoma, and the molecular classification will be non-Wnt, non-SHH group tumors.
So you are talking about the classification, ma'am.
Yeah.
So there are two classifications, what we
Yeah.
know. One is histopathological based
Histopathological.
classification. Will you be explaining these classifications?
Yeah. As the histological classification, the morphological groups are four groups mainly. One is a classical type, which is the most common morphology which we see on histopathology, and they generally belong to all the groups, predominantly non-Wnt, non-SHH groups, and the Wnt associated groups. Other is a desmoplastic nodular medulloblastomas. They generally belong to the SHH activated groups, and the medulloblastoma with extensive nodularity also belong to the SHH activated groups. Whereas a large cell medulloblastoma, these are associated with SHH activated groups, which are P53 mutant type, and they're generally associated with a very bad prognosis. Large cell and anaplastic medulloblastomas generally considered together, and they're rare but very bad prognosis.
So depending on this classification, large cell anaplastic, very bad prognosis.
Yeah.
And classical,
They're okay, like normal.
average risk.
Average.
Yeah.
The best is that of the desmoplastic
Desmoplastic with nodular.
medulloblast.
And again, molecular defined, we define the medulloblastomas on basis of this IHC marker.
Yes, sir.
Will you be explaining that also, ma'am?
Wnt activated medulloblastoma, there are four molecular groups: Wnt activated, SHH activated, P53 mutant, and P53 wild type. And medulloblastoma, non-Wnt, non-SHH group. They are further divided into group 3 and group 4. Wnt activated medulloblastoma is associated with activation of wingless pathway. And on immunohistochemistry, we generally see beta catenin nuclear positivity in these tumors. SHH activated group are associated with GAB1 and YAP1 positivity, and they associated with that SHH sonic hedgehog pathway activation, and they can be further divided depending on the P53 mutation or wild type. P53 mutant are generally with the worst prognosis. And in these, the third and the fourth category, non-Wnt, non-SHH, they are associated with MYC amplification, MYC or MYC amplification, and they generally, the role of other pathways are not that much like we know about that other genetic alteration in these pathways.
So, ma'am, you have already explained the significance of this histopathology and molecular basis. Dr. Payal, I would like to ask you, why are these IHC markers are necessary for you to decide about the patient treatment protocol?
Okay. So first, I would also like to put one more point. I think you had put a point about NGS as well. Usually, when you want to know the molecular subtype, the ideal way is to send an NGS. But all of us know we have NGS in-house at RGCI. However, we know that it costs a bomb. So usually in India, we are struggling with finances, whether to tell the patient chemo le lo, itne mahine chalegi. So in that, it is sometimes difficult to have the molecular subtype, but it is very, very important to prognosticate in today's era, to risk stratify and also to decide the treatment. So in our lab, we have IHC markers, which are surrogate to Wnt. So for Wnt, we have beta catenin. For SHH, we have YAB and CAB. And if both are negative, then we can't say whether this is group 3 or group 4, but likely it is group 3 or group 4. Group 3 have got the worst prognosis. They are associated with NMIC amplification. SHH and group 4 are intermediate. So this is how we can know. They are just surrogate markers, but we are not really testing for any molecular classification. So IHC markers are necessary as surrogate to your molecular subtyping. This is what we are doing at our institute as well.
Ma'am, again, she was talking about NGS. So will you be explaining how do we go for with NGS? What are the other markers and other information we can take out from NGS?
NGS is routinely not done like in most of the institution. It is generally in the research purposes we do the NGS. NGS and specifically DNA methylation analysis, which has come in recent years, they help in subgrouping these medulloblastomas further. Previously, we just know the 4 major groups. Now, DNA methylation and the transcriptome analysis has helped in further classifying these 4 groups, 4 groups into further subgroups. Like Wnt has further 2 groups, SHH has 4 subgroups, and medulloblastoma non-Wnt and non-SHH has further 8 groups. And these further groups, DNA methylation and genetic analysis has shown that they have separate clinico-pathological and prognostic implications. Like in the non-Wnt, non-SHH, there are 8 groups, and among those 8 groups, it has been found that group 3 has a worse prognosis, and the subgroup 7 has a best prognosis. So NGS help us in diagnosing the genetic alterations, which are the basic levels, and they can guide us into the further clinical trials and the precision risk-based stratification of the patients and the therapy which we can further be done. But these are generally done at the research purposes, not the routine level. We can do just, as ma'am said, because of the
Financial issues.
restrictions.
Okay.
I just wanted to add on that, as Dr. Swati correctly pointed out about getting subgrouping, methylation, hypermethylation patterns can also help us to decide further therapy. There are demethylating agents and hypermethylating agents. Being in research, they have phase 3 trials. There are studies published for having molecular targeted therapy in these patients. And more so, once we say that group 3 is the worst, but you have a subgroup which is not worse. So you'll be able to further dissect out good players amongst the bad players. Yeah.
That's great.
And in fact, IHC markers or molecular subgrouping is guiding radiation oncologists also now. Earlier, we had a standard protocol, dose volumes and doses were based on standard risk, high risk. But we know that the Wnt activated medulloblastomas have a role of de-escalation.
Yes.
Similarly, there's data coming up that probably medulloblastomas which are TP53 mutant, SHH activated, and the NMIC amplified medulloblastomas may require dose escalation.
Escalations.
So
Okay.
it's important for us also.
Sir, Oberoi sir, just I wanted to know, can we predict these molecular subtypes depending on pre-op MRI findings?
We can predict the molecular subtypes on the pre-op MRI findings because of their locations and MRI features. On the locations, the W and T type are mostly located in the cerebral peduncle or sepingles, and SSH activators are usually located in the cerebral hemispheres, while group 3 and 4, they are usually in the midline. And other is their margins. Group 3 and 4 usually they have a ill-defined margins, and other is the enhancement pattern. The group 4 patient types usually shows a very less or no enhancement. can be differentiated from the group 3.
Group 3.
And another is the MR spectroscopy, which also help to differentiate between group 3 and 4. MR spectroscopy is also typical taurine and creatine peak, which can differentiate between group 3 and 4. And if the hemorrhage is predominant, it is more commonly seen in the type.
That's great, sir.
So there was a paper also which I saw that MRI feature that are helpful tool to predict the molecular subgroups in medulloblastoma. Let's come to post-op management. Dr. Payal, now after the surgery part is over and patient had underwent gross total resection, a patient comes to you. So how do you stratify the risk in these patients? How do you classify these patients on basis of risk?
So for risk stratification, first I need to stage my patient. Usually when these patients, they come to us, they have an MRI brain and they are operated, and usually a post-op CT, which is done as a part of protocol. But for staging, we need to have an MRI spine as well.
Yes.
Then we also need the MRI head to know the extent of resection which was done, whether it was a decompression, debulking surgery, or whether it was a GTR, NTR, or whatever was done. So for staging, what we used is the modified Chang staging, which primarily depends on the extent of the disease and extent of METs. Extent of the disease, I will not go into theoretical classification just for understanding. If it's T1, T2, T3, T4, T3 is further divided into T3A, T3B. T1 is basically less than 3, T2 is more than 3. T3 is if it reaches the foramen of Luschka or aqueduct of Sylvius. If it bypasses aqueduct of Sylvius or comes down through foramen magnum, it becomes T4. Now coming to METs, extent of METs. I would like to say that extent of disease is not as important for prognostication or risk stratification as much as the extent of METs. Whether it is T1, T2 or T3, it is important or imperative that the neurosurgeon is able to do a safe maximal resection. However, if the patient is metastatic, it makes the patient upfront high risk. So for METs, they have divided it as M0, M1, M2, M3 and M4. M0, we understand there is no METs. M1 is if you have microscopic METs. How do you see that? You do a CSF analysis. So if this patient comes to me, I will do an MRI brain to look at the extent of surgery, MRI spine to look at spinal METs, and a CSF analysis. If there is microscopic evidence, it becomes M1. M2, if it is the subarachnoid, cerebral subarachnoid space, it shows METs. If the spinal subarachnoid space shows METs, it's M3. M4 is extraneural. Extraneural is more so theoretical. Usually, especially in pediatric population, we don't see extraneural. Extraneural is defined as METs to bone, bone marrow. We don't even do that as a part of routine staging workup. For risk stratification, there are 3 important parameters which were used as a contemporary risk stratification. Now what is added is molecular subtyping, and I will not repeat it because we have discussed that in detail. The other 3 parameters which still hold its importance despite the molecular classification are: first, the age of the patient. If the patient is less than 3-year-old, no matter whatever are the other parameters, this patient is high risk. Primarily so because in less than 3, the radiation oncologist will not be able to deliver radiation. Second is if the surgery was suboptimal, which is described as if the tumor is after the surgery is more than 1.5 per millimeter cube. Third is presence of METs. So if METs are present, whatever is the age, whatever is the surgery, this patient becomes high risk. However, having said that about less than 3-year and radiation, things are changing right now. We know in ependymoma, we radiate the patient even if the child is more than 18 months. And even in medulloblastoma, we wait for the child to become 3 years and irradiate. But primarily these 3 parameters and definitely molecular subtyping, which has come in a big way for risk stratification.
Okay.
To add to what she said, actually, one of the important things for risk stratification is the extent of resection. Ideally, you should go for a GTR or near total excision. At the parameter, the threshold that has been described is actually 1.5 centimeter cm square. we take the axial scans and the maximum the axial scan section at which there is maximum tumor that is left, find out that area that has been associated statistically associated with the prognosis, not the volumetric or any single dimension. That's the
Yes.
one thing.
And another point, like sir added, is when do you do that MRI? So you don't like to do it within first 48 hours or 72 hours. You know, post surgery there is going to be edema and inflammation, and you may falsely estimate that tumor resection ठीक से नहीं हुआ है. It is more than 1.5 centimeter cube. So actually there has to be a definitive time limit when do you perform that MRI. And also for CSF examination, you wait till 2 weeks from the surgery. Why? Because when you do surgery, the debris, the blood will be there in the CSF, and you're going to falsely estimate or underestimate the CSF analysis. So wait for 2 weeks from surgery to do a CSF analysis.
To add to that, actually, the protocol that we follow is we need to do a contrast MRI within 48 hours. After that, there are actually surgical changes that might mimic residual.
Yes.
And second thing, because of the contamination, we need to wait for a lumbar puncture for around 14 to 21 days for all the contamination to settle, and then we can and that should have around 10 cells probably to make it positive.
Yes, a positive. So, ma'am,
For both of them, for both the surgeon and the medical oncologist, we prefer that the post-op MRI should be done in radiotherapy planning position.
I agree.
Because
what we are-
because
I was
for
coming to
us
you.
it is the post-op MRI that we register with our planning CT. So at least the MRI of the brain has to be done in our radiotherapy planning position, which is just that the neck has to be kept neutral.
Okay.
And we prefer 2 mm or 1 mm cuts from vertex to at least the C4, C5 vertebra. Usually the protocol is till C2.
Okay.
I think this point is very important because these kids are going to require GA. A 3-year-old is not going to lie and get an MRI done. So we can't get a repeat MRI done. So always take in consideration the radiation oncologist while you do. Last point, sir.
Yes.
The CSF analysis, there is a lot of debate about whether you do a spinal CSF या फिर surgery के दौरान if they make an omaya, they may do a CSF analysis. So studies have shown that spinal CSF has got the highest sensitivity. However, if somebody does a ventricular CSF analysis, is not something which is wrong.
Great. So we did post-op MRI, spinal MRI, and Dr. Payal, you were talking about these drop mets. So there are other tumors which may cause spinal drop mets. Can you explain those tumors also?
Yeah, so one is ependymoma. Medulloblastoma per se can cause spinal mets. That's why you do an MRI spine. Other is ependymoma. Then there are high-grade gliomas. These are, I think, the commonest in pediatric age group, which may be associated with drop mets in the spine.
ATRT.
ATRT as well. But
Yes,
since
yes.
it's rare, so I didn't mention that. Yeah.
We have already discussed about the timings of MRI and CSF. Dr. Anjali, I'm coming to you regarding radiotherapy. So what are the concerns of radiation therapy in these particular pediatric age group? What is the minimum age criteria you have given radiation in medulloblastoma? And what are different modalities you use for radiation?
For us now, the age criteria that we follow is at least in high-risk patients. We don't wait till the child is 3 years of age.
Okay.
Up to, I mean, a child more than 12 months of age in the high-risk criteria can be taken up for post-op radiotherapy, even in medulloblastomas. For standard risk patients, if the child is less than 3 years old, yes, maybe we can wait till the child turns 3 years of age. Then different modalities, the best modality of date is of course proton therapy. Then what we are using here is helical tomotherapy, with which our dosimetry, that is the hot spots and the cold spots that we are able to prevent in the field of radiotherapy is much better optimized than our conventional radiotherapy techniques. Ideal time for, usually the child comes to us around 3 weeks post surgery.
Yeah.
So once the metastatic workup is complete, we just do some patient-centric investigations before we take him up for radiotherapy. One is a baseline audiometry, two, a baseline neurocognitive assessment, and endocrine profile,
Yes.
especially the thyroid
Thyroid and-
profile. Yeah. Dose adjustments are mainly based on, as of now, based on standard and high risk category.
Categories.
For the total dose in both the categories, as of now, remains to be 54 grays. But of this 54 gray, 23.6 gray is given to the CSI, craniospinal axis, in standard risk. But if it is a high risk category, then we go up to 36 grays to the CSI. And there is a difference in the volume of the tumor bed irradiated. If it is standard risk, we treat only the tumor bed with some margin. If it is a high risk category, we treat the entire posterior fossa.
Great. So, and now there is time constraints.
Just one question. Once you de-escalate the radiation therapy, do you go for concomitant platinum-based chemos, or is just a pure de-escalation of craniospinal radiation? From 36 to 24, when you drop down, do you add platinum-based chemos?
Concurrent chemoradiotherapy, that is 23.6 gray to the CSI, followed by boost to the tumor bed only, and we are supposed to give concurrent vincristine. So when we were using the conventional techniques of planning CSI, we used to experience so much pancytopenia and interruption of treatment that largely we had given up on giving concurrent chemo. But now we are encouraging our colleagues to start
the
giving concurrent regime, because that is the standard protocol.
So coming on to you, Dr. Payal. In short, what are our institutional protocols we do follow at RGCI for these patients?
So I'm not going to available options. I think in interest of time, what we are using is the POG 9031 protocol. This uses a total of 35-week treatment. It has an induction chemotherapy, and it uses four main drugs. One is cisplatin etoposide, 3 cycles, 21 days, and then 7 cycles of consolidation, which are vincristine and cyclophosphamide. So a total of 10 cycles over 35 weeks, vincristine and cyclophosphamide 4 weekly, and cisplatin etoposide 3 weekly. Cisplatin, the cumulative dose is 90 per meter square, etoposide 150, and for vincristine it is 2 per meter square, and cyclophosphamide 1 gram per meter square. So this is what we are using at our institute. Just to mention one thing, when POG 9031 protocol was introduced, they actually did it for high risk medulloblastomas, and what they tried was to give the induction chemotherapy, that was vincristine, cisplatin etoposide pre-RT, and then after RT give the consolidation. Then they also, the other arm received the entire 10 cycles after radiation. And what they saw was that there was no difference whether you give chemotherapy before the radiation, that is the induction, and give consolidation after radiation, or you give the entire course of chemo after radiation. The only rationale for giving it pre-RT was that when you do surgery, the structures are vascular, the blood-brain barrier is weak, there is inflammation, so probably the chemo will penetrate the brain better. That is why they thought that probably giving after surgery the induction, then giving radiation and then consolidating will be a great idea. But there was no difference in EFS, and so we also follow to finish the radiation and then give the complete course of chemotherapy.
So I think time is really a constraint. I'm just being told that we have already exceeded the time. There is a lot to discuss about the post-op follow-up and in recurrence of these tumors, and about the prognostication and long-term outcomes. But I think we should end up our discussion over here. I will ask the audience if they have some specific questions. They can definitely ask our panelists.
All is clear.
Are you talking about the verification CBCT? Because we don't need a CT otherwise. We just need one CT.
I'm just asking in as a general, how many CT scan if a child
We don't need a
Medulloblast-
C. We don't
Sir
need
is
a
asking
C.
that how much radiation sometimes
radiation dose after your recommended protocol of all the
Radio-
All the
medulloblastoma
treatment is
treatment is
come.
being over.
Okay.
What do you
Sir,
say to attendant
sir,
or the patient parents that what they precaution, how much radiation dose they can give through CT scan if that child need in future?
sir, I'll take this question. So we are not doing CTs. We do MRI. And
No.
MRI.
Ma'am, I'm not asking. If patient get if your child that patient get a fall from bed.
Okay, in general. Okay.
In general, I'm
Okay.
asking.
And
In
not in the case of
general,
Basically,
medulloblastoma.
what I felt, I know normally deal in trauma. What I found very interesting in our society, particularly in India, that CT scan, you can go directly to lab and say that I want a CT scan and that fellow will do it. Without thinking that it may call radiation or whatsoever.
no, here I think it is more about the benefit of getting an investigation done over probable late effects. So if in a case of a fresh trauma, if CT is the necessity of the time, we don't think about probability of second malignancy that may happen 10, 25 years later. So it is very difficult to quantify as to how many CTs are required. As a radiation oncologist also, when a pediatric patient is referred to us, our first question we ask ourselves is, do we really need to irradiate this child? Does the child really require radiotherapy, or can we omit radiotherapy altogether? That is the first question we address. In a given case, if radiotherapy is an essential part of treatment, it has to be done. Similarly, as a child grows in a childhood survivor, if a CT for any condition, any problem in life is required, it's a necessary, it has to be done. There is no limit to the number of
No, no.
CTs that can be done.
I just want to emphasize on the thing that we as a society, being poor, we think of preventing the things. How to, I'm not going to cure part. I'm just taking it a broad spectrum of prevention.
So, what, sir, I got your point. Probably your message is if we can avoid CT scans during investigations.
Unnecessary required CT scan.
Yes.
And I just want to emphasize one more thing. You can guide your patient's relative also ultrasound. If we have hole
Open
in
fontanelle.
brain, hole in brain means you have done craniotomy or whatever to remove this thing. By ultrasound probe, you can also take get an image of brain if there is a.
Definitely, sir. Sir, your point is well taken that in general community, we should spread this message that radiations are really an important concern for pediatric age group, and if necessary, we should avoid it. Thank you, sir. Thank you all the panelists. Thank you.
Thank you, Dr. Kaviraj, and I thank all my co-panelists. Before we move on to the academic sessions, I invite all of you to join us for the inaugural ceremony for this program. Let's invoke the blessings of Lord Ganesha before we move on. I invite our graceful sister Megha to perform the Ganesh Vandana.
गणनायकाय गणदैवताय गणाध्यक्षाय धीमहि गुणशरीराय गुणमण्डिताय गुणेशानाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि सर्वराजाय गन्धाय सर्वगानश्रवणप्रणयिने
गाढानुरागाय ग्रन्थाय गीताय ग्रन्थार्थतत्त्वविदे
गुणवते गणपतये ग्रन्थगीताय ग्रन्थगेयाय ग्रन्थान्तरात्मने गीतलीनाय गीताश्रयाय गीतवाद्यपटवे गेयचरिताय गायकवराय गन्धर्वप्रियकृते गायकाधीन विग्रहाय गङ्गाजलप्रणयवते गौरीस्तनन्दनाय गौरीहृदयनन्दनाय गौरभानुसुताय गौरीगणेश्वराय गौरीप्रणयाय गौरीप्रवणाय गौरभावाय धीमहि गोसहस्राय गोवर्धनाय गोपगोपाय धीमहि गुणातीताय गुणाधीशाय गुणप्रविष्टाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि एकदन्ताय वक्रतुण्डाय गौरीतनयाय धीमहि गजेशानाय भालचन्द्राय श्रीगणेशाय धीमहि
Thank you, Megha sister, and may Lord Ganapati bless us with success, wisdom, knowledge, and new beginnings. May I please invite our dignitaries, our CEO sir, Mr. D.S. Negi, Dr. A.K. Diwan sir, Director, Surgical Oncology, Dr. Prem Sagar, and Dr. Prakash Singh, our guest of honor for today. He is a unit head of neurosurgery at Max Super Speciality Hospital, Delhi. And our chief guest, Dr. V.S. Mehta, is the chairman, Department of Neurosurgery at Paras Health, Gurugram, to please light the auspicious lamp. Dr. Archana is here. No, please. PPT study.
Photography. Oh,
Thank you. And with everybody's blessings, we move with the next session of the program. Every field in oncology has been witnessing advancements in diagnostics and management for improving patient care and outcomes. To update ourselves in the domain of glioma surgeries, let's listen to some eminent speakers in our next session, chaired by Dr. Dipankar Singh, neurosurgeon at Vardhaman Mahavir Medical College and Safdarjung Hospital, Delhi, and Dr. Subodh Gupta. Dr. Dipankar and Dr. Subodh Gupta.
+2, 13. Time please. 20.
Good morning. This session is on recent advancement in glioma surgery. And the first speaker is Dr. BP Singh. He is speaking on awake rhinotomy for lesion of eloquent areas. Time allocated is 13 minutes and 2 minutes for discussion. Please.
Thank you, chairpersons. Friends, it's a pleasure to be here in Rajiv Gandhi Cancer Institute. I'm going to be talking about awake craniotomy. Now, when we talk about gliomas, there is a onco-functional balance that we have to consider. The oncological perspective is take out the whole tumor if possible. The functional part is that in the brain, we need to preserve function so that we don't have a patient who doesn't have a tumor but can't move. So that's where we have to work on. And one of the there are various techniques to achieve the functional aspects of the patient. One, of course, is intraoperative neuromonitoring. The second is awake craniotomy, a low-tech technique. And the third is a combination of the two. So awake craniotomy has been done for many years. Like in the ancient Peru, obviously they didn't have anesthesia. They would trepanate the skull. Sushruta is known as description of the awake craniotomy. So in the Middle Ages, and this is the modern awake craniotomy. So the rationale is, it sounds very gruesome that you can operate the brain tumor without anesthesia. But the whole concept is based on one basic anatomical fact. The brain itself has no pain receptors or pain endings. So all the pain nerves go to the brain, which perceives and localizes somatic and visceral pain right down to the minutest detail. But itself, it is not pain sensitive. So you have the scalp, which has the nerve endings. The periosteum of the bone is pain sensitive. And when you come to the dura, only the basal dura has pain receptors, and that too are stretch receptors. Intracranially, there is no pain except the large blood vessels at the base of the skull. So what do? We anesthetize the scalp nerves with long-acting anesthetic agents like bupivacaine, give short-acting intraoperative sedation, propofol. The moment you turn it off, after a few seconds, the patient wakes up. Intraoperative good analgesia, fentanyl. You sedate the patient when you're doing the craniotomy. Then make him wake up when you're doing the actual tumor removal and during closure against sedated. So dexmedetomidine is a good agent which is now available in India, which you can use. So it's what is called arousable sedation. And these are the various nerves which you have to block. They're not difficult to do. You can easily do it, and you can do the surgery. So this we've already talked about. You want to remove the tumor completely, but you want to preserve function. And as neurosurgeons, you're always worried when the patient wakes up, will he move his arms, will he speak, or will he not do it? So that is always the conundrum and the dilemma in the surgeon's mind, how much to do, when to stop. You want to remove more tumor, but you also want to preserve function. Now, when you open up, we've got big advances in radiology, but when you translate them in the operation theater, it doesn't really happen. The localization, we do have the neuronavigation, which actually predicts exactly where you are, and you can go directly to the tumor. But the motor cortex and the speech cortex on visual examination, even under the microscope, look exactly the same. So you need monitoring. And intraoperative neuromonitoring can give you monitoring for the motor pathways. For speech, we still don't have good monitoring under anesthesia. So when there's a tumor near the eloquent area, motor area, speech area, then you need this awake craniotomy. Contraindications, a patient who's not cooperative, a hyper-anxious patient, patients with low pain threshold, and very young children. Having said that, I've operated 15-year-olds also under awake anesthesia. The important thing is to gain the confidence of the patient. He has to be convinced that you will not harm him. He has to be convinced that, he has to have faith in you. You have to build that relationship with the patient that you'll be able to do it and he won't be uncomfortable. So patients who cannot follow your command because of altered sensorium or speech disturbances, obviously we can't do it. So we have to counsel the patients very well because the anxiety of pain causes more problems than the pain itself. So we give the local anesthesia. The patient should lie down comfortably. The draping is extremely important. If you drape the patient fully and the head is covered, he cannot see outside, he's going to panic. So you have to drape it so that his vision is not obstructed. and keep talking to the patient. And so that the patient is relaxed and engaged. And here the value of a good talkative anesthetist is paramount. You know, if the anesthetist is talkative, talking to the patient all the time, they relax the patient. Some pitfalls during the bone opening, the craniotome makes a big noise. So counsel them beforehand. You will feel us doing something, you will hear sounds, but it won't be painful. The craniotome also generates local heat, which can be uncomfortable. So keep irrigating the bone. And you can stimulate the cortical surface with a low dose current to see if it's a motor or speech area. We do use navigation in these cases. The classical navigation you cannot use, but the axiom, where it's electromagnetic radiation navigation, that works very well. So you stimulate the cortical surface, make sure it's not eloquent, incise the cortex, and start tumor decompression. The anesthetist should continuously keep checking the movements of the face, arm, and leg in speech, and stop at the first sign of a mind deficit. Then wait for it to recover. Often it's because of manipulation, and then it settles down. But if you're constantly getting deficit in a particular area, leave that area and move ahead. The negative thing about awake craniotomy is that you have to sometimes leave tumor behind. As a surgeon, we often get upset if the patient moves. We shout at the anesthetist. So here you have to anticipate movements. No patient can lie down in the same position without moving for 2 hours or so, 1.5 to 2 hours. So you anticipate movement. The moment the patient makes a slight movement, don't shout, don't irritate, or don't speak firmly to him. Just withdraw your instruments, let him settle down, and then redo the surgery. And always keep boosting the confidence of the patient by saying how good he's doing and how, patient is very good. And always remember, the patient is awake. Do not discuss what you did in the party last night in front of the patient. So just to show you a few cases, 29-year-old had focal seizures in the face for 2 years. He was operated earlier. Only a biopsy was done because the tumor was in a speech area. Biopsy was a grade 2. And now he was followed up, and there was an increase in size of the lesion. This was the lesion right in the speech area. And they had done this tiny biopsy, you can see. Just a bit of biopsy was done for fear of causing deficit. But now the tumor had started increasing, and we didn't have any option but to do the craniotomy. We did it awake. During surgery, twice he had difficulty in speech. We stopped and resumed after he recovered, and the post-operative scan was good. It was a grade 2, and we followed him up. He's about 4 or 5 years now. Patient is still doing well. No tumor seen on the MRI. Another patient with a 6-month history of right lower limb focal seizures. The patient was intact, and this is a lesion near the midline, right in front of the motor cortex. So we did a wake craniotomy. The patient sometimes have seizures during the surgery, and that's a very worrying thing, because if it's a generalized seizure or if there's a major seizure, then they become confused and disoriented and do not recover, and you cannot proceed with the wake craniotomy. But always have ice cold saline handy with your nurse. And if there is a seizure, a direct application of very cold water saline directly on the brain surface can abort the seizure. So luckily, this patient did have his sensorium improved, and we were able to monitor, and we were able to do it. And that was the tumor, which was excised. Another case, a tumor right in the Broca's area in the frontal. Those are the scans. You can see it, and it's on the left side. And these are the scans after surgery. A good excision has been done. There may be some tumor on the posterior part, but a majority of the tumor was taken out. Let me see if the video works. Anyway. So another patient with an insular tumor, a tumor near the motor cortex on the non-dominant side. And that's the tumor. So again, we did it awake. And before doing that, we done the functional MRI for the motor strip. We had the tractography. It was just adjacent to the posterior margin of the tumor. And we did this tumor. This is the immediate surgery. The top part of the tumor has been taken out. The lower part, which may be partly edema, was still there. We were getting problems on taking that out. And this is a follow-up scan after 3 months. And you can see once the edema has settled, practically all of the tumor has been taken out. There may be some edema and some tumor here in the lower portion, but the patient is doing well, was subjected to radiation. So this is how we do it. The patient's face is exposed. He can look outside. We don't cover the face. And during the surgery, the anesthetist is talking to him, checking his power and following commands. And we are able to do these things safely. The negative part is that you will be leaving some tumor behind in certain cases, but that was the whole perspective, the reason for doing it. You wanted to preserve function. Thank you for your attention.
Thank you, Dr. VP Singh. Any question?
I think it's the demand of the day that to avoid the functionality deterioration. But sometimes in patients who have a benign lesion and a malignant lesion, I think I would little differ or I have a different approach. If it is a benign lesion, which are extracerebral, even if there is a little bit of deficit, I would try to remove it completely because they're likely to improve the deficit over a period of time.
Extracerebral or intracerebral?
Extracerebral, like
That,
cavernoma,
of course, you won't do this.
meningioma.
Absolutely.
That is what I'm doing.
100% agree with you. I think this what I was talking was for intraaxial tumors.
I'm saying if you are doing an awake craniotomy for extra.
No, we don't do it for that at all. Because there you have,
For cavernoma, why not? Meningioma, why not?
Meningioma, yes, because it's an.
For cavernoma?
No, for meningioma, I won't do it because it's an extracerebral lesion. And therefore, the chances of causing damage.
No, if suppose right on the motor area.
Right.
Right on the speech area.
Right.
Then
so because the pine plane is intact in those cases. And
still,
therefore,
sometimes
with
you
good
do develop
surgical
some
technique,
deficit.
You may have deficit, but they will recover.
Yeah,
as long as
that
the
is exactly
surgical
what I'm
technique
saying.
is good.
If you are
I mean, you
doing-
of course are an excellent surgeon.
If you are doing because in one of the conference I remember a person who was doing a cavernoma and awake craniotomy, and because he developed deficit, he left the cavernoma, and that deficit will never improve. Never improve.
Right. So
unless you remove that.
So my thing is that I would not consider awake craniotomy in an extracerebral lesion. I mean, that's what I follow.
Any more question? Now we think.
Thank you.
Excellent talk, sir. So now we shall call upon Professor Sharat Chandra from AIMS. His talk will be on surgical management of pineal tumors.
Good morning, everybody. It's a great pleasure to be here, especially in front of my mentors and teachers, Professor Mehta. Apologies, we had to do some rescheduling because I had to go out of station and I had to catch a flight. And thank you very much for the organizing committee for having adjusted me. So, yeah, I'll do it. I'll do it. So I will be speaking about pineal region tumors. It's indeed a challenge to complete the entire spectrum of pineal tumors within a period of 13 minutes. So I thought I will just show you two videos and briefly speak about pineal tumors, particularly about the surgical strategies and the philosophy behind surgical strategies. So when we look at pineal tumor, we have something which is a big dissuadance for us to approach this area, which is the vein of Galen, because if you damage it, patient will end up having a central venous infarction, which is terrible. Patient is never going to recover from his consciousness. So the entire approaches are based on whether you would go superior to the vein of Galen or inferior to the vein of Galen. And that is what has to be determined on MRI. Now, most of the pineal region is supplied by the PCA. A little small portion is by the SCA, superior cerebellar artery, to the inferior colliculus. But we have to understand that most of the supply is from the posterior cerebral artery. What is important are the veins. So when anybody who has done a pineal tumor surgery, the first thing which he or she would see, which stares at his or her face, is a large vein of Galen, and that is what has to be preserved when we do the tumor. So commonly it could be the germ cell tumors, you could have pineal cell tumors, and you could also have extra lesions, extra pineal tumors. And pineal tumors clinically do have a unique way of presentation, and that's the reason I put up this chart. And my apologies if the chart looks a bit cluttered. But as you can see, a majority of the pineal tumors occur in kids, children. There seems to be a slightly male preponderance, especially for germinomas and teratomas. Now, most of the pineal tumors are homogeneous, except perhaps germinoma and teratomas, which have hematomas, so they could look heterogeneous, and this could be easily made out clinically. And germinomas have a brilliant enhancement. So there's something called as an ectopic germinoma. So you could have a germinoma in the posterior third ventricular area and also within the pituitary, and it becomes diagnostic. So the triad of presentation of germinoma is particularly in team between the first and second decade, brilliantly enhancing. There could be a lesion in the pituitary, and they are supposed to present more with diabetes insipidus. Again, calcification is very common, particularly if you consider the more benign varieties of tumors. Edema is not very uncommon, but can happen with malignant tumors like germinomas. And METs can also happen. The enhancement particularly is of very important because that changes the strategy. Because if you think of a germinoma, then you don't think of a radical excision. You like to get a biopsy and then subject because they're supposed to melt with chemo and radiotherapy. Now, CSF markers are again very important in pineal tumors. So you could have increased beta HCG, particularly very high in choriocarcinomas. And then alpha fetoprotein, of course, we know that it is increased again in yolk sac tumors. So if you can get a CSF analysis and a biopsy, particularly if you think germinoma, that is the first strategy by which we would avoid any kind of a major surgery. Now, endoscopic third ventriculostomy has definitely become a very important armamentarium in surgeons, because you not only can you decompress the hydrocephalus, but you could take a biopsy, particularly if you think that it's a germinoma. Now, these are the positions which we use, but nowadays I prefer to use a semi-sitting. By semi-sitting, I mean that the knee joint should come up to the same level as the head. So as a result, the head can come quite low down and it becomes much more comfortable. And there are much less complications with semi-sitting. And of course, if we have to go through a tentorial, supratentorial, interhemispheric, we like to put the patient on something called as a Concorde position. So one could go infratentorial, supratentorial approach, supracerebellar approach, particularly for infragalenic pathologies. So this is a picture of a typical pathology where you would like to do a infragalenic, that is infratentorial supracerebellar approach. And this is a pathology where you can go from the top. You can do a supratentorial approach. Now these are pathologies where you can do an interhemispheric approach. So these three approaches, they form the mainstay for tackling, particularly for doing open surgeries for pineal tumors. So I'll just show you a couple of videos. It's a 4-month-old patient who had a moderate size meningioma, but most of the meningioma was infratentorial. Now, one exception for infratentorial pathologists to approach from a supratentorial approach is a meningioma. So in this case, even if even if the meningioma was predominantly infratentorial, we still went through an interhemispheric approach for two reasons. A, we can directly tackle the attachment of the meningioma. B, we are having a more easier approach because this posterior fossa is particularly steep, where sometimes it could become very difficult, particularly to devascularize the tumors. Now, there is no need to do angiograms for all these cases, but in this case it was done. And as you can see, there is an increased meningohypophyseal trunk. The reason is most of these tumors which arise from tent, meningiomas, they're not very vascular. So angiogram is not mandatory, but in this case, yes, I have done it. It's more for, so I'm showing it more for a teaching purpose. So that is the approach we took. We undertook a posterior interhemispheric approach. So that's a standard craniotomy. And in such cases, I would prefer to do a large craniotomy. I do not, at least I do not advise doing a mini craniotomy or an endoscopic approach for such tumors because you need to protect the neural structure. So minimally invasive structures is not a small opening, minimally invasive access approach, but it is how much we can protect the surrounding neural structures. So we start cutting the forks. And then cauterizing the meningioma right at the point of attachment. And as we do, the meningiomas, they become completely avascular. So again, this is the brain and this is the forks and the tent. So we have now directly approached and started tackling it at the focotentorial junction, cauterizing the point of attachment of meningioma. So by devascularizing at the base, one would make the tumor completely avascular. I do see that it's a mixed audience. I think more of non-surgeons, but I was under impression that there will be more surgeons. So I've kept two videos. So again, separating the tumor very nicely from the surrounding structures. I will fast forward it. So you can see as we keep on decompressing, more and more tumor comes out. And by tackling it right at the point of attachment of the tumor to the tent, we are able to make it completely avascular. And again, more and more tent and fox is cut. So this way we have a graded approach by which we have a complete control on the vascularity of the tumor. And even though we are approaching it from the top, we have a very nice, easy access to the tumor. So that's it, the whole tumor is removed. So one may either remove it piecemeal or one could remove it in 1 or 2 blocks and then visualizing the other structures deep down to ensure that they are completely protected. So that's the end of the surgery. So the basal vein of Rosenthal, the vein of Galen, they're all well preserved. That's the end of craniotomy. And by this, we can also achieve a grade 1 Simpson's excision because we are excising the entire tent to which it is attached. And that's the post-op MRI showing complete excision. That's plus contrast. That's a pre and post-op. So this is a short video on pinealoblastoma, which is a typical intrinsic pineal tumor, where we do it using a sitting position. Oh my God, I think by mistake I put. So 18-year-old female presenting with headaches, nausea, vomiting, difficulty of upward gaze. So she had a typical perinodes. That is what the clinical examination is. And this shows a very typical heterogeneously enhancing tumor. And as you can see, most of the tumor is infragalenic. So obviously it's logical that we approach it from a sitting position from below. So we prefer to use a reinforced endotracheal tube. And this is a typical opening. We also keep an opening ready for CSF drain in case there is too much of brain swelling. So that's a typical craniotomy which is done. Again, I don't prefer to do a minimally invasive or an endoscopic approach, even though people are doing it, because this is a very crucial area. You come across a lot of crucial structures, and its neuroprotection is the most important thing over here. It's not the size of craniotomy or trying to do minimally invasive or making a keyhole opening. It's the two fundamental objectives in such cases is neuroprotection and complete removal of the tumor, and these are the goals which cannot be compromised. So in sitting position along with gravity, you can see the cerebellum starts coming down. You don't need a retractor. So it can be very gently given a traction inferiorly, and you open this arachnoid. So whenever you do a sitting position, you come across this thick band of arachnoid which is surrounding the vein of Galen, and this is what has to be opened up with a sharp dissection. There are small veins which has to be cauterized and then cut, and then you come across this large vein of Galen. So now here, generally surgeons do become confused as to where is the location of the tumor. So one has to understand that the tumor is always inferior. So what generally surgeons start doing is they either start going on one side of Galen, either on the right side or left side, and they become confused. So initially when you do this, it's better to take a neuronavigation so that your guidance to tumor is good. So sometimes you can enter into the brainstem if you're not careful. So now we go in the infragalenic direction. I tend to use a lot of sharp dissection, show that the dissection is good. And I found that using sharp dissection, it's actually quite safe and is also bloodless. Now below that, now you'll find some pre-medullary veins, pre-Vermean veins. And these veins can be cauterized most often without any issues. So once you expose this, the dissection has to be continued in the infragalenic direction. So this is where normally the surgeons, they get confused. And as you do, suddenly you'll come across and you'll see. So that's a tumor. So the tumor is seen like, on either side of the pre-Vermean veins. And as you can see, these are very small veins. So before cutting it, I always put a Doppler just to ensure that there are no vessels, major vessels there, because sometimes the vein of Galen can still run down again. So now one can cauterize these veins. These are not, these usually they don't cause any problems if you cauterize these veins. And after doing this, one gets a very good access to the tumor. So take a biopsy. So generally, if it's intrinsic tumor, these tumors are quite soft. And biopsy is very, very essential. One should take a good amount of biopsy and then continue on decompression. Now, total excision here is very, very important. You should not just do a biopsy or do a partial decompression and come out. And you have to keep on doing it till you reach and open the third ventricle, the cavity of the third ventricle. So using CUSA ultrasonic aspirator is really very useful here. Now, thankfully, because of the sitting position, the bleeding is not much. But again, one has to be very careful to cauterize all the small vessels because again, air embolism is a potential complication in sitting positions. So even if it's a very small vein, if you don't cauterize it, again, it could suck out. Now, most of our cardiologists, they have a catheter which is kept with a Doppler. So they always end up finding about 4 to 5 cc of air going into the heart. That's not a problem, which they aspirate it. So earlier we used to get very much worried even if a little air goes in, but nowadays small amounts of air we can easily tackle it. So that's the floor of the third ventricle now being exposed. So till this area is seen, till this whitish area of normal brain is seen, one should carry on with the excision of the tumor. Because these tumors, they have an excellent prognosis once they are removed completely. So one can always be tempted just to do a biopsy for the reason of safety, but one has to understand that the margins of safety is also good provided you go in the good tumor brain interface. So now you can see we have removed most of the tumor using the CUSA, just a small nubbin superiorly, and which is once removed, exposes the third ventricle completely. So this automatically performs a third ventriculostomy from a posterior aspect. So the third ventricle is opened up. So as a result, one doesn't have to do a shunt or an additional third ventriculostomy, because doing this technique, some more tumor falls from the superior part. Now this is end. Now you can see that the third ventricle is opened posteriorly. That's interthalamic adhesions. And one can also visualize the choroid plexus there. So this is a side, this is a visualization that one must see at the end of surgery. So that's a choroid of the third ventricle with interthalamic adhesions at the top. So adjuvant therapy is important, and I think a lot has been spoken about here. I will not spend more time on that. And obviously, you need to also do a spinal radiotherapy. And similarly, chemotherapy is very effective for certain categories of tumor. Now, the only exception for doing surgery is if you do germinomas, in which a biopsy is very important. So once you get a diagnosis, they are very much amenable for radio and chemotherapy. So I will stop here. So my idea was to mostly show two cases of posterior third ventricular tumors. I had an option of either going into details of management of posterior third ventricular tumors versus showing two videos, and I chose latter. I hope I was able to convey the meaning. Thank you very much.
Excellent talk, sir. If there are any questions. Yes.
Yes, sir.
Still more effective, and because sometimes,
some tumors can be left on the side.
So if you use endoscope, that will be much better.
Well taken, sir. Point well taken. Thank you. Thank you once again.
Nice talk, Dr. Sharat Chandra. Next speaker is Kaviraj Kaushik. He is speaking on brain metastasis, role of neurosurgery using navigation.
Good morning, everyone. So I'll be talking today about brain metastatic tumors. So the role of surgery in cerebral metastasis, whether it should be done or not, when to do, and how to do. About 25% of all cancer deaths in cancer patients have brain metastasis on autopsy. And since cancer therapies are advancing and better survival in cancer patients, we are expecting that the more incidence we are getting with the brain mets. Lung, breast, melanoma, renal carcinomas, and colon carcinomas are some common tumors from where we do get brain metastasis. While in children, leukemias and lymphomas are common. In teenagers, in young kids, germ cell tumors are really having important brain metastatic diseases. So if we go incidence-wise, lung cancers are most common metastasis which a neurosurgeon encounters, about 30 to 60%, followed by breast malignancies in 10 to 30% patients, and melanomas in 5 to 20% of the patients. Rest, kidney, colon, stomach, prostate, thyroid, choroid, carcinoma, germ cell tumors, and ovary are other tumors which we get. The most common cause of brain mets in males is from a lung, while in females it is more common from the breast. And melanoma, since overall incidence of melanomas are small, so only 4% of all cancer metastasis are there from melanoma, but they have the highest propensity to metastasize to brain. And lung cancer has the second highest propensity for brain metastasis. Although metastatic disease is more common in lung and liver, but since manifestation of brain metastasis are more overt and disabling, so these are the main cause of morbidity and mortality in patients with metastasis. Brain metastases are usually peripherally located. They are usually on gray-white junction of the cerebrum. And if we talk about location, 80% are in cerebrum, around 16% are in cerebellum, and 3 to 4% are in brainstem and other locations. There are solitary mets, mostly from breast carcinomas or renal cell carcinomas, and we get multiple metastases from lung carcinomas. It can be synchronous metastasis or metachronous, that is when there is an interval between the primary diagnosis and the brain mets. So lung tumors have short duration of brain metastasis, while breast carcinomas do metastasize very late. Clinical manifestations. Since brain metastatic tumors have the characteristic that they have extensive edema more than the size of lesion. So they usually present with signs symptoms of raised ICP. And usually they are rapidly growing, and sometimes they can present like stroke-like features when the intratumoral hemorrhage are encountered. While seizures and focal neurological deficits are other possible manifestations. Now, regarding the treatment part. So we have mainly three modalities: surgery, radiation, and chemotherapy. I will be only talking about the surgical part. While in radiation, we have different armamentarium, whole brain RT, with SIB, simultaneous integrated boost, or stereotactic radiotherapy, or fractionated stereotactic radiotherapy. While in chemotherapy, some of the newer drugs are doing very well even in brain metastases, but most of the chemotherapeutic drugs don't penetrate into the brain, and they are really a challenge. Since brain metastatic tumors are well circumscribed and spherical, they can be easily taken out, and we can find clear-cut margin from the parenchyma. If we cut the surface of tumor, they are pinkish gray, granular, sometimes soft, sometimes hard. If these tumors are very vascular, they are from renal carcinomas, choriocarcinomas, melanomas. Cystic tumors, when we do encounter, they are mostly from lung malignancies. And if we are suspecting from breast carcinoma, they are usually hard and calcified masses. Other differentials can be like lymphomas are usually hard, glioma and abscess, I won't see. Now, surgical resection, what are the advantages of surgical resection? We have complete, if we can do complete excision, then there will be immediate reduction in ICP, and sometimes it gives good relief from the deficit. And if we are not sure of the diagnosis, then histopathological diagnosis can be there in unknown primary. And sometimes, rarely, it can be a different primary apart from the main tumor. So different histopathology we may also get. There will be good local control for long term, and that is the main advantage of surgical resection. Again, morbidity, surgical morbidity is the main disadvantage. Neurological deterioration, non-neurological like bleeding, sepsis, and DVT like in other tumor surgeries. But if we consider the mortality, it is as same as in radiation therapy and other oncological treatment. Now, when do we consider the surgery? Like single METs, good KPS, low tumor burden, stable primary disease, multiple, then it is an ideal candidate to take out the metastatic disease. While multiple METs within the same part of the brain, in same location, non-locant area, we can even take out 2 to 4 malignancies. Tumor size, like more than 3 centimeters, big sizable tumors, there is no controversy, surgery is the answer. And in small tumors, deep-seated tumors, SRT or SRS are main answers. But when the tumor is in between, like 1 centimeter to 3 centimeter, then we have to decide about the surgery, whether we need to reverse the deficit or not. We should consider the surgical morbidity in those patients. we have to see tumor burden and other comorbidities, and we should weigh the benefit versus risk of the surgery. And superficial tumors, every surgeon would like to take it out, while in brainstem, basal ganglia, we don't have much surgical option, and if unknown primary, we can do stereotactic biopsy in them. Eloquent area, we can do biopsy, or sometimes with modern gadgets, navigation and awake craniotomies, even excision is also possible. Now, surgical benefits versus limited life expectancy is also a big question. And if expected survival is more than 3 to 6 months, then only we should consider taking out the tumor. Again, decision also is important on the basis of histopathology, their radiosensitivity and chemosensitivity, like small cell lung carcinomas, lymphomas, germ cell carcinomas. They are usually very radiosensitive or chemosensitive, and even with bigger tumors, we can try without surgery. While some tumors like melanomas, renal cell carcinomas, and most of the sarcomas, they are radio-resistant tumors, and option of chemotherapies are also very less. In those tumors, even with smaller tumors, we may have to go inside and we have to take out the metastasis. Like non-small carcinoma, breast carcinomas, they have intermediate radiosensitivity, and again, there are multiple factors which will help us in detection, decision making. Now, how to proceed for the surgery? Always and always, en bloc resection is the choice of a surgeon while dealing with metastasis. That will avoid spillage and leptomeningeal enhancement. Like we can use navigation, intraop USG, and other gadgets. Functional MRI or brain mapping, intraop DTI mapping are helpful tools. And so these are few cases which we usually routinely perform. This is isolated brain, isolated metastasis from CA breast in the posterior fossa. In breast carcinoma, we usually see propensity of the metastasis in posterior fossa, while in lung and all, we see in cerebral cortex. This is another tumor as metastasis from sarcoma, which our radiotherapist and said to take it out because it was post-irradiated. Again, surfacing isolated tumor, which were resected en bloc. And when there was a large tumor, we resected it in piecemeal manner. And after that, USG, we check whether there was any residual disease or not. In cystic tumors, again, and this is a pontine mets where we need to do a stereotactic biopsy. It was done frame-based. Again, solitary metastatic tumor from CA breast taken out completely. These were two metastatic tumors in each hemisphere. One was in posterior parietal and another was in right temporal. Both the tumors were taken out because he was post-irradiated. There was no focus of radiation in those. This same cystic tumor from CA lung in the same hemisphere, which we take out. Again, cerebellum mets from CA rectum. This is a metastatic tumor from renal cell carcinoma, which was taken out and block. So, some words about leptomeningeal disease. About 5% of all cancer patients at their palliative stage, they land up with leptomeningeal disease also. And sometimes even with our interventions, when we do take out piecemeal, there is propensity for leptomeningeal disease spread. So in these patients, the life expectancy is really very less. And the role of a surgeon in these patients can be like CSF diversion while if the patient lands up in hydrocephalus and raised ICP, or sometimes putting Omaya for intraventricular chemotherapies and all. But no much things can be done in leptomeningeal disease. conclusion. So MRI brain with contrast is the ideal modality of looking for brain metastatic tumors, not the PET scan. There are decision we have to make on the number of metastatic location, size, edema, and involvement of eloquent area. Neurological deficit, steroid challenge test, and are the main tools. Only patients with good KPS do well post-surgery. PET CT primary, we have to decide what is the burden of the primary disease, and histology of the primary disease. En-bloc resection should always be considered, and post-op RT should be considered for every patient. Thank you.
Excellent talk, Dr. Kaviraj. Any questions, comments?
Kavi, you said in your talk that best to operate on single mat is there.
Yes, sir.
Then in the second line, you wrote down that 2 or 4 you may take out anything.
So it is always depend on the decision, what is the primary burden, whether the tumor is radiosensitive or not. Sometimes patients do come to us after SRT has been given and they have failed, and still the tumors are increasing. And tumors, if they are locating in a same lobe, then it is easy to take out 2 to 4 malignancies at a time.
Matlab, you want to say that 2 or 3 mats, different mats in the same location.
Either in same location, and but we have the cases even in different hemispheres. We have taken out at a same sitting. It is always an individualized approach depending on the patient clinical condition, his tumor burden, and his pre-op therapies what he had received and response to that therapies.
And volume also.
Yes, sir, definitely.
Thank you.
Thank you, sir.
Next, I would like to call upon Professor Ali Asgar. He shall speak on role of intraoperative ultrasound in brain tumor surgery.
Good morning and thank you. Thank you, Dr. IC, RGCR team, everybody. I was happy to hear one of our chairpersons mentioning ultrasound during the last session, and I'm happy to carry on from that, trying to describe the application of intraoperative ultrasound as a kind of a cost-effective, but yet very efficacious intraoperative imaging adjunct. So I'm going to focus on its application in tumor surgery, but it can be used in many other things. I'll just show a couple of slides. So when we talk about tumor surgery and intraaxial tumor surgery, we are trying to balance this. It's a very fine balance, right, between resecting maximally and also maintaining function. However, if you go back and look objectively whether we've achieved the aim that we set out to in terms of extent of resection, most of the times our subjective evaluation as neurosurgeons, if we are honest, falls short. And many studies, this is one of them, have shown that even when surgeons estimated a gross total resection intraoperatively, postoperative MRI showed a residue which was inadvertent. That means it was unexpected. They thought it was resected, but it was still there. And this is seen in almost upwards of 60–70% of the cases. And this highlights the limitations of pure subjective evaluation of extent of resection in intraaxial tumors. And there are many reasons why this can happen. And the aim of surgery, neurosurgery, any kind of surgery is to avoid those mistakes, errors, inadvertent, unforeseen. And if you look at it, this is something in any organizational structure which is important, minimizing errors, and neurosurgery is high precision. So you want to do that. And you start off by first selecting the right cases to plan for surgery and aligning your goal of surgery with the case. Not all are resectable, remember. And then once you decide you have to resect it, your surgical planning, preoperative preparation, the right surgical technique, microsurgical technique, and then the appropriate adjunct, if needed judiciously, is also very important. So many adjuncts, we've seen talks about a few of them. And what we will focus on is the intraoperative imaging and ultrasound in particular. Now, if you go back historically, ultrasound was used as an intraoperative tool in surgery for the first time in neurosurgery, actually, in the 1960s, 70s.
And since then, I think we've come a long time from these unwieldy big machines with large probes and poor image resolution. We've seen a lot of advances in technology, and now you have ultrasound images in the brain and spine, which can compare with the MRI, and in fact, sometimes provide you with more information in real time than the preoperative MRI. And we'll focus on its role as an resection control tool, helping you gauge the extent of resection in intraaxial tumors, mainly gliomas. So what's the evidence of the accuracy or the diagnostic accuracy of ultrasound? I think this is an old study, but it's still a very important study which compared the diagnostic accuracy of biopsies taken intraoperatively in various intraaxial tumors, low-grade, high-grade metastasis, using an intraoperative navigated ultrasound, and compared it with the MRI T1, T2 images, which were preoperatively imported on the navigation. And what it showed was that the diagnostic accuracy, histologically confirmed, of the ultrasound was equal and actually superior to the MRI in most of these tumors. Now, you might argue that the preoperative MRI was inaccurate because there was brain shift and therefore there was an error in the registration. But then there is studies, this is one of them. There are other studies which have compared intraoperative MRI, intraoperative ultrasound, ALA in this case, because it was GBM, with the diagnostic accuracy, and they have similar results, which means that the ultrasound is effective and it's diagnostically accurate, provided it's done correctly. This is a meta-analysis which highlights the diagnostic accuracy overall in the high range. The summary of all this is that the ultrasound, if used correctly, can give you good intraoperative information. And that's been our experience too, where we've had a reasonably high diagnostic accuracy. But what is more important is that the diagnostic accuracy leads you to change the course of your surgery when you do the ultrasound. Remember, I talked about inadvertent residues, leaving behind something which post-operatively you pick up. And what this, our experience and others also shown that when you do the intraoperative ultrasound repeatedly, intermediate scans, you pick up those residues, which leads to a positive change in your surgical decision, provided you can resect it safely. And this happened in more than 40% of our cases. And more importantly, very useful in low grades, non-enhancing tumors, which are a little diffuse, difficult to see the boundaries, and where other adjuncts like fluorescence, for example, may not be of many use. And even in high-grade gliomas, and this we had done a study many years back, we were able to resect beyond the contrast enhancing tumor into the T2 flare using the ultrasound. And now we know, and this is very recently the RANO-resect criteria for high-grade or GBMs basically, that supratotal resections beyond contrast enhancing into T2 flare, basically called flarectomy, is prognostically significant. And as you see, the ultrasound can help you achieve that. So it also helps, it's accurate, it also helps and impacts the course of the surgery positively. Not only that, it has many other purposes besides just resection control in various other surgeries. For example, localization, planning a trajectory, doing a biopsy, and even orienting yourself in the surgical field when you do not have navigation. And it's not one-dimensional. Ultrasound has many facets. We all think of ultrasound as 2D, B mode, real-time grayscale imaging, but there are many other aspects, including Doppler imaging, angiography. You can have elastography, you can have contrast-enhanced ultrasound, you can do fusion imaging. This is an example of fusion imaging where the ultrasound is acquired using a calibrated and reference probe. Combine it with your navigation. You can navigate with it and you can update repeatedly during surgery. You have Doppler and you can do real-time color Doppler angiographies. In many cases, it is helpful pre-op, post-op. This is an example for an insular glioma where you can see the relationship of the MCAs. And if you do it well, even appreciate and visualize the lenticular striates. You can do it post-op to confirm the patency and the flow in the MCA vessels in these tumor surgeries. Elastography is another example which helps you gauge the stiffness or the consistency of the tumor. Now, it is something which may not really directly have an impact on the resection rates, but it helps you consider what kind of resection tool you'll use, whether suction will be enough, for example, whether it's going to be firm, it's going to be hard. And these are examples of some tumors where the different components of the tumor have different consistencies on the elastography. And then you have contrast-enhanced ultrasound, which uses nanobubbles to predict the enhancement pattern as well as the vascularity, and very good for microvascularity in tumors. I must admit, we don't do it, and this is because it's not labeled for use in the brain in our country, but it can be done. The benefits of the navigated ultrasound or fusion imaging that I spoke about a little while earlier is that sometimes the ultrasound has a problem because we feel it difficult in orienting or in adjusting and understanding the relationship to various structures, especially in the beginning of our experience. And a navigated or fused ultrasound with MRI helps you overcome that learning curve faster. And it also helps you compare serially acquired ultrasounds much better because you can actually see it in the same planes and assess the residue and gauge your extent of resection. And very importantly, and this is something becoming more useful nowadays, is how to update the brain shift using a real-time imaging, and that's where ultrasound fits in very well. It helps you update the MRI which you had preoperatively acquired and get it correctly aligned to the brain shift which has happened. And this kind of obviates the need of having an intraoperative MRI completely. So the ultrasound is also a multifaceted tool. It's accurate, it helps guides you surgery, it helps you course correct during surgery. It has multiple applications as we've seen. And therefore, it's not just limited to tumor surgery and not tumor surgery in the brain, but can be used for various other things in neurosurgery, which I will not focus on because the talk is on brain tumors. But this is an example. It can be used in tapping cysts, in ventricles, in hematomas, and guiding the endoscope. And this is just an example of how it basically improves your confidence, your comfort level, and helps you minimize those errors. Even if it's 1 in 1,000 that may happen, you still want to avoid that. In spine, it has a lot of applications. For example, in extradural lesions, where you would want to assess the extent of the lesion sometimes, and whether the adequacy of your decompression and the dura is pulsating and there is no significant ventral compression. In intramedullary tumors, for example, here where there were some drop mets from a myxopapillary ependymoma, you can pick them all up and you avoid missing any of them if your intention is to remove them all. In certain cases, for example, a dermoid here where it was difficult to make out the plane, the ultrasound helped show the kind of combined plane that it had intramedullary coming out exophytically at one part, and also as a resection control tool to make sure that everything is removed and there is no residue left behind there, and then during surgery you can confirm. And in intramedullary tumors, I think it's most useful. It helps you determine the extent craniocaudal of the tumor, determine where you might do the myelotomy, the thinnest part, because it shows you very well. And it helps you gauge how much you've resected. Of course, here the intraoperative neuromonitoring probably is more important, but both of them together work very well. So you see that the ultrasound is also a very versatile and multi-purpose tool. And most importantly, it fits in nicely with your neurosurgical OR, the workflow. It does not disrupt it in any ways. It complements other modalities that you're going to use and does not interfere in any way with any of them. As you can see, it does not occupy too much place in the OT. Very well gels with your OR team, and it's very easy to use. And most importantly, if you look at the cost factor, it definitely is cost effective compared to intraoperative MRI, for example. And there are a few studies, unfortunately, none in the Indian context, but very relevant in India because you want a tool here in our cost constrained setups, which is available not just as few centers, but as many centers where these surgeries are done across the country. And this is something which the ultrasound can probably satisfy and fit in nicely. However, and this is just the last couple of slides, you still need to know how to use it correctly. Because if you don't, then all these benefits, so-called benefits, will not be achieved. And this is important because you need to have a good image quality in order to interpret and act on it. And therefore, competency development by having a good scan and then able to interpret it is something very important. And if you do that, you realize that compared to, say, the intraoperative MRI, which is the gold standard for intraoperative imaging, there are many benefits of the ultrasound over and above that. And you can overcome some of the perceived limitations by either using fusion imaging or by training yourself and developing competency to overcome that subjectivity and the learning curve. And thereby, all these possible errors which we talked about can be minimized. And no wonder then that the ultrasound interest in ultrasound has really increased exponentially. This is a PubMed search over the last 10 years. You can see intraoperative ultrasound is becoming more and more popular and more studies coming out. And just to show you what the status is, that this is a trial in the UK, the NHS running, where they consider standard of care versus a combination of intraoperative navigation DTI with ultrasound to evaluate its efficacy in intraaxial tumors. So I think I can reasonably safely say that the ultrasound, if done correctly, is quite reliable, accurate, multi-purpose. It is also real-time, fast, and convenient, and therefore it can fit in with anybody's neurosurgical workflow. And most importantly, it's cost-effective. Thank you.
Very nice talk, Ali Asghar sir. Any question?
Yeah.
Like we brain tumors, the ultrasound is also, I think it is very important, and we almost use in all the patients ultrasound. The problem which we face while during intraaxial tumors, when we take out 80-90% part of the tumor, then when you apply again the ultrasound, the resolution is not that good. How do you overcome that problem?
Yeah, I think I didn't have time to cover that much, but that is a one big major problem with ultrasound, is that the image quality degrades as you go ahead, and that's because a lot of artifacts accumulate. There are two kinds of artifacts quickly. One is because of some debris, either it's blood clots or something, or Surgicel gel foam. You need to wash out everything, have a clean cavity. That's sometimes a pain, but I think eventually it makes you a better surgeon. You have a clean cavity. The second artifact is kind of related to physics of ultrasound, where you have certain properties which make the image appear brighter or darker. And there, a little bit of knowledge about basics of ultrasound, maybe help from radiologists, will help you overcome that. Even otherwise, what you should always do is to not do just one scan in the beginning at the end. What we generally like doing is repeat scans in between, because artifacts which appear over time can first be picked up if you have serial comparison. Unless you pick up the artifact, you won't try to eliminate them. So the next step is then to eliminate them in order to get a better image quality. So I think it's a little bit of trial and error over a period of time. And eventually, I think you reach a state where you can actually get good images, but it may not always be the situation. It's not an ideal adjunct. As I said, a lot of subjectivity, but it gets better as you do it more often.
Ali, I just want to know, what do you think about learning curve? How much time a person required to?
So I get that question many times, and I tell everyone it's not long. It takes maybe 15, 20 cases. And what I suggest is that you just use it in even all cases whenever you're doing a craniotomy, just to get a hang of how basically to set it up, take the probe, insonate, basic gain, how to adjust. Within 15, 20 cases, you should be quite familiar with the basic working. These things like artifact avoidance may take a little longer. And in our case, using it with navigation combined shortens the curve further, because your orientation with the MRI being there and navigation makes it easy to interpret the ultrasound image. Once you get that hang, I think then it becomes, then it's completely up to you how much more you want to get experienced with it and how much more familiar you want to get. But I would say 15, 20 cases is good enough to get the basics right.
Because in future, I think through AI and mobile in your hand, the ultrasound can be done very easily.
Even now it's possible. Mobile ultrasounds, point of care ultrasounds are already available, and they give good image quality. In the OT, there are a little bit other limitations. Everything has to be sterile, so you have to sterilize whatever you're using. So that makes a little bit of a challenge. And in terms of image interpretation, I think a lot of work going on, but AI still has a lot of, still going to take a long time to get you to image interpretation. But basic ultrasound insonation and image interpretation, I think AI will help a lot. So I showed you those meta-analyses. They're basically diagnostic accuracy studies, where they compare the intraoperative ultrasound diagnosis residue yes, no versus postoperative MRI. And they have shown that the overall accuracy, diagnostic accuracy, is around 85%, which means, and positive predictive value, negative predictive values are in the 90% ranges, which means it's not 100%. but it also depends on what you're using as the gold standard, MR as the gold standard. There could be some error in the interpretation of the MR also. So I think if you look at the histology studies, the first one which I showed, the ultrasound did as well as the MRI and the intraoperative MRI. So it's in these studies, it seems to be working as well. So I would say that if I had to choose between two, I would choose the ultrasound without the navigation. But what the navigation helps is that if your learning curve initially, the main problem people face is orienting the ultrasound, which is anterior, posterior, which is left, right, because it's a limited field of view and it doesn't come in the same axial coronal sagittal that we are all very accustomed to seeing. With the navigated ultrasound, that happens. You can put it into axial coronal sagittal and you have it overlaid next to each other with the MRI. So you can kind of mentally learn faster how to interpret that ultrasound based on the MRI. And in some cases, use additional features of the MR which the ultrasound doesn't have. For example, DTI, functional MRI, you have some segmented objects. All those can be superimposed with the ultrasound to give you that additional information. And nowadays with the ultrasound, you can correct that MRI as I showed. You can do a brain shift correction. So it combines the best of both worlds. So there are advantages in it, but the real-time information is contained in the ultrasound only. So to look at the residue, I think you would still rely on a good ultrasound and assess and interpret that itself. No. I think any machine is good enough. It's just that we use this and it's integrated. But I think any machine is good because it has a lot of the only thing precondition is you have to get familiar with the machine. Each machine is a little different. It has its controls, settings. Once you get familiar with it, using it yourself, then I think it works. Integration with navigation depends on how the two companies have an integration because it requires the navigation company to be compatible and those are a little bit challenging, but things are improving a lot more coming into the field. So hopefully that should change.
Thank you. If no more question.
Thank you.
Thank you, chairpersons. And I thank all the speakers. You literally transported us to the OT. We come back to the hall now and we move with the next academic session, next academic lecture, series of academic lectures. I invite Dr. Ajay Chaudhary, neurosurgeon at Ram Manohar Lohia Hospital, Dr. V.S. Mehta, sir, Dr. Madhu Sethi, assistant professor and founder faculty member at Dr. Baba Saheb Ambedkar Hospital to chair the session.
Morning. I welcome you all to this session. And the first speaker is Dr. Satnam Chabra. He'll be speaking on his experience on pituitary tumor surgery.
Good morning, Professor Mehta, sir, Dr. Ajay, and ladies and gentlemen. I'm going to talk about my experience with pituitary surgery. Yeah. You'll be running from there or? So as you all know, the pituitary tumors are a common problem which we all handle. They account for about 10 to 15% of all brain tumors. Incidence is about 3 to 4 cases per lakh. And classification microadenoma, macroadenoma, giant pituitary tumors, we all know that. So surgery for pituitary tumors can be transcranial or can be transsphenoidal. So as more and more experience you get, the indications tend to vary. You can do more tumors transcranially, and there are very few indications for transcranial when there is a lateral extension and beyond cavernous sinus. Then probably you need transcranial route. Transcranial can be microscopic or endoscopic. So endoscopic can be uninostril or binostril. In late 90s, the papers on endoscopic neurosurgery, endoscopic transcranial surgery came. And first was Joe, who introduced uninostril approach. And then Amin Kazam group introduced a binostril approach. The advantage of uninostril is that there is lesser trauma to the nose and nostril, and you can go in through single nostril and remove the tumor. But with binostril, you can do a much wider work, bimanual technique. So it has a great advantage for larger tumors. So I basically started my endoscopic pituitary surgery. I'm going to talk more about endoscopic pituitary surgery. I started around year 2000 with uninostril following Joe's technique, and I'm doing it without any ENT help. And later I switched over to binostril. So I find binostril much better than uninostril because you have a better control. You can use bimanual dissection. So, but of course, there is a little more trauma to the nasal cavity, but still, this is better than uninostril approach for especially for large tumors. So I started using nasoseptal flaps for repair of the dura in large tumors or extended approaches. This is how we have been doing two-surgeon technique forehand. And my associate is my neurosurgery colleague only. I don't call ENT people for nasal part also. And this is the technique. Haddad flap is raised in most of the cases. Multi-layer closure is used when there is a CSF leak or extended approach. I use fascia, fat, Haddad flap, glue. We have tried Duragen also, but I don't find it very good. Lumbar drain, nowadays most of the cases I've stopped using it. Last 1 year, I have not used any lumbar drain in any of these cases, even extended approaches. Just fat and fascia. Just fascia and Haddad flap. Even fat, I try to avoid because if you are doing larger opening, it tends to fall in the cavity. Nasoseptal flap is a very good flap for the repair of dural defect. It is based on the nasoseptal artery of the nasoseptal branch of the sphenopalatine artery, and which is raised from the nasal septum and turned back like this to cover the dural defect. So this is the video which I'm going to show. This was a case, this was earlier operated way back, I think 2011 by transcranial approach, and there was a recurrence now, and patient presented with CSF leak and meningitis. Meningitis was controlled, and this patient was operated endoscopically. This tumor has gone right into the third ventricle, anterior cranial fossa, and around the vessels. So I've skipped the nasal part. We have reached sella. And this is the tumor. So one gets a very panoramic view with endoscopic technique. One can, if tumor is going into anterior cranial fossa, you can move the planum sphenoidal tuberculum celli, go anteriorly, extended approaches. You can take the telescope inside for tumor removal. And like this was a very extensive tumor going into anterior cranial fossa. This has gone into the third ventricle. I'll show you. This is removing more bone towards tuberculum celli because tumor was going there. This is, you can see dura of the planum. Dural opening is being extended. So bimanual technique to binostril. So you can see the anterior cerebral arteries. Tumor is going. Yeah. This is up to the third ventricle. You can see the thalamic adhesion for mammillary bodies, aqueduct. So most of the tumor has been removed. And then this was repaired by inlay and overlay facial autograft superimposed with the superimposed with the nasoseptal flap, and then merocell packing over there to hold the flap there. So these are few cases. This was a giant pituitary tumor, which was going into retrocellular, supracellular, into the third ventricle, pre-operative and post-operative picture. This is the same patient, contrast enhanced, complete removal of the tumor. You can see the pictures. Another giant tumor, pre-operative and post-operative pictures. Another tumor which was going into the cavernous sinus in the left side has been removed completely. Another giant tumor which is going into multi-compartments, post-operative picture. Another tumor, pre-operative and post-operative picture. This was a growth hormone secreting macroadenoma, which was removed completely, and patient is hormonally normal. This is another large tumor. There is a small residual tumor there in the post-operative picture. This is a growth hormone secreting microadenoma, pre-operative and post-operative. Another microadenoma removed endoscopically. Giant tumor. So these are all cases. So, oh, sorry, this was going into, this patient was on pacemaker, so MRI could not be done. So there was a giant pituitary tumor going into anterior cranial fossa, which was removed by extended approach. Post-operative picture down. Another large tumor, pre-operative and post-operative. So since 2001 till date, we have operated more than 700 cases, skull-based surgeries. Most of them, 95% were pituitary tumors. And recently, we studied the outcome of consecutive 100 cases of endoscopy pituitary surgeries conducted over 3 years between September 19 to November 2022 as part of the thesis, DNB thesis, where we studied percentage of tumor resection, hormonal cure in functional adenomas, visual outcome, and development of any new post-operative hormonal deficits. So gross total removal of tumor was called when there was a complete absence of contrast enhancement in MRI after 6 months post-operatively. So out of 100 patients, there are 95% GTR achieved. Out of 11 giant pituitary tumors, 7 patients had GTR, that is 63.3% of the patients. Subtotal resection, that is up to 10 to 20% residual tumor, was seen in 4 out of 11 patients of giant pituitary tumors. And partial, more than 20% residual was seen in 1 patient out of 100 cases. Hormonal outcome, 10 patients had growth hormone secreting adenomas. 8 patients, 80% had hormonal cure at 6 weeks post-operatively. 2 patients had reduction in their levels, significant reduction, but still 4 patients had ACTS secreting pituitary adenomas. 3 patients achieved cure, hormonal cure, and 3 patients of prolactinomas we operated who presented with CSF rhinorrhea, because it infiltrates and sometimes it can produce CSF rhinorrhea, and their prolactin levels were significantly lower in all these patients at 6 weeks. And visual field improvement was seen in almost all patients. 71 presented with visual field defect. Post-operative new hormonal axis deficit was seen in 16% of patients post-operatively. And most of these deficits recovered over next 4 to 6 months. Few had persistent deficits, so required hormonal replacement. I think I have time. So I'll show, this is not actually pituitary. This is suprasellar craniopharyngioma, in fact, retroinfundibular craniopharyngioma, which was removed through extended approach. So this is the nasoseptal flap being raised. This is the nasoseptal flap. This is scale of sphenoid. I cannot forward it. How much time do we have? Can I present this video? 3-4 minutes? So I'm drilling the sella and tuberculum celli plenum sphenoidale. This is about 4-minute video. So please, this cannot be forwarded here. Sorry, I don't have any control here. So you can see the dura over sella turcica and plenum sphenoidale. And there, this optic chiasma is visualized. So this is prefixed kind of optic chiasma. So there is hardly any window between diaphragma and optic chiasma. So we opened the diaphragma. This is a pituitary gland. And going between pituitary gland, diaphragma, and optic chiasma. This tumor was completely retroinfundibular behind you can see the superior hypophyseal artery, which is traveling along the stalk. And there is a stalk there, pituitary stalk, and tumor is behind pituitary stalk. This is craniopharyngioma in a 12-year-old child. This was solid part was removed completely. And you can see the stalk there on the right side. And then this was repaired with inlay and overlay facial autograft. And then over that, the flap was laid. This is inlay flap. And this is the overlay on. So advantages of endoscopic pituitary surgery, they are all well known. You get a improved field of vision. It is a minimally invasive, reduces recovery time. There is a comprehensive removal of tumor is possible. Lower risk of complications because you see structures very well, and surgeon's comfort is there. You are not using microscopes, so your neck is comfortable. Disadvantages are that you get a two-dimensional view, so one has to get used to it. Nasal complications are common after this thing, and you require regular ENT care after that for a few months, and there is a learning curve problem. Thank you so much. Thanks for patient here.
Thanks, Dr. Satnam, for your nice elaboration of your experience with pituitary endoscopic surgery. So, was there any case in which you subjected the patient for gamma knife after some of the patient in which paracellular extension was there?
A few patients, there was a small residual tumor or there was recurrence. So some of them were subjected to gamma knife. Yeah.
Any question from audience? Sir.
Sir.
So anyway, just to discussion sake.
Yes, sir.
Is there any indication of transcranial surgery in your opinion?
Yes, sir. If there is beyond cavernous sinus lateral extension, yes.
Then you do it.
Yes, yes.
Small
Not,
thela or is
no,
not.
otherwise no contraindication. If a tumor is in the midline, right from the plenum spinalis anterior cranial fossa right up to the retrocellular, we can do it comfortably. Little lateral extension also. But as far as Kazam, what he says, if it is beyond the nerves in the cavernous sinus, one should not go. And I also feel the same thing.
Okay.
Kissing carotid?
Carotid?
Kissing carotid.
Kissing carotid, really, I've never faced any such problem.
Yeah,
I have
very
done it in
occasionally, but
close,
you
yeah.
do sometimes see where there is.
Yeah,
both
but
carotids are
fortunately,
coming.
I've operated so many, never
You are
had
not
any
seeing.
carotid injury so far in my
Of course,
experience.
you
And I never really look at, but of course, I see where carotids are, but really, I'm not. Luckily, so far I've been lucky.
I think, but if you see, then probably you will not
Yes,
avoid
sir.
it.
Yes, sir.
Now, so, there's a patient who you operate, developed CSF leak, and you put a head flap also during the first surgery, but he developed severe meningitis. How do you tackle that?
Sir, in this series, I think 3 of my patients had meningitis. 2 patients recently, maybe 2 years back, post-COVID. So I had bad experience. I realized that I use Duragen. I've stopped using Duragen because I feel it's a foreign protein which stays there. If it gets infected, it's a source.
Absolutely
Otherwise, really in such a large series, I had CSF leaks, but no meningitis except one case who had a very large tumor and long back. So recently, 2 cases 2 years back. So I've stopped using Duragen. And then of course, then standard treatment, use lumbar drain, pack, and all that for whenever you have it. In these 2 patients, we did repeated lumbar punctures, antibiotics. Fortunately, both of them survived, and they are all right. Nowadays, I've stopped using lumbar drain also. What I do is multi-layer like this. I showed inlay and overlay and then graft. And then what I feel that the flap has to stay there. Earlier, we were trying to use glue or Foley's catheter which Kazam group uses. So I realized still CSF leak was possible because probably the flap didn't stay there. So nowadays, what I do, I put a Merocell right into the sphenoid sinus because initially I remove all mucosa completely. I put one Merocell right there up to the sphenoid sinus and take a thread out. And then there are, of course, in the nostril, there are 2 Merocells, which I remove next day in 1 or 2 days. And this inside, I keep it for 2 weeks. I remove it after, and I've realized after, yes, sir, longer, yeah. 1 week is not enough. Even after 1 week, patient can have leak. I've seen a patient. So 2 weeks, I had no problem, and patients are doing very well. Because why I did this? Because I've seen people who are using absorbable nasal packings, which stays there for several weeks. So they don't have any problem for it. So then I thought, why not we try this? We don't have absorbable nasal packings available in India. Or if they are available, they are very expensive. And luckily, there has been no problem. No case of meningitis, no case of CSF leak in last 1 year. I've stopped using lumbar drain. even these extensive tumors, which the patient whose craniopharyngioma I showed, I have not used any lumbar drain.
For 2 weeks will not be a source for infection also.
Sir, because I have removed that nasal or the mucosa from the sphenoid sinus, so I find, because I have told you the people are using absorbable nasal packing, which stays for 3 weeks and don't have any problems, sir. Then why not use it for 2 weeks? Yeah, it works very well, sir. You must try it. You can take it out. No, that I removed next day. Nasal nostril. From the nostril, I remove it, and then sphenoid sinus, I keep only that within the sphenoid sinus, where I have removed, denuded it completely during first surgery. There is no mucosa there. So, no case of CSF leak so far, no case of meningitis in last 1 year. This is in a continuation of that absorbable. I was looking for basically absorbable nasal packing, which was not, it comes from Stryker, but it is not available in India. There are a few other companies which are doing, but it is very expensive. It's cost several thousands. I saw this this guy from Malaysia, Pepagran. He uses absorbable nasal packing in all his cases of extended approaches. They do it very often, and they use absorbable nasal packing. Absorbable nasal packing there in the sphenoid sinus. In the sphenoid sinus, they put it there.
Only one comment, if there is a delayed CSF leak. So I have seen people going in and repacking quickly. A delayed CSF leak is evidence is that there is a meningitis. Otherwise, it should not happen. So you should treat the meningitis and then repack.
Yeah.
Because
Yes,
if you put the pack in presence of meningitis, it will.
Yeah, then of course it is. Meningitis has to, that I agree. Because whatever is, the flap really has to stay there for 2 weeks, or you put stitches. These Japanese group, they have started putting stitches. They have made special instruments, and then they stitch the dura, put a graft and stitch it. But otherwise, chances of CSF leak, you see you go to these Western literature, they have 5% CSF leak or more than that in these extended approaches. They have
Actually, the problem arises when patient is Cushing or hypocortisolemia.
Right.
And you have to give steroids. And
Yeah,
those
there
cases,
also, those cases are prone to meningitis.
Yeah.
Extended approaches where you removed dura extensively. So there the chances are very high. This Kazam was criticized extensively in US for extended approaches because of incidence of meningitis, CSF leak in the beginning. So he has modified his techniques and all. But I think this has worked.
Thank you.
Thank you so much.
Thank you.
10 days try. 1 week has failed. After 1 week, it failed. So I made it 2 weeks. So maybe gradually, this is a big.
So the next speaker is from abroad, Dr. Carlos Serra is from Zurich. He'll be presenting online on his topic is importance of white fiber tract in glioma surgery.
Yeah, good morning. Can you hear me?
Yes.
Okay.
Yes, it's audible.
Thanks a lot. Thanks, of course, to Professor Prem Sagar for the invitation, and thanks to the organizing committee of the Rajiv Gandhi Cancer Institute. Can you see also my slides? Hello? Can you see my slides?
Yes.
You see my slides? Okay.
Yes.
So thanks a lot. So yes, again, thanks to you, Professor Prem Sagar, and to organizing committee of the Rajiv Gandhi Institute. As presented, my name is Serra. I am responsible for skull-based and oncological surgery here in Zurich. And today I will have a pleasure to introduce you, to present you a more qualitative talk, if you want, discussing why the knowledge of white matter anatomy is of crucial relevance for oncological surgery. I will just allow myself to take 5 minutes of your time to make a short historical overview on how did we get where we are now from a surgical perspective, and then present to you some possible points to underline why is it relevant to know this topic. So from an historical point of view, how did we get there? Actually, it's a rather long journey. If you want, starting almost 2000 years ago, at least in the western part of the world, which, however, had the true focus between the 18th and the 19th century. The reason being that up to that time, so before the Rinascimental period, there was no true interest here concerning human brain anatomy, because there was no interest in human, if you want. The interest was only on metaphysics. In the 16th century, however, the cultural focus shifts to try to understand how things work, if you want, how things of this world work. And most importantly, technology starts to burn, to start as we know it today, developing methods of fixation of brain, of specimen, which allow a gradual improvement, as you see here in this picture, in the fixation, in the dissection, and of course also in the depiction of white matter anatomy. And I'm not going to detail from Vesalius to the Italian school in Padua and Bologna, up to the Germans, here Meinert and Rai, Peninsula of Rai, who depict in very fine detail the white matter anatomy, I would say, as we know it today, at least from a surgical point of view, which means in a millimetric scale, which is very important. In the 19th century, however, the shift of understanding of the cultural interest of white matter anatomy goes to micro and nanometric scale, and also the connectivity studies move to that focus, so that basically up to that period, and here you have some pioneers, Golgi, Cahal, Marchi, Nisle, we go to a cellular level, which is of course highly relevant from a scientific point of view, but surgical speaking, for our surgical routine, it is less relevant on a concrete phase. The study of the white matter anatomy, again on a millimetric scale, goes further in the 20th century with a well-known professor, Mr. Klingler, a technician of the Basel Institute in Switzerland, who develops a highly effective protocol to prepare specimen, to do dissection, that allows him to make the first photographic atlas of white matter anatomy, a truly nice atlas, with a protocol, as said, that is then further pursued, further studied by Professor Jagergil, who was chairman here in Zurich and is deemed to be the neurosurgeon of the century, but most of all by Professor Ture, who revitalized this technique in the 2000 year. What are the current results now, this short historical premise? These are some dissection from some paper of our group, Professor Ture. I have a pleasure to be one of his pupils under this regards. And you see how nicely we can represent and understand, if you want, the beauty of brain anatomy, but most importantly, probably, the intricate relation between anatomy of the white matter and the cortex. Now, why is this relevant? We come to the first point. It is relevant from an oncologic point of view because, and this was an observation of Professor Jagergil, which is increasingly being confirmed, because brain tumor at the beginning, in most cases, not always, of course, but we can say more than 80% of cases, at the beginning, on a millimetric scale, again, I underline this, have on one end a focal origin, so in one gyrus. On the other end, they have an expansive growth. I underline again on a millimetric level. Here you have a very obvious example of this. You can see this was even an exophytic growing tumor. But what do I want to underline here? That at this part of a tumor stage, the surrounding brain structure are displaced and not infiltrated. Again, millimetric scale. And you can see it pre and post-operatively how the normal brain anatomy comes back to its position. This is obvious in case of exophytic tumor, but it occurs, and maybe it's less obvious, also in non-exophytic tumor. And I will show you some cases just to underline this concept. Here you see a tumor that usually radiologic would call like frontotemporal parietal tumor. But if you see it after surgery, you realize it affected only the superior temporal gyrus. So it was just displacing the surrounding white matter anatomy. The same in this case, which affects in the end only the fusiform gyrus. So it was just expansively displacing the remainder of a normal brain structure. Another case, this is not frontoinsular parietal temporal tumor. This is a fronto-orbital tumor confined to the posterior orbital gyrus. And this is not a parieto-occipital tumor. It is just a precuneal tumor. Some other cases, gladly, this is not a frontoparietal tumor. This is just a inferior frontal gyrus tumor. So I think I'm showing you enough cases, again, another one, to underline a point that I would like to repeat. At the beginning of its evolution, gliomas in most cases are focal and displacing, expansive in their growth. And if you know where they are, and if you know where white matter anatomy and how white matter anatomy is around it, then you can have a better understanding of the pathology. Of course, you can do, if you want, in more complicated cases, DTI. This is particularly helpful if you want, sorry, one step back. On neocortical, so telencephalic lesion, often you don't even need it, DTI, because if you know where the tumor is coming from, then you can predict where the white matter tracts will be. However, in case of deep located tumor, where the space relationship are much more tight, it might be, apologize, it's very cold here, I got a cold. For deep located lesion, it's very useful to know where the white matter tract are dislocated. Here we've seen thalamic lesion. We have a nice paper on this in the series Professor Ture, and also for what concern midbrain lesion. So you see also here, and this is much more evident, white matter tract are not infiltrated by the tumor, again, on a millimetric scale, are just displaced. And the tumor displaces them, and once you remove it, they come back. Now, why is this important? We go to the second point. Once you know where the tumor is, and once you know where the white matter tract and how the white matter tract have been displaced, then you can start planning surgery properly. Now, according to the principle of microneurosurgery, which would be the thought of Professor Jacek and of many of us, the main idea is you might know where is the tumor, you know where are the white matter tracts orientated. Your goal must be to remove only the tumor, avoiding to disrupt any otherwise normal white matter structure or anatomical structure. And this means that you have to exploit natural spaces to reach anywhere you need without any anatomical disruption. So you can go through the interhemispheric fissure, transsylvian fissure, transsulcal, subtemporal if you want, supracerebellar. The main goal is go only to the tumor and take out only the tumor. If I can be more practical, another 3 cases. These 3 cases I always show them because they came in 1 week, all 3 together, 2 years ago. They were all called temporal tumor by the radiologist on call. No critic against radiologists. This is also many neurosurgeon, and I mean, I can understand it makes also sense, but not from a surgical point of view. Because from a surgical point of view, you must be able to distinguish more finely, more in detail these 3 entities, and also to understand much more in detail where are the white matter structure. Because if you call them just temporal, you might be tempted to do the so-called 2 points method. Choose the shortest way and get it out. However, in light of the concept that we show, we can and we should understand that the first one is not just a temporal glioma. It is a submiddle temporal gyrus glioma, and there you can do indeed the shortest way because it's on the surface. The second one, however, is not a temporal glioma. It is a parahippocampal glioma. And if you want to take him out selectively, then you have to come from below, supracerebellar transtentorial, so that you just get only to the target. The third one, same story, is not a temporal glioma. It was an hippocampal glioma of the anterior third, actually. And so transsylvian is most appropriate. So all approaches that go directly to the tumor without disrupting surrounding anatomical structure. And why is like this? Because if we understood where is the tumor and how is the white matter anatomy, then if by this tumor we would do the so-called 2 points method, these are all the white matter structure, the healthy white matter structure that you would disrupt and possibly damage to get there if you go transcortical. If you go transcisternal, because you know where the tumor is, you know where are the white matter tracts, then you will never touch them and possibly you will not damage them. I can show you, of course, also other cases, not only temporal, also frontal. Same story here, all three tumor called just frontal, but in light of what we said, we need to be more accurate to see that the first one is not frontal, it's a cingulate tumor. The second one is not frontal, it's orbitofrontal tumor. This is frontal in the sense it is an inferior frontal gyrus, and this is the exophytic case I showed you before. And in light of our concept, then we would prefer to go interhemispheric for a cingulate tumor because you go directly on the midline, subfrontal to the second glioma so that you go directly to the tumor without touching the convexity. You can go through the convexity for the third one. And of course, for the exophytic glioma in the cilium fissure, you just open the cilium fissure and you take it out. And why? Let me repeat again the concept. I apologize. Because as we said, if we just go to the tumor transcortically, these are all the white matter structure that we would damage. And we believe this makes not necessarily any sense. This concept applies, of course, if white matter tracts are displaced, but also, of course, why not in those cases where white matter tracts are not displaced? Let us take the example of a colloid cyst. It's very popular to go transcortically endoscopically, right? Which it has its advantages. They are undeniable. But if you go endoscopic, in most cases, you will do a kind of a tunnel in the white matter, in 5 centimeters of white matter. And we saw before how many white matter tracts we have in this trajectory. You might want to consider, if you have, again, a white matter tract concept in you, you might consider instead of going maybe transcallosally, because in the end, you need just to displace one white matter tract, so the callosum, and then you are there. And this applies, okay, for colloid cyst, indeed, you might consider that endoscopy is quicker, for sure. You might say, well, if it's just 1 hour, I won't disrupt too much the white matter tracts, this might make sense. But for bigger tumor, and I will show you just quickly some of them, going transcallosally instead of playing 5 hours, 4 hours in the cortex of a person, in my personal opinion, you see also your thalamic lesion, in my personal opinion, should be better discussed. So this for what concerns millimetric level understanding of white matter anatomy. So we see, understand where our white matter tracts on the scale, understand the relation between white matter tract and tumor, and based on that, decide the best surgical approach, which in our opinion should be transcisternal. But of course, we are not only neurosurgeons, we are also neuroscientists like everybody in the audience. And if we are neuroscientists, we know that on a millimetric level, as we said, tumors are focal in most cases and expansive, but we know, of course, that glioma on a micro and nanometric level, they are infiltrative of white matter. They are spreading around what we see in MRI. The main point, which is to be discussed, and it's a matter of a lot of research in several centers, is understand how it spreads on that level. Now, one possibility that had been explored by Professor Liage Guillain, under some regards also confirmed, is that maybe tumor might remain confined to the same area, showing same architecture, cortical architecture, so-called isocortical area, the red ones, 6 layers of cortex, allocortical area, hippocampal, or mesocortical area, insula, parahippocampus, cingulate. Allocortical area, 3 layers, mesocortical somewhere in between 6 and 3. Indeed, if you think hippocampal tumor are most often confined to hippocampus, the same applies to insular glioma. Even when we go to the opercula, you see a shift of them. So this might be reasonable, and this could be justifiable in light of the fact that every topographic area of the brain has a distinct histogenetic identity. So it is an epiphenomenon of a genetic structure. In the end, that glioma might show a preferential pattern is, interesting enough, not well accepted, although we accept this concept for several other illnesses. We accept limbic encephalitis, we accept locotypical bleeding, but for glioma, this is not so well established. We are not claiming that this might be necessarily be like this. It might be the tumor follow white matter, follow the pattern of the veins, of the arteries, of radial glia. But interestingly enough, the idea that anatomy plays a role in the development of glioma is emerging also in the WHO organization classification of tumor. If you remember, in the classification of 2007, that was based only on genetical factor, molecular factor, sorry. But with increasing now, again, of technological development, we started to see appearing topographical anatomical elements. We have a midline glioma, we have diffuse hemispheric and midline glioma, ependymoma have a different prognosis if they are supra or infratentorial. So it is highly likely, and evidence are starting to emerge, that anatomy plays a role in the occurrence of glioma, of pathology, and also the aggressiveness of that. A group in my department, we have a very young and brilliant guy, Kevin Ackeret, has been publishing a lot about this topic, so giving also support to this concept, showing that probably we might distinguish anatomical staging of glioma, which might show a differential aggressiveness, and they do show a differential prognosis according to the distribution along the radial glia pathway. So tumor confined on the gyral element have a more benign prognosis, or better say, a longer life expectancy. Once they get, however, along the path of the radial glia, the prognosis is much worse. Why do I mention this? Why do we need to know the development of tumor on a micrometric level? Because surgical speaking, again, we speak at millimeter. But we might want to know how tumor behave on a micrometric level, because we might think if, maybe I go back here, if we can find a treatment of this. So if we find a tumor at anatomical stage 1, but should we demonstrate that they have then this development along the radial glia, then we might want either to consider pharmacotherapy, of course, or maybe radiation. If you take this tumor out, you might want to irradiate all the so-called histogenetic units. or surgery. Now, you know that in surgery, there is a lot of topic about supramarginal resection. There are some groups that are really hooligans of that. But I believe that the problem is that up to now, we do not really know how we should make this supramarginal resection. Why? Because we still do not know, despite 5-ALA, ultrasound, intraoperative MRI, neuromonitoring, and whatever, we do not really know how the tumor infiltrates at a micrometric level. Just to underline how difficult it is like this, all of you know Dufault, who is one of the supporter of the supramarginal resection. And we remember the seminal paper of 2011 saying that by mapping motion and language, you might do a supramarginal resection in the sense that you go up to this limit, you take out everything that do not respond in terms of language or motion, and that's fine. However, this means removing a lot of brain that might have a role that you do not just know how to measure, right? And this appeared 10 years later when he realized that indeed, beyond avoiding hemiplegia or aphasia, there are also all cognitive aspects that must be considered. And here's the biggest issue. So we have to really think about if the supramarginal resection with the goal of removing tumor on a micrometric scale, if this should be goal of a surgeon or maybe of other discipline. I warmly invite those interested of you in white matter anatomy also to join our yearly course that we have every year in June. And thanks again for the invitation, and I hope it could be somehow interesting for you to hear my points. Thanks a lot for your attention.
Thank you very much, Professor. Now, I have one question in my mind. Can
Please.
you listen to me?
Yeah.
Now, you see a patient of a diffuse brainstem glioma.
Yeah.
And you see that tractography, the tracts are passing through the tumor. But yet the patients are walking. How do you explain that?
So, diffuse, now we are talking morphologically, right? Not histologic. So if we speak about diffuse white matter, diffuse brainstem glioma, we are speaking of a very, very distinctive pathological entity. As we are saying, as I tried to explain before, but it's a huge topic, it would be really interesting to discuss it. It is highly likely, it seems, it appears that depending on anatomical region where the tumor is coming out, you have a different, not only incidence, but also epigenetic and symptoms. So diffuse brainstem glioma, which means almost exclusively pontine, diffuse pontine glioma, are a truly distinctive element. And the reason why it's like this is probably because this tumor originates in most of cases in basis pontis. Now, if you go back to the axial imaging of the basis pontis, you will see how is the anatomy there of the white matter. There you have the superficial and the deep transverse pontine fibers intermingling with pontine nuclei in between. So here is not a matter of displacement because the gray and the white matter is intermingling one in the other. So it's completely differential architecture compared to the other anatomical structure. The pyramidal tract, they are usually posterior to that. First point. So this explains why this happens. You might have a very big tumor, and the tumor, and usually DTI shows a displacement posterior. If you see a displacement anterior or really between the tumor, well, this is somehow more rare. It might still happen, however, but there is the point which should be considered is the following. On one end, if you have also basic MRI sequence really of a high level enough, because this is not always the case, also in everyone experience. The other point is considering that DTI is not reality. DTI is an algorithmic reconstruction of a signal. And there is a lot of algorithm-dependent variability. depending on the algorithm you choose, you have a different DTI result. And you have also a lot of operator dependent. So a true interruption of a pyramidal tract with no neurological deficit, then in my opinion, you have to consider really an artifact of a technique. So that what you see as interrupted is indeed not really interrupted.
Okay, thank you. Dr. Prem Sagar.
Dr. Sera, it was very nice talk. This is Dr. Prem Sagar here.
Thank you.
Are you okay? So now you said you have got a course there on the 16th and 18th June next year.
Yeah.
And this is about the supratentorial fibers, or this is the cerebral fibers?
Also brainstem.
Brainstem.
Also brainstem. We have a wide.
Also brainstem.
It's 3 days.
And now, do you recommend all the young neurosurgeons who want to take up as a career as a neurosurgeon in the neuro-oncology, they should undergo all these courses? And how does it help?
Well, this question I usually answer, it's if I allow myself like a joke, it's like asking if to learn Hindi, I should learn also Hindi alphabet or not.
Okay.
So, I mean, you can learn Hindi on the street, like every language, but to really master it, you must do it. I believe, I don't speak Hindi, I don't want to be arrogant, I apologize, but any language, you need the alphabet, so you need it if you want to do really good. If you want to put yourself on the street to order a pizza, then okay.
No, that's very true. But you know, we learned anatomy while we were doing the medical graduation course. And while at that time, we did not know whether we are going to be a neurosurgeon or not. And we were never concentrated on private tract dissection. And once we take up the neurosurgery or want to become neurosurgeon, this, according to you, this is mandatory. But however, there are not many courses across the world, whether it in India or I think you do it every year or alternate year.
I think it's every year. Then with Professor Nupur Prut in Niemans, I don't want to make publicity with concurrency, but in Niemans we make a course also. Then we are doing also in Taipei, we are doing in Istanbul, and these are courses. Then of course technology can help us. We are trying to doing a lot with videos. We are trying to do a lot also with virtual reality. So this technology can help to spread this knowledge. So we are trying to do our best. For example, the course is available also on Zoom.
Thank you very much.
Thank you.
I now invite our next speaker, Dr. Ali Asghar Moyadi. His topic is optical imaging in glioma with special emphasis on ALA-guided dissections.
Okay, good afternoon again, everyone. Sorry, you have to bear me one more time, but I'm filling in for Dr. Vivek, who is not able to come. And this time I'm going to be talking on the role of optical imaging, specifically ALA-induced fluorescence in malignant gliomas. We had an excellent talk by Dr. Sera here, showing that tumors, infiltrative tumors, even though they may appear to be confined at the microscopic level, show infiltration. And if we agree that the aim of surgery or aim of treatment is to remove all of it, then we have to have some way and means of finding out how to remove them. So let me put it in full. Okay, I can do that. Okay, so I will focus the talk on, there are many different optical imaging techniques. I'll focus on the ALA-induced fluorescence and a little bit about sodium fluorescein, because a disclosure, I don't use sodium fluorescein, and I will talk of my experience with ALA. I showed this slide in my earlier talk that what we want to do is we want to balance outcomes in terms of extent of resection and function. And in order to improve our radicality, one of the techniques we can use is optical imaging. Now, when we say optical imaging, what do we mean? We mean something that helps us change the visualization of the structure and differentiate two structures. And for that, there are two basic things that you need. One is you need some kind of marker, and one you need is an optical visualization device. The markers can be intrinsic. That means there's something already there in the body, in the tumor, in the normal tissue, which you can exploit by certain devices or optical techniques, or you introduce a marker exogenously by some way, and then you pick it up by using an optical device. And the two device and the marker have to be compatible. The optical imaging phenomena that we try and exploit are many, but we will concentrate on the fluorescence, which is basically a mechanism by which, when certain chemical structures, molecules are subjected to a light of a particular wavelength, they get excited. Not everyone does, but some of them do, and they get raised to an excited state and then come back to a stable state, in the process releasing some radiation in the form of light of a different frequency, which is very specific for that particular structure and the combination of stimulated light. So that is what fluorescence is. In the body, there are many fluorophores, and these are some of them endogenous. A lot of the chemicals, the proteins in the body can fluoresce, but the fluorescence levels are not enough to be of clinical use as neurosurgeons for us during surgery. And the other caveat is that the fluorescence has to be visualizable. That means you have to be able to see it, and we have a range of frequencies, a range of wavelengths which we can visualize. The rest goes in the infrared or the ultraviolet. Then you need some special techniques to see that. So therefore, the fluorescence, which is clinically enough and in the visible spectrum, is what we can use with a microscope or to see during surgery. And this is where the two of them, sodium fluorescein and 5-ALA, are effective, because they emit the fluorescence in that visible range. ICG, as you see there, is a little bit larger wavelength in the infrared range, and then you need a specific optical imaging camera to see it. You can't see it with your naked eye. So for any fluorophore to be useful clinically, it has to have certain characteristics. It needs to be very specific for what you see. It has to show you what you want and nothing else. That's important. So if you want to see a tumor and a glioma, you want to have it only in that, nothing else, because you want to differentiate it. And it has to be also practical and efficient. It has to be stable, adequate. It has to have a good yield. It has to be biocompatible, non-toxic. And eventually, of course, the bottom line is it has to be also cheap and not very costly. And as I said, these are the two which are most commonly used, though there have been tens and hundreds of them which have been tried, and some anecdotal evidence. If you were to compare both ALA and sodium fluorescein, I think the ALA is a chemical prodrug and therefore highly, highly specific for glioma cells. And we'll see the mechanism in a minute. Also, it is quite stable. Even fluorescein is stable. But because of its intracellular localization and metabolic mechanism by which it generates the fluorescence, ALA-induced fluorescence becomes highly specific for glioma, unlike sodium fluorescein, which is more based on a leaky blood-brain barrier permeability, and therefore is not very specific for tumor cells. There is a risk with all techniques, even with ALA, of photosensitivity, but practically hardly anything has ever been reported. And in my experience, we've never had a photosensitivity reaction. Also, the convenience of dosage, ALA is given orally, sodium fluorescein has to be given IV. And the evidence which has been generated is in favor of ALA as a intraoperative visualizing tool for gliomas. The biggest limitation and hurdle is the cost. And this is what kind of limits the use of it more liberally in glioma surgery. Now, going back to the basics as why this is ALA is very specific, is that ALA, or aminolevulinic acid, is a very integral part of the human body. It's something synthesized in the body and used as the initial step or the initial raw material for the heme cycle. And this heme is an important protein for not just blood hemoglobin, but many other structural proteins. What happens in the heme cycle is that ALA goes through a series of steps, gets converted to protoporphyrin 9, and then into heme by an enzyme called ferrochelatase. There is usually a negative feedback loop. That means the more heme you produce and enough has been produced for the body, it stops the raw material, ALA production. In glioma cells, ferrochelatase is deficient. That means the production can't go beyond protoporphyrin 9. And in order to overwhelm the negative feedback, you challenge the body with a large amount of exogenous ALA by giving a large dose of the drug. And therefore, you push the entire cycle towards protoporphyrin 9 where it gets stopped. So protoporphyrin 9 accumulates and it accumulates intracellularly, therefore being very specific. And protoporphyrin 9 is fluorescent. It fluoresces with a bright red color when you illuminate it with a blue light. And this is how devices, including microscope, endoscope, or loops that you have, all of them integrate these differential filters in order to stimulate and receive the fluorescent light. Practically, how it works is that you give oral ALA. Patient takes it a few hours, 4 to 6 hours before surgery. It goes through the cycle in the brain. Gliomas would accumulate the protoporphyrin 9, and then when you have the craniotomy open using your microscope, which has fitted with a filter, you have to have that filter, you can visualize the fluorescence. And how it is visualized? It's visualized against a blue-black background as being pink, dark pink, red, orange, depending on the grade. And that helps you remove it and differentiate it from normal or non-infiltrated tumor. In terms of its predictive value, strong fluorescence is highly, highly predictive, almost close to 100% of malignant tumor cells. And the positive predictive value starts reducing as the fluorescence starts becoming fainter, which means as the fluorescence becomes light pink, as you move away from the infiltrating edge, there can be very faint fluorescence and sometimes non-fluorescing areas which may still contain some microscopic tumor cells. And that's partly because visualized fluorescence has a limitation because the eye can discriminate only some amount of color. If you have a highly specific kind of device which picks up fluorescence at the microscopic level or with a spectrometer, you can even pick it up then. But that's not very practical to use during surgery. So from a practical point of view, it shows you infiltrating tumor up to a point and helps you resect beyond grossly abnormal tumor level, tumor boundaries. The necrotic core of the tumor in GBMs will not fluoresce, it's non-viable, but that's usually not a problem because the necrotic core, the tumor core is something you can anyway see. What you're more interested in is the peripheral zone where there can be fluorescing tissue which is not looking abnormal to you with your naked eye or the microscope. Again, one point of view of evidence-based medicine, comparing it to intraoperative MRI and ALA, the sensitivity and specificity of ALA seems to be much better than intraoperative imaging with the MRI, for example, here. And this is because it will show you even microscopic spread. This has been demonstrated as an effective tool in a randomized control trial and probably one of the only randomized control trials ever to be done in neurosurgery, where the gross total resection rate was almost doubled from 36 to 65% when ALA was used as opposed to the control group which used only microscope white light illumination. And not only that, it also subsequently was shown that it removes the tumor volumes beyond the contrast enhancement into the infiltrating zone, which was shown to be prognostically beneficial to the patient. And this has been subsequently, that study was very old, but subsequently we've seen large number of studies showing that removing the T2 flare should now be actually the goal of surgery in glioblastomas, not just the enhancing tumor. It also has use in so-called non-enhancing or intermediate grade gliomas where you want to resect the tumor and you want to ensure that you pick up all the malignant foci because those are the most important to remove so that pathology is correct. Plus you've removed all the most malignant component of the tumor where this can be a marker, even for biopsies. But we should remember that ALA, again, just like the ultrasound I said, is a tool in your hand to be used judiciously, knowing its benefits, knowing its limitations. You could have false positives because of some reaction, inflammation, especially previous surgery. And as I also mentioned, there can be some levels of autofluorescent. Generally, autofluorescence is very, very minimal and it does not cause a problem, but in some cases it may. But again, remember, this is in less than 5%. 95% of the times you will not have false positives. One small component which you should remember, and this is from experience and even experience across literature from other people, is that sometimes when you resect gliomas, you might find faint fluorescent in the ependymal layer if you've opened the ventricle. This does not necessarily mean it is tumor unless it is focal and solid fluorescence. Very diffuse, mild fluorescence is seen Pathological significance is uncertain and you should not be chasing that. Also, one should realize that everything that appears to be non-fluorescence need not be normal tissue. So you have to again be careful. There can be some technical problems with the dye, with its conversion, with the filter. So beware of that. But usually you assume that these technical problems are ruled out, and then you have certain biological false negatives which you need to keep in mind. One is that the low grade, less cellular component of the tumor may not show up, as I mentioned. That's because of the limitation. Sensitivity of visualization of the eye is to a limit. If you want more sensitive techniques, it's not that low-grade gliomas don't have the fluorescence, but you need more sensitive techniques to pick them up, and research is ongoing to see if that can happen. Also, that the fluorescence is a surface phenomenon. You have to have light incident on the surface. If it gets blocked by an overhang, by something on it filled with saline, with a layer of patty, you will not see it. You have to keep those technical nuances in mind. And there, sometimes a combination with a tomographic intraoperative imaging like ultrasound, for example, shows you the depth of tumor that may be left behind and therefore avoid a false negative. Example, in this case, where we thought we removed all the fluorescing tumor, but the ultrasound showed there was non-infiltrating, non-fluorescent infiltrating tumor left behind. So again, a judicious combination of all devices. And also, you should remember that sometimes there can be biological heterogeneity. And this is one of our papers where we found that even in so-called histologically similar grade components in the tumor, there was a variation in the protoporphyrin accumulation. And therefore, you must always use it judiciously. Finally, I'd just like to end by saying that, we always have this cost constraint in our minds, and that's always something that bears on our decision making. And India is a very complex, very, very chaotic country. It's a study in contrast. You have centers and places which can afford almost everything, and some of them which just can't afford anything. And therefore, we have to have a practical approach to anything that we use, not just because it's effective and efficacious in an ideal situation in a clinical trial, but it has to be efficient in our practical day-to-day use. And it has to also translate into a cost-benefit ratio. We use a lot of adjuncts, a lot of costs come into the picture, and the cost of consumable is one important cost in that. And I would say from that perspective, I'm not talking about health technology assessment overall, but from the ALA point of view, I think that's a point of concern because of the cost of the drug, because it's a patented drug and it's available only in one form. But hopefully, and I'm aware that there is research and there is activity going on in the country where you can have an alternative low-cost solution, both for the drug as well as for the visualization device. For example, this head loop mounted one, which we've also been trying to experiment with. And then you have sodium fluorescein, which is a passive fluorophore, very cheap. It has certain limitations in terms of specificity and also in the timing of giving, so that it may cause false positives in certain situations. But because of its low cost nature, I think there should be more systematic research in that so that it can be proven to be effective in gliomas besides other tumors. Eventually, our goal is to balance outcomes, neurological as well as extent of resection. And these are just all one cog in this entire machinery. And that's what functional neuro-oncological surgery is all about. So thank you very much. And with that, I think I will end.
I think it's good presentation. Now, my only worry is the tumor or gliomas which are astrocytoma series and are converted to grade 4, where some part is lower grade, some are high grade. How does there a false positive, false negative in these patients?
So you're right, sir. But it's actually in those cases which this becomes probably more effective, because the higher grade component, which is necrotic, we anyways you don't need anything. You can make it out. But it's in that region around it, which is very low grade, which may look low grade on MRI, but histologically may still be high grade, where more often than not, as we've seen, we think it looks okay on white light. The moment you switch on the filter, you see it red. And there the positive predictive value is very good. Again, provided it's not going into important eloquent structures, you can go ahead and resect it quite safely.
People are doing sodium fluorescein in spite of ALA. So
I know, that's why I also spoke about it, though I don't do it. So it is good. That one slide I showed you actually is a study done somewhere else comparing both ALA and sodium fluorescein and dual fluorophore technique. So its basic advantage is its cost. There are two ways to approach this. Either you study it systematically and show it is equally effective, or you bring down the cost of ALA to match the sodium fluorescein. So I think both strategies are being worked on, and hopefully it will be effective. But based on its biological way of working, it's still not very specific. In sodium fluorescein, for people who've used it, when you do a resection, you do corticectomy, after some time you come back to that area, even if it was normal brain, it will start fluorescing there. So you have to avoid that, or you have to know that you shouldn't come back. Otherwise, you see again yellow green, you'll start resecting even normal. So I think these are the technical challenges and nuances.
thanks. Any comment?
ALA costs around 1 lakh per patient, means one vial is around that much. Whereas sodium fluorescein, I think, costs 100 or maybe less than that. I don't know.
Generally require one.
Generally, it goes by weight, but for our patients in Indian, we don't have patients who are usually overweight. One vial suffices. Yes.
We can go for a supratotal.
So the answer to your first part is yes. The darker it is, the more, more dense and high grade. But it is relative to the person who's seeing. For you, what is dark for me may appear medium. But if I'm only seeing, for me, relative medium dark will mean the same thing, that it's high grade and low grade. So they are right. Combination with ultrasound, yes. Integrated, I'm not sure, but we use it together in cases. So if low grade non-enhancing, I don't use ALA because the benefit is not much. I just use the ultrasound if I need a modality. But high grades, I would combine the two for seeing different reasons, and both of them would be helpful. The ALA would probably be more helpful because of the infiltrating component. But like I showed one case, sometimes it's negative, but you still have very low grade component which may have ALA in it, but you can't see it. You need something more sensitive. And there the ultrasound might help you pick it up.
Wonderful talk,
Thank
Dr.
you.
Ali Asgar. Now I now invite Dr. Rupinder Baveja, Consultant Department of Radiology at RGC IRC, for his next talk.
Good afternoon, Chairperson. And today my topic of the talk is response assessment in neuro-oncology for glioma, what neurosurgeons need to know. I'll discuss about the need for an objective response assessment evaluation for gliomas, then the current standard for the evaluation, that is RANO criteria, then the concept of pseudo progression, pseudo response, and how to differentiate them from true progression and true response, and the role of advanced MRI imaging in all this. Imaging plays a critical role in management of glioma right from the start when we diagnose the glioma. Imaging plays a role in diagnosis. Then once the patient is diagnosed with glioma, the standard approach is step protocol for gliomas. So imaging plays a role in pre-treatment, post-treatment, adjuvant chemotherapy, and the follow-up. During the evaluation, we use the RANO criteria. And here comes the million-dollar question of whether it is its true progression or pseudo progression during the follow-up whenever we see an enhancing lesion. Say the primary treatment fails or the disease progresses, then we have second line treatment either with anti-VEGF immunotherapy. For those criteria, we have modified the RANO to iRANO. But today my topic will be limited to RANO or the pseudo progression and the pseudo response. What is the need for objective criteria evaluation? We need a response, either it is a true response or a false, whether the disease is responding or not, so that we can modify the treatment accordingly. In 2010,
The work group on the response evaluation in neuro-oncology updated these criteria for high-grade gliomas, known as RANO criteria. These are the current standard for assessment of the high-grade gliomas. In RANO, we try to classify the disease either as a complete response, partial response, stable disease, or progressive disease. For a complete response, we need to have disappearance of all the lesions for at least 4 weeks. In the nutshell, with RANO, we have objectively classified the disease response, complete response, partial response, stable disease, or progressive disease. I'll be discussing few of the key concepts of the RANO. The primary concept is whether the disease is measurable or non-measurable. For measurable, we need to have 3 criteria. The disease should be bidimensional, that is, it should be measurable at least in 2 dimensions, more than 10 mm, and it should be visible in 2 axial sections. Any other disease, whether it is a unidimensional or whether the margins are not clearly defined, or it is only a T2 flare hyperintense lesions, all those come under non-measurable disease. So we have just discussed. This is a bidimensional and we have clear-cut margins. So this is a measurable disease. This is a T2 disease, which is showing not clear-cut margins and no enhancement was seen on the contrast images. So this is a non-measurable disease. This is again a well-defined clear-cut margins, but the disease diameter is less than 10 mm in perpendicular diameter. So this is again a non-measurable disease. This is a post-op cavity which is showing enhancement, but this is a without any clear-cut margins. So this again comes under non-measurable disease. RANO criteria is a combined clinical and radiological criteria. Means we need the inputs from the clinicians and we need the input from the imaging to classify the disease response. Say in this, this is the summary chart for the RANO, which shows we need to assess the gadolinium contrast enhancing lesions, we need to assess the T2 flare lesions and new lesions. Along with this information, we need to know whether the patient corticosteroid response is corticosteroids are required in more quantity or less. Then we need to know the clinical status. When we combine all these criteria, we classify the disease either as a complete response, which means there is no gadolinium enhancing lesion left, the T2 or flare lesions, which may not regress completely, but they should be stable or reducing. Then there should be no new lesion, and the corticosteroids are not increasing in dose, and the patient need to have a stable clinical response. If all the criteria are met, then only we would classify the disease as a complete response. For partial response, we need to have more than 50% reduction in the size of tumor. And for stable disease, we classify if the response is less than 50% or less than 25% increase. What we need to remember when we try to measure these lesions is that for the progressive disease, we compare it with the nadir, whatever was the smallest diameter available during the follow-up imaging. So what we need to remember is for progression, if any of the criteria means whether the enhancing lesions increase by more than 25% or there is any increased T2 or flare lesion or any new lesion or the clinical status is worsening. Any of the, if the criteria is met, then the disease is classified as a progressive disease. Few of the practical relevant points for RANO are the post-operative imaging within 48 hours is a must because it helps to differentiate the residual tumor from the post-operative enhancement. See if in this case, this was the imaging obtained after 3 months of study. In this we see a post-operative cavity and an enhancing lesion along its medial margin. When we took up, this can be very confusing, whether this is a residual disease or not. But when we went up and studied the immediate post-operative images, we can very well see there is a infarct along the medial margin, which was a restricted diffusion on ADC. And there was no enhancement in post-operative imaging. So we were able to classify this as a known disease. T2 and flare hyperintense lesions, they have a clinical correlation with either the vasogenic edema or neoplastic infiltration.
we cannot tell in conventional imaging. And to add to the confusion, after the operation, we can have inflammatory changes. So these T2 flare hyperintense lesions are practical confusion in post-treatment evaluation. But if we assess them carefully, like we see two components, either the gray white matter differentiation is preserved or there is an increasing mass effect, then these classify as a brain tumor, not as a treatment response. This was a case where after 5 years of completion, we have radiotherapy hyperintensity induced changes. But if we see carefully, this is the gray-white junction, which appears relatively preserved. So this is an admixed low-grade tumor or radiation injury. After 8 months, we can see no gray-white junction. And second, here we see there is some residual ventricular. However, this shows compression, which signifies the mass effect at this level. So this again is a disease. Reno criteria are to be modified for low-grade gliomas. All the low-grade gliomas, including diffuse astrocytoma or oligodendroglioma, they have an indolent course, but they have a natural history to progress to the high-grade gliomas. So most of these low-grade gliomas, they're not associated with any contrast enhancement, but the T2 flare hyperintensity is seen. So in a typical case, this was a case of 33-year-old with low-grade glioma. At the presentation, we can see that there is only T2 hyperintensity in the posterior parietal region, which is not associated with any sulcal effacement. You can see the sulci within. However, at this time, there was no enhancement associated as well. When we followed up the case after 2 years, we can see there is increased T2 flare enhancement. There is reduction of the gray-white differentiation and loss of the sulcal spaces, which all signify mass effect. Then on the post-contrast images, we see the interval development of enhancement. This again tells that low-grade gliomas is now transformed into a high-grade glioma. Next concept is an important concept of pseudo-progression of the lesions. Pseudo-progression by Reno is defined as any new or increased contrast enhancement that eventually subsides without any therapy. Now, in its definition itself, we see by the definition, there has to be a contrast enhancing lesion. Number two, it has to subside without any therapy. Second, about the definition is the stability of enhancing lesions. So the concept of pseudoprogression is it is subacute treatment related effect which can mimic the tumor progression. For its diagnosis, the diagnosis is usually made retrospectively as far as Reno criteria is concerned. And it is usually in the setting of combined radiotherapy and temozolomide therapy. Pseudoprogression is usually seen within 3 months after completion of chemoradiation. And conventional MRI is limited in distinguishing between progression and pseudoprogression. Say we see this case, this was the 56-year-old who underwent chemoradiation and gross total excision of GBM in left parietal lobe. These are the serial imaging obtained after 1 week. We see this peripherally enhancing cavity. After completion of radiotherapy, we see the enhancement is progressing and there is a fuzzy margin here. After 3 months, there is a progression of mental altered status and with patient presented with right hemiparesis. At this juncture, we are not sure whether this is a true progression or this is a pseudo progression. But after 4 months, the patient improved clinically. So this is here the enhancement has subsided. So in this case, what we get is the pseudo progression is typically diagnosed retrospectively. Means we were not able to diagnose the pseudo progression at this level, but after 4 months, we can say definitely because the patient has clinically improved and the enhancement has regressed. Now we can say that this is a pseudo progression. But what we need to know is at this junction, whether this is a pseudo progression or true progression. These are two similar looking cases which show post-operative cavities with associated T2 flare hyperintensity and enhancing margins. Can anybody guess whether this is a treatment-related change or a tumor progression? Which one is one? So this was a true progression and this was a pseudo progression. The conventional MRI is equivocal in distinguishing the true progression from pseudo progression. So here comes the role of advanced imaging. We have some, when the conventional MRI fails to answer the question, we have few tools, and the two important tools in our armor are MRI perfusion and MR spectroscopy. These are the post-operative cavities which show enhancement along the margins. These are two similar cases again. So with MRI perfusion, we try to assess the relative cerebral blood volume along the margin, which is the area of concern. For this, we need to apply a region of interest in the normal appearing similar white matter on the opposite hemisphere. So for true progression, the high RCBV is due to high vascular density. And for pseudo progression, because there is no neogenesis, so the RCBV will be having low values. So MR perfusion measurements significantly differentiate between true progression and pseudo progression. However, with it, there are certain pitfalls. Like low RCBV can be seen in true progression if the area is more necrotic or edematous. And the pseudo progression may show high RCBV if there are associated aneurysms, telangiectasia, or vascular elongation of epithelial proliferation. Similarly, the second tool we have is of MR spectroscopy. Here we assess the various metabolites, primarily Na and the choline ratio, and the lipid lactate peak. For recurrent tumors, they exhibit high ratio of choline to creatinine and choline to NNA, N-acetyl aspartate. We take a cutoff value of 1.8. And because of the radiation necrosis is associated with necrosis, so it will cause increased lactate to lipid peak, which has a cutoff of 0.75. If both the criteria are met, say we have a tumor which shows increased choline to creatinine ratio of more than 1.8 and is associated with lipid lactate peak less than 0.75, this will favor a true tumor versus necrosis. However, MR spectroscopy has its limitations as because it is a very sensitive technique. I'll just wind off in 2 minutes. Close to ventricular skull, the lesions show limited efficacy and surgical clips can cause distortion. So to summary, we have many predictors for the evaluation of true progression versus pseudo progression, but none of the predictor in itself is highly sensitive or specific enough to show us the results. So in practical way, for a true progression, we have a postoperative imaging, and with any enhancing lesion, we combine both the techniques, like elevated choline and Na ratio and high RCBV, in this case, took us to the diagnosis of true progression. Pseudo response is any decrease in treatment enhancement after starting of the treatment that is not reflective of the disease burden. Again, here in pseudo response, because it is due to transient decrease in permeability, so we can see the reduction in enhancement, but it is not true progression, true response. Like this is the case immediately after starting anti-VEGF therapy, the enhancement reduced. However, the mass effect on T2 as well as the mass effect on T2 kept on increasing. So this was classified as a pseudo response. So the takeaway from my talk are the response evaluation in glioma is objective, not subjective, and the RANO criteria are the current standard of response evaluation, and advanced MRI imaging, perfusion, and spectroscopy can help us differentiate between pseudo progression versus true progression and pseudo response versus true response. Thank you.
Thank you, Dr. Rupinder sir. Any question? Okay.
Criteria or just we have to make one at random? No, we don't have to make it at a random place. We have to make the ROI at the site of enhancement. Say if it is a postoperative cavity and it is showing enhancement, then the ROI is at the site of margin of the cavity.
So any single ROI is enough?
No, never a single ROI is never enough. But even if a single measurement is into the high grade, then we take it as high grade.
But what sometimes happens is the other area, if we feel there is some enhancement, it comes less. So it's
That's what I'm talking. Say we take 10 ROIs and only 2 are showing the increased RCBV.
So
So
still
we
we
go
have to
with
take
the
it as
higher
progression.
value. We go with the higher value.
Till we take it as progression.
Yes. But you must remember one thing, these RCBV and MR spectroscopy, they are not specific and sensitive in themselves. It is to be combined with the clinical information as well as the conventional MRI imaging.
Thank you.
One question. One.
Diffusion.
Contrast MR and diffusion study, how confidently can you say it is a true or a pseudo progression?
Sir, say if we have to classify which is better, then MRI perfusion, then MRI diffusion, then conventional imaging, and then MR spectroscopy.
Dr. Satnam.
My question is to both to Dr. Ali and Dr. Rupinder. So what is the consensus? Should we go ahead and remove all T2, the flare in hyperintense area around the tumor, or?
Sir, all the T2 flare hyperintense area is not tumor number 1. It is edema. It is number 2, the tumor itself. And number 3, the inflammatory changes associated with the treatment.
But what is your opinion, Dr. Ali? Dr. Ali, hi. My question. So should we remove all flare hyperintense area around the tumor, or what is your opinion? GBM, yeah, other grade tumors, not GBM only.
Low grades, all the T2 flare is to be assumed to be tumor.
In low grade?
In low grades. I mean, you don't expect much edema there. So whatever is T2 flare, you assume is tumor. And if it is not conflicting with eloquent areas, that should be the aim.
But
in glioblastomas, traditionally, it's only the contrast enhancing. But now we know that the infiltrating tumor is there beyond it, and that corresponds to T2 flare. But how much of it is only infiltrating, how much edema, and where to stop is still a big question mark. But the more you can remove.
Even with low grade tumors, if we remove the tumor, we have seen that T2 flare, that flare hyperintense stays stable for several years, maybe.
It may stay. I agree. It may stay. Depends on the grade and now with molecular. So if you have an oligo grade 2, 1p19q co-deleted, and you do a radical resection with some residual flare, you might choose to observe and it may remain stable. But if it has some molecular features which are high grade, it is likely to progress or transform at some point of time. So those are the cases which you would treat with adjuvant even upfront. If you can resect everything, you have two advantages. Once you'll be getting adequate sampling and pick up the highest grade component if there was anywhere. And second, it has a prognostic benefit in itself.
Okay, thank you.
I think we close the session. Thank you
Thank
very
you,
much,
sir.
Dr. Uppal. Thank you.
Thank you, chairs, and all the speakers for the session. Thank you very much. Before we break for lunch, let's have a quick interactive panel discussion. It will be moderated by Dr. Rajat. He's Senior Consultant, Department of Medical Oncology at RGCIRC. The theme is brain metastasis.
In the meantime, we can just invite our panelists, and I thank Dr. Prem Sagar for allowing me to moderate this session. And this is a panel discussion on the management of brain metastasis, and our panelists include our neurosurgeon, Dr. Lakshya Raheja, our radiation oncologist, Dr. Jaskaran Sethi, our medical oncologist, Dr. Varun Goel, our pathologist, Dr. Garima Durga, and our radiologist, Dr. Mahindra KM. So we are the 5-6 people here who are just standing in between you and the lunch. So we'll be very, very quick. But still, we would like to drive in some basic points on the management of brain metastasis. So the need of the hour is basically brain metastasis patients are a unique cohort of patients. Definitely requires a multidisciplinary discussion of all the patients in our tumor board. And patients with brain metastasis generally are underrepresented in the various trials. But nowadays, definitely they are getting a good representations, and we definitely need some typically brain metastasis specific clinical trials also in the near future. So why it is unique? Because there is a divergent therapeutic response between the intracranial and the extracranial sites. We as oncologists are very comfortable in treating the extracranial sites, but when it comes to intracranial, there is definitely a divergence. And that is because of unreliable penetration of most of the traditional therapeutic agents in brain. So definitely the prognosis of any brain mets patients depends on the number of brain mets, the volume of brain mets, location, symptomatic, yes or no, performance status. How is the baseline performance status? Any extracranial, the bulk of extracranial disease? Are there any systemic therapy options? And these is a lot of factors which go into the actual prognosis of a patient with brain metastasis. And that is why we require the collaborative efforts of our neurosurgeon, radiation oncologist, medical oncologist, pathologist, and radiologist, and palliative care specialist to kind of hold the patient together. So we'll be discussing case number 1, which is a 52-year-old female diagnosed as CA right breast in December 2017. And it was a IDC grade 3, ER/PR negative and HER2/neu 3+. So this is the basic histopathological diagnosis. And the PET scan done at initial diagnosis showed a right breast lesion with axillary lymph nodes and multiple bony metastasis. So she took 6 cycles of chemotherapy and targeted therapy with Herceptin till April 2018. And bisphosphonates were also given. And subsequently, she was started on 3-weekly maintenance trastuzumab from May 2018. So till that point, the treatment is actually a no-brainer. We always start it this way only. So in August 2018, patient started complaining of vague headaches, intermittent, and with no major neurological deficit. And a PET scan was routinely, we do it, and it was done, and it picked up a non-FDG avid breast lesion, 1.2 into 1 centimeter, and with sclerotic bone mets. So that means extracranial disease is generally well controlled, and new FDG avid brain lesion was seen. So this is the brain MRI, and Dr. Mahindra, if you're there, we can just have a quick comment as to what we can see on the MR brain contrast.
Yeah, we are seeing a focal lesion, peripherally enhancing lesion seen in the right parietal region with a mild edema. Perlesion edema is there. Appears to be metastasis.
So some frequently asked questions which we have in our mind is, these are the questions actually. Generally patients come from periphery, they get a CT brain, and then they come to us. Should we rely on the CT brain? Is MR better, CT better? Comments?
Definitely the post-contrast MRI scan, they are far better than the CT and gives exactly the outline and number of lesions and characteristic of lesion. Definitely we should go for an MRI.
And is spectroscopy necessary in all cases or in some cases? How do you decide?
Usually the spectroscopy will not give the ultimate diagnosis, but in some cases it helps to give some clue whether the choline peak is there or not. Spectroscopy is an adjunct to the usually the perfusion MR sequences.
And Dr. Jaskaran, if you're the radiation oncologist, you would be planning the patient subsequently. Any specialized MR sequences you would like, or anything you would like to ask your MR colleague to report better or something?
Yeah, for us, if we are going to plan a stereotactic radiation, then we need a thin cut MRI, number 1. Number 2, we would need the MRI in a neutral head position. Because usually the MRIs that we get from outside are in an oblique position and they are not in a neutral position. So for us to plan a stereotaxy, we need a neutral head position MRIs. Sequences are usually well covered.
Yes. So now our IHC profile read at ER/PR negative and HER2/neu 3+. So Dr. Garima, as our pathologist, does the IHC profile of the tumor decide the incidence and prognosis of breast cancer with brain mets?
Yeah, so
tumors which are triple negative or HER2 3+ positive, they have more propensity to cause brain metastasis in
Correct.
cases of breast.
Correct, correct. So as correctly pointed out, TNBCs and HER2/neu positives have a higher propensity for brain mets. Out of that, HER2/neu is the highest out of all the subtypes of breast cancer. And also it is one of the best managed when it comes to the brain mets management. So now let us come to the treatment options. We have one single MET in the brain. So these are the options in front of us: upfront surgery followed by RT, radiation, surgery, and or change of systemic therapy. So Dr. Lakshay, as a neurosurgeon, what would you like to kind of offer our patient?
I think I think considering the superficial location of and solitary metastasis, I think best option is to go for surgery upfront followed by cavitary radiation, and then followed by subsequent radiological follow-up in this patient.
And Dr. Jaskaran, surgery or radiation? We are in a tumor board right now.
Why subject the person to double therapy? Let's just do a good, nice stereotactic radiosurgery, in fact, not a radiotherapy. Also, it looks to be a small tumor amenable for a high dose stereotactic radiosurgery.
So this particular patient was kind of asymptomatic, means not very symptomatic, no focal neurological deficit. There was not much of a perilesional edema, no midline shift. I take both your points. Surgery upfront followed by post-cavitary, yes. But I think so preferably, I think so SRS in this case. Dr. Varun, you would like to add anything?
If this case is not upfront metastatic in the form of bony mets and all, if it is localized disease and there is single brain met, maybe we will go for surgery followed by radiation. But here it is already systemic disease, so it would be better just for SBRT and followed by maybe change of systemic therapy.
Correct. Point well taken. Our patient is a de novo metastatic disease. So here we can opt for a lesser modality of treatment as of now, and we can go ahead with an SRS followed by further follow-up of our patient. This patient received radiation therapy, 10 fractions in 3 alternate days in August 2018. And trastuzumab was continued because that was the only site of progression, and trastuzumab was continued. Dr. Varun, you would like to change any treatment right now, or we can just continue on trastuzumab? This was one single met which has been taken care of.
Yes, this case was in 2018. That time, maybe this approach is okay. But now, with the availability of newer drugs like TDXT and lapatinib, we have with us in generic form also. So I would like to change the systemic therapy. If patient, there is no contraindication, if she afford, then TDXT will be the better option here because of the good CNS like response of this drug. Otherwise, at least change to lapatinib. Because Herceptin CNS penetration is not good. That's why patient progress in CNS. So if we continue same, in any case, she is going to progress CNS again.
Here. But here, I think so, because we at that time thought that the only single site of brain metastasis has been taken care of. So we continued on Herceptin. So these are the pros and cons in favor of upfront surgery versus upfront SRS. We have already discussed. So definitely, once that brain mets has been taken care of, so what follow-up imaging do we, and in what frequency do we order for? Dr. Mahendra, what should be the ideal follow-up of our patient?
Actually, like after 2 to 3 months, 3 months would be the ideal one, and we can have the contrast MRI brain with perfusion MRI. That would be the perfusion MRI has to be done to differentiate whether it's radiation necrosis or a recurrence. So we should keep it in mind that contrast MRI that with the thin cuts, that is, and perfusion MRI.
Perfusion in every follow-up, or if
The first follow-up would be the.
Okay. So this was August 2018. Now, after about 1.5 years, in December 2019, patient had another lesion in the contralateral side, left posterior temporal area, and the PET scan did not show any extracranial disease at that time also. So now, again, the question open to our neurosurgeon and radiation oncologist. This is a contralateral lesion. Dr. Jaskaran, SRS versus WBRT, And the pros and cons of each.
You see, the systemic disease is well controlled. I don't think so there's any role of WBRT in today's world, except very few indications. So I would again go for an SRS, again a localized small lesion, and should receive SRS.
Dr. Lakshay, any अभी surgery करना चाहेंगे कि means we can just.
Well, I mean, surgery is feasible, but yes, again, as we discussed before this, that SRS will allow for a non-invasive line of therapy, then yeah, I think that way SRS can be considered.
So actually, here also the patient was asymptomatic. We followed it up on that 3-monthly MRs. We got this meds. So I think so. Yes, this patient, as planned, received the radiation therapy by SRT technique, 24 gray single fraction to that area. So this
just sir one add, like if we are going to change systemic treatment now, at least because we have given trastuzumab at that time only.
So
Even
this is the next change of systemic therapy now.
no, I just want to say that why any local treatment? Patient is asymptomatic. Why again SRS? Just change treatment.
Just change treatment. Okay.
And
So-
on further progression, because we have lapatinib with with some CNS activity, and otherwise TDXT with the good CNS activity. Patient is asymptomatic, very small lesion. Why again and again SRS? If patient becomes symptomatic later,
So
then
we can serially follow up the patient, but we have to be very confident of our systemic therapy that it should penetrate the brain. 2018-19, we did not have agents like TDXT. So we definitely changed the systemic therapy simultaneous to administration of SRT. So lapatinib was started. So this is 2019. So Dr. Jaskar?
I have is there any randomized data available that you should not do SRS and change of chemotherapy is giving the same results? I don't think so.
yes, sir. So there is no data because, as sir has said, that these drugs are new. So with further maturation data, maybe we will get hold of those data. But because as we see in other malignancy like lung cancer, there is good TKI available. Now these we are talking about lapatinib, but tucatinib is there. If we give tucatinib, that is very, very good CNS penetrability. So and with the less side effect if we compare with the lapatinib. So because we, in any case, it may be that further on follow-up, she may require, but maybe she will not require.
Yeah, lung is a different ballgame altogether. We got good molecular targets, we got good drugs targeting those things. But I think in breast so far, we don't have a data that asymptomatic brain mets should be left alone for observation or change of chemotherapy.
No, it is definitely our systemic therapy options are strengthening. So in the coming 1 or 2 slides, we'll definitely show that tucatinib data which is there. So Dr. Jaskaran, definitely you've told that whole brain radiation therapy generally is to be avoided, and definitely hippocampal sparing whole brain radiation may be done if we have to opt for WBRT. My specific question is, ki suppose there are 4 METs, 6 METs, 8 METs, 10 METs, can you target all via SBRT? I just heard one of our other speakers, he told that even 30 to 40 METs, Dr. Deepak Agarwal was saying that we can target by a single session of SBRT. So what is your criteria for selecting?
You see, I think rather than the number of lesions, it's the volume of the disease. So up to 15 cc disease, I think even in multiples can be targeted well. When it comes to numbers, the data is very robust for up to 10. But beyond 10, yes, it has to be an individualized decision. It cannot be a one size fits all. It will be an individualized decision. But I think volume is very important. A single large, big lesion is also not amenable for SRS, whereas multiple small lesions can undergo SRS.
So the volume of the disease, the cumulative volume of the disease is what matters here. And the numbers generally do not matter as long as they are in the same SBRT plane. So now we were in 2019. In 2022, the third brain recurrence, marginal recurrence in the left temporoparietal area, 1.5 into 1 centimeter. My regrets that we don't have the MR plates of this time. And PET scan again showing a very controlled extracranial disease. So this is the third recurrence, marginal recurrence. So, Dr. Lakshay, now would you like to go ahead, or patient is still not very symptomatic? She has some vague headaches, but not very symptomatic for her.
I mean, at this point, considering that SRS has already been instituted, we don't have, I mean, directly for local therapy, the best way to go about it would be to go for resection at this point.
Correct.
If there is a recurrence.
Correct. And Dr. Mahindra, at this point of time, I think so your perfusion studies might tell us more about probably
Yes, sir.
radiation necrosis versus.
Definitely. Actually, if you do a perfusion MRI, the DSC kind of MRI, dynamic susceptibility imaging, that is a contrast, using the contrast. So if the cutoff of 2.1, that has got a sensitivity of more sensitive to 70%, and the specificity is very highest. It's more than 85 to 90%. That differentiates whether it's a tumor recurrence or is a radiation necrosis.
Correct. We did the this patient received radiation because it was a marginal recurrence. She received radiation for the third time in June 2022, 5 gray in 5 fractions. And now this is the fourth recurrence now. Left posterior parietal area, March 2023, and this is the MR reading from that time. And at this time, the patient was quite symptomatic with marked edema and a midline shift of approximately 10 millimeter. So this is, as Dr. Mahindra has pointed out, we definitely need a perfusion imaging to differentiate between radiation necrosis versus recurrence, and with a cutoff value of 2.1 or more. And now, Dr. Lakshay, because this patient is now quite symptomatic, has a midline shift, I think so, would we go ahead and do a surgery right now?
Definitely. Definitely.
Okay. Definitely. So this patient did undergo a tumor decompression surgery in March 2023, and the histopathology of this report read as a metastatic carcinoma with ERPR negative and HER2/neu 3+ with a Ki67 of 30%. So this patient all this while has been on lapatinib, but has suffered one more means isolated brain recurrence. So Dr. Garima, some comments on how do you kind of pinpoint to the diagnosis of breast?
Actually, it was quite a straightforward case because we already had a history of CA breast, and on histopathology, it was an epithelial gland forming, epithelial looking gland forming tumor. So because of the history, we just put single IHC marker GATA3 which for breast erosion, and it was positive. And we also did ERPR and HER2/neu on this case, and it was similar to the primary breast tumor. It was ERPR negative and HER2/neu 3+ positive.
So do we see a discordance in expression of the hormonal and the HER2/neu profile between the primary tumor and the brain mets?
Yeah, so in the metachronous setting, in the literature as well as in our hospital data, we see about up to 5% change in the profile. The HER2/neu negative ones become positive, and ER positive become
Definitely. So definitely, this is one paper which I pulled out. It was a systematic meta-analysis which showed that 40% of the brain mets exhibit receptor discordance from the primary tumors. 12% had discordance in this series. 12% had discordance in the HER2/neu, and ERPR loss and HER2/neu gain were the most common observations which were seen. So March 2024, patient started again showing some lesion, but patient was asymptomatic. We chose to follow up on the patient. And in October 2024, again, she presented to our center with a severe headache and altered sensorium. This is the perfusion scan on the left panel, and this is the tumor on the right panel. Dr. Mahindra, any? We have already given 3 radiation courses. Patient was essentially asymptomatic in March 2024. She was pretty.
No, maybe they have continued lapatinib.
Yeah, we continued lapatinib. Systemic therapy was going on. Yes. Definitely, there is a failure. There is a failure of systemic therapy, but patient was asymptomatic. No, maybe not, maybe not. It is a logic. We
But
can.
sir, that time, as sir already have told that TDXT was not available with us. Tucatinib still is not available with us. Only Lapatinib is available. So
Okay, yes. So this yes, it is a very correct opinion that we can operate at this stage also, even before the patient becomes symptomatic. Yes. Correct, correct, correct. So, however, in this patient, the patient actually was quite fed up overall over the entire work, even though her prognosis was still better than the other patients because she did not have too much of extracranial disease. So in October, definitely she had a symptomatic progression, and this was the lesion. It was involving the sinuses also. And Dr. Lakshya, second surgery now because patient is symptomatic.
Yeah, considering that we've already tried SRS a few times, and there is still recurrence over there. It's now crossing the tentorium, going into the infratentorial compartment. Also, there's I think a better approach is to directly excise it. Obviously, there is a safety concern with respect to the sinus being involved, or at least just yes.
Because it has involved the sinuses. Yes. Yes. Okay. So definitely surgery was done, and it has been just recently done last month. And the histopathology is again showing the same profile, ERPR negative, HER2/neu3+. So it's one of the unique patients who is only showing intracranial progression and no extracranial progression as of date. And at this point of time, we were still on Lapatinib because we were at a dearth of giving any other agent. Now we may have Tucatinib and or TDXT as our armamentarium. And now, if suppose, Dr. Jaskaran, just one question. If suppose our neurosurgeons have been able to decompress to the maximum, but there is still some area which is left behind, would you still consider the patient for radiation therapy? Third time in that area.
Some time has elapsed from the last, but I think overall the normal brain has received quite a significant dose, should have received by this time. So I am not very sure how much addition of radiotherapy here would help, although the only possibility now that I see is either because the volume of the disease is quite big. So SRS is actually what is recommended post, but I would not do that. Maybe some limited field, low fractionation, but I'm not very sure. I would rather not go in, to be very honest.
Rather observe. And Dr. Varun, I think so. We have now got TDXT. Would you like to target the patient with TDXT?
yes, sir. She had already progressed 2 times on Lapatinib. We have continued because of the systemic control, but still we should give some agent which with the more CNS response.
Correct. So we have got Tucatinib, which can be combined with Capecitinib and Herceptin. So this is one, the HER2 CLIMB trial, very good CNS penetration of the drug, and the CNS progression-free survival definitely improves quite a lot over not giving Tucatinib, and the overall survival also is better. Trastuzumab deruxtecan is also there with us. It is definitely an antibody drug conjugate of trastuzumab, and in the Destiny Breast 03 trial, in the CNS only patients, it definitely showed an improvement in the progression-free survival probability of patients with upfront brain metastasis. Again, proving the fact that nowadays our systemic therapies are definitely getting better, and we have got better CNS penetration and better overall long-term control of our disease. So I think so. Should we kind of do away with the second case, or?
I think this case gives us a little bit of perspective on SRS, especially for a surface tumor.
This case,
yeah. This case in particular, because
Mm.
we've done it twice and then it recurred, became
Yeah.
a difficult resection. Is it better to go for resection, do tumor debulking, and then give cavitary RT, or do RT twice and then have something like? I mean, obviously, this is one of rare cases. I mean,
So that is
But,
definitely a debate, because what you're trying to say is that it has
Upfront.
recurred twice, thrice, even after giving SRS.
In an amenable area, then surgery should be preferred over SRS, let's say. I mean, considering we've already given it to the other side.
But I think recurrence is and different location, not same location.
Yes, yeah. No. I mean, in the second location, it's recurred a couple of times.
3 times.
3 times, yes.
3 times, 3 times. So all points well taken, and definitely patient is the king here, and because all the treatment options should be kept in front of the patient. And definitely these are unique patients, and SRS SBRT is definitely nowadays preferred over WBRT. Surgery is definitely the preferred modality for single symptomatic brain metastasis. And we have a plethora of brain targeted therapies which can be judiciously combined with local modality therapies. And I thank all my esteemed panelists and our audience for a patient hearing. Thank you very much.
Thank you, Dr. Rajat, and I thank all the panelists. We break for lunch, and please be back by 2:15 for the next session.
Every year, more than 10 million individuals worldwide succumb to cancer. It is critical for cancer patients to have prompt diagnosis and treatment, to be in a healthy and cheerful environment, and to experience love and compassion from caregivers. No matter how complex the malignancy, the Rajiv Gandhi Cancer Institute and Research Center understands cancer better than anybody else. And most importantly, years of expertise in fostering a culture of caring to touch lives and spread smiles. Since its inception in 1996, the Rajiv Gandhi Cancer Institute and Research Center has committed itself to provide exceptional cancer care for more than 25 years. It is one of Asia's foremost cancer research and treatment centers. The institute is the outcome of a dream and the persistent work of the founding members to make it a reality. This is RGCI's incredible story.
RGCI is truly a remarkable story of how, within a short period of 25 years, an NGO with very little funds has developed into a premier cancer hospital of world class. Our medical fraternity is the backbone and our greatest strength. They collectively hold an unparalleled depth of experience and expertise, which is as good as the best in the world. RGCI has done a tremendous amount of work over the last 25 years in the areas of prevention, in the areas of research, and in terms of treatment. And a lot of very good work is going on today. I'm confident that in India, RGCI will be able to help to eradicate cancer. This ensures continuance of our core values of staying a not-for-profit institution which runs on the principles of democracy and meritocracy.
Rajiv Gandhi Cancer Institute has come a long way since it was set up in 1996. The team of our doctors, the nurses and the paramedics have really dedicated so much in the last 25 years that today we are counted as one of the best cancer care hospitals in the country. We understand the nitty-gritty of the cancer and we follow the international guidelines for the treatment of the cancer. We are the one which can take care of any type of cancer and we can treat them in a much better way than those who are not a dedicated cancer center.
The institute provides highly specialized tertiary care services in medical, surgical and radiation oncology, which are integrated into dedicated site-specific teams. The tumor board serves as a second opinion clinic for cases that are more critical than others. And the institute uses an organ-specific multidisciplinary approach to cancer diagnosis and treatment. There are hidden costs in the usual modern corporate hospital. RGCI has hidden compassion. With a current capacity of 500 plus beds, spread across nearly 2 lakh square feet, RGCI is committed to bringing the benefits of cutting-edge technology to its patients such as whole-body robotic surgery, tomotherapy, cyber knife, true beam, digital PET CT, next-generation sequencing, molecular laboratory for gene profiling, biorepository for clinical and research purposes, and dedicated cath lab. Today, we recall 25 years of its journey and other academic and research activities. RGCI organizes its annual international conference, RGCon, every year, where the eminent faculty from all over the world share their views and deliver lectures to focus new advancement and updates in the field of oncology. The institute also has a dedicated pediatric hematology oncology department, providing excellent cancer treatment in child-friendly environment. The bone marrow transplant unit started at RGCI in 2001. Now RGCI has a 18-bedded full-fledged BMT unit with the world-renowned clinicians performing around 125 all kind of transplants in a year, including half-match transplant and sibling transplant. Following the Institute's multi-modal approach, the laboratory not only offers virtually the entire spectrum of investigations required for cancer patients, but the tests are also performed in-house, including molecular biology, immune histochemistry, microbiology and biochemistry. The Institute is involved in many clinical trials by testing drugs and devices which provide a scientific base for advising and treating patients for better outcomes. The Department of Philanthropic Services of RGCI is responsible for promoting, coordinating and supervising humanitarian initiatives. Various patient welfare programs are being launched to ensure that no patient is refused care due to a lack of funding.
UVCAN is delighted to have partnered with RGCI since 2019 to provide financial aid for the cancer treatment of underprivileged children who are facing difficulty in continuing their treatment due to financial constraints. Through UVCAN Cancer Fund, we will continue to work with you to save many more lives.
A dedicated preventive oncology department started in 2008 to focus on spreading cancer awareness amongst the general public and conducting cancer screening camps in underprivileged sections of society. Home care is offered by doctors and skilled nurses at RGCI to patients who are unable to go to the hospital for medical reasons throughout their treatment.
My mother was detected with last stage cancer, 4th stage, in the month of September 20. It was in consultation with the medical oncology team at RGCI, it was decided by the family to not put her through this regimen, and a call was taken that we would be under the care of they have a team at RGCI who look after the patients. They played an important role and they were a real good support in times of crisis for the family. That is all I would like to say, and a big thank you to the home care team of RGCI.
Another RGCI RC center is located in Niti Bagh, South Delhi, a sophisticated cancer center with 30 beds that provides medical and surgical oncology treatment to its patients. The Institute has emerged as the pinnacle of care and service, with an outstanding and continuous track record of achieving outcomes. We not only give the greatest care, but we also go above and beyond to exemplify caregiving by placing the patient at the center of all we do. We are not only treating an illness, we are also healing a person, and that person is you. Equipment. The highly talented team does not overlook the importance of a personalized connection. The Institute not only serves Indian patients, but we also take great delight in serving patients from all SAARC nations and others. A highly talented team of medical oncologists are available at RGCI. The Institute has evolved in organ-based practice with super specialty clinics. The hospital's medical oncology department is additionally supported by a contemporary and highly efficient NABL-approved blood bank that provides blood and blood components around the clock. The Institute is actively involved in research and academic activities, making it a preferred location for the DNB program and other academic and research activities. RGCI organizes its annual international conference, RGCon, every year, where the eminent faculty from all over the world share their views and deliver lectures to focus new advancement and updates in the field of oncology. The Institute also has a dedicated pediatric hematology oncology department, providing excellent cancer treatment in child-friendly environment. The bone marrow transplant unit started at RGCI in 2001 Now RGCI has a 18-bedded full-fledged BMT unit with the world-renowned clinicians performing around 125 all kind of transplants in a year, including half-match transplant and sibling transplant. Following the Institute's multi-model approach, the laboratory not only offers virtually the entire spectrum of investigations required for cancer patients, but the tests are also performed in-house, including molecular biology, immune histochemistry, microbiology and biochemistry. The Institute is involved in many clinical trials by testing drugs and devices which provide
A very good
a
afternoon.
scientific base for
A very good afternoon, all. I, Dyuti Suri, welcome here. Let's start with a session on medical oncology and pathology. I would like to invite our respected chairperson, Dr. Irfan Ahmed, Consultant Radiation Oncology, RGCI-RC, Dr. Sumit Goyal, Senior Consultant, Medical Oncology, RGCI-RC, Dr. Sunil, Senior Consultant, Histopathology, RGCI-RC, and Dr. Gurudat Gupta to come on the stage.
Good afternoon, everybody. So this is a postprandial session. We are starting with the adult glioma, a neuropathologist approach to integrated diagnosis. This lecture is by Dr. M.C. Sharma, who is a professor in neuropathology department of All India Institute of Medical Sciences, Delhi. Sir, over to you.
I'm thankful to the organizer for giving me this opportunity to talk on approach to adult diffuse gliomas. In 2016, WHO revised edition, they integrated the layered diagnosis. And the final diagnosis, they say that it should be based on the histology, grading, molecular markers, and genetic studies. In brain, it is very useful in the sense that in the diagnosis, in the prognosis, in the prediction, what treatment should be given. In 2021, they revised the WHO classification, and this was a long list in the 2016, but now only there are three groups. One is the astrocytoma, which is IDH mutant, oligodendroglioma, which is IDH mutant and 1p19q co-deletion, and whatever is the wild type, IDH wild type, they are glioblastoma. So only the three groups, and further they are divided into the childhood type, adult type, and circumscribed. Circumscribed are the one which has relatively less infiltrative, grossly, but microscopically they may show infiltration. And surgery is the treatment. They say that this is a the term is used the pediatric type and adult type. The reason is that most of the tumor in the adult type, they occur in the adult age, but there is no tight boundaries. Even the 16-year male, he has a right temporoparietal lesion. It was IDH positive. So this is a more like a child or the adolescent, young adolescent, but this is IDH positive, which according to the WHO usually are in the adult age. So that is the reason they have used the adult type and pediatric type. And the other reason is that molecular pathways are different. In adult, it is the IDH, the P53, TDNK2 co-deletions, this is deletions. In children, it is the MAP kinase pathway. And in infantile, all the molecular changes which occur in the lung adenocarcinoma, ALK, MET, NTRK, and the prognosis is different. In grade 4 tumor in infantile is not like the grade 4 tumor in the adult glioblastoma. The second is the targetable. Many of these tumors are, the targeted therapies are available. So that is the another reason to characterize these tumor properly. The other difference is in childhood, the tumor from low grade to high grade transition is not seen usually. In adult, the grade 2 may become grade 4 over the time or with the therapy. This is the Vaishali will speak on this low grade molecule, this glioma in children. They are MAP kinase pathways mostly involved. But in adult, it is supposed that it is people think that the all tumor arise from the precursor cells, and the IDH is a mutation from the very initial. It is the initiating mutation. If there is IDH mutant and 1p19 code deleted on then it is oligodendroglioma. If it is IDH positive, P53 mutation or ATRX mutations are there, it is a IDH mutant glioma, which may be grade 2, grade 3, grade 4. In addition, one has to do the FISH for CDNK. If there is a deletion of this homozygous, then it is grade 4, irrespective of the histology. For example, it is a grade 2, but IDH positive, it shows deletion of this CDNK2, it becomes grade 4. And IDH wild type are glioblastoma grade 4. The other mutations which are commonly seen in the gliomas are EGFR amplification, third mutations, chromosome 7 or gain and 10 loss combined, not in isolation. For example, this is a grade 2 tumor. This 33-year male, very cellularity is very low, no mitosis, and this can be grade 2 or grade 3 or grade 4, depending upon the WHO has given this algorithm. Some are essential features for the diagnosis, some are desirable. And in the desirable, some places it is the methylation is essential. It depends upon the tumor type. If you do these antibodies are available against these P53, IDH, which are very good surrogate marker for molecular. If it IDH positive, there's low cellularity, ATR is lost, P53 is positive. This is a grade 2 tumor or grade 4, depending upon the CDNK deletion. If it is absent, it is a grade 2. This is another example where there is CDK 2-way deletion, homozygous deletions, both loci are lost. Then it becomes grade 4, irrespective of the grade, whether it is a grade 2 or grade 3. Grade 3 are usually, they show the loss of CDNK and they become grade 4. So it is very important to do CDNK, especially in the grade 3 tumor. Now, should we do this CDNK FISH for every case? This is the study, even from the France, one large study they carried out, and they recommended that in grade 2, there is no need of doing the FISH for CDNK2. Vaishali carried out the study in our institute, 150 cases, and only the 6 shows CDNK code at this deletion. And what she recommended is if it is a recurrent is a grade 3, when then one can do the fish for the CDNK. Otherwise, in grade 2, there is no need of doing fish. If the tumor is already grade 4, it is IDH positive, but it shows the necrosis, endothelial proliferation, or the necrosis, it is grade 4. In grade 4, there is no need of doing CDNK fish. It is already grade 4. This study has shown that there is a good correlation between the immunohistochemistry, and 90% of the tumor which are IDH positive, they are IDH R132, and very less are 5% are IDH2, or maybe the variant of the this classical canonical pathway. One of the study, we also compared the immunohistochemistry with the molecular, and we found a good correlations. Only some of the variants which are not classical 132H, they are negative for this antibody. So this antibody is a good surrogate marker for mutations. When one should do the sequencing for IDH, if any tumor which is astrocytic in nature, it shows ATRS loss, P53 positive, but IDH is negative. This may be there may be the possibility that is not the classical ART132 mutation, which is not picked up by this antibody. So because maybe the one of those 5% variant. In this situation, one should go for IDH sequencing. The third type of tumor is the glioblastoma, which is a classical necrosis, endothelial proliferation, radiology is classical, ring enhancement. These are the glioblastoma which are IDH wild type. And if you want to go further, one can do the fish for EGFR amplification. There are a lot of signal in EGFR. Rarely these tumor can be P53 positive. But if any tumor which is IDH positive, grade 4, it is a grade 4 astrocytoma IDH. It's not the glioblastoma. Glioblastoma term is only this used when there is IDH mutant tumor. Wild type tumor. The other recommendation is if the patient is more than 55 years, one should go for the MGMT methylation. That determine the sensitivity for the temozolomide. Sometime there are occasional cases where one can get the small cell differentiation, PNAT-like areas. And these tumors are glioblastoma, but they show the anemic or MYC amplification, which can be tested by the fish. Another subtype, which is common in young patients, is very well circumscribed tumor. Its morphology is very bizarre looking. It looks like either the melanoma because the nucleoli are very prominent, or like carcinomas, metastatic carcinomas. But one of the good things is that it shows the mutation for the VRAF. When this is absent, then there is a problem to diagnose. Sometimes all markers are negative. The OLIG2, which may be positive a little bit, that may determine its glial nature. And most of these tumors are misdiagnosed as metastasis or some other tumor. This is further complicated sometimes when there is cytokeratin or EMA positivity, which are the marker for the carcinoma. One should be very careful in a young patient with bizarre looking cells, eosinophilic cytoplasm, prominent nucleoli. And the prognosis is bad in this case, in this tumor also. Another variant is the giant cell. It also occurs in the young children, but it shows P53 mutations, which is very classical. But this is a tumor, giant cell, lot of giant cells. And many times these tumors shows defect in the mismatch repair genes. Gliosarcoma is another variant, subtype of a glioblastoma. It is a grade 4, and the sarcomatous component may be maybe non-descriptive or maybe osteosarcoma, chondrosarcoma, leiomyosarcoma, even the angiosarcomas. Their prognosis is as bad as the glioblastoma. So in astrocytic tumor, the first step is to do the IDH staining, P53 ATRX. If the ATRX is lost, it's astrocytic. There's no need of doing 1p19q co-deletions, even in the oligodendroglioma. If ATRX is retained, IDH is positive, then it may be oligodendroglioma. And those situations one can do the 1p19q co-deletions. So there are situations where grade 2 tumors, which are IDH wild type, they behave like GBM. And that is the reason that any tumor which is IDH wild type, WHO say this is a glioblastoma. This prognosis is as bad, one should do the markers, molecular markers to prove it is the glioblastoma. But I will discuss, there are some instances where it is not fitting in any of these categories. This is the one tumor which is a triple negative. All three are negative. This is a grade 2, but its behavior is like grade 4. It is a glioblastoma. Another situation where the morphology may be grade 2, depending upon the grade 2, grade 3. This is the granular cell glioblastoma, astrocytic tumor, very histiocytic looking, very difficult to diagnose. They are missed as some demyelination or some other histiocytic lesions. Usually they are multicentric. So irrespective of this, another situation, irrespective of the histology, whether it is a grade 2, it becomes grade 4. Behavior is like a glioblastoma. This is oligodendroglioma, classical fried egg appearance, chicken wire pattern of vasculature. When you get these nodule like this bluish nodule, one should look for the mitosis in these bluish nodule. They are usually seen in the high grade, grade 3. Mitosis more than 6 or 6 is anaplastic, and it shows IDH positivity, ATRX is retained, P53 is negative. The only situation where P53 is positive in oligodendroglioma is after the treatment with the temozolomide or radiotherapy. These oligo can become P53 positive. Otherwise, they are negative for So now the question is, should we do 1p19q in every oligodendroglioma? There are some studies which are showing that H3K27 ME3, which is a methylation, trimethylation, this antibody, if it is lost in oligodendroglioma, it indicates it's a good correlation with the 1p19q co-deletion. Although WHO has not integrated, I think the next classification they will integrate in the diagnosis of oligodendroglioma. The other, Vaishali is also carried out one study, her paper is under publication, is triple. If the tumor is bimentin negative, this HIP1 are positive and M3 is negative, and then this is a oligodendroglioma. And this correlate with the 1p19q situation, positivity. The mitosis 6 or more than 6 indicate, and for 1p19, any method can be used, fish, the PCR, or any other. This is when to do the IDH sequencing. If it is a classical IDH 132, then it is picked up by this antibody. If it is some of the other mutations, then it is missed with this antibody. In those situations, one can do the sequencing for IDH. And it is seen only less than 5% of the cases. There are situations where the morphology is oligodendroglioma, like for example here, but it is showing the IDH positivity and P53 is positive, ATRS is lost. Although morphologically it is oligo, but molecularly it is astrocytoma. So this should be called as the astrocytoma. Now, WHO recommended these 5-6 tests for the classification of these adult gliomas, and based on these, one can reach to the methylation. It may be optional in some tumor; it is essentials, and there are some problem with this classification. One of them is with if it is a grade 2 tumor, grade 3 tumor, which is IDH negative. WHO, according to WHO, it is grade 4. There is one study who carried out large number of sequencing in glioblastoma, high-grade tumor, which includes both wild-type cases, and they found that there is 140 cases where the morphology is more like low-grade tumor, and they found this mTOR pathway mutations. Their prognosis is better. So I think in the next WHO, whatever is the IDH wild type, they called it as a glioblastoma, is not true. The methylation is recommended, but methylation has its own problem. There are some advantage. For example, this tumor, this record after 3 years, 2 years, we called it as a glioblastoma, and according to this methylation, it turned out to be neurofibrosarcoma intracranial. So those are the tumors. Sometimes there are surprises. We will never diagnose neurofibrosarcoma in the cranium. That was very rare. Sometimes this is we called it as the glioblastoma and grade 4 tumor in a child. But according to this methylation, they say this is the SMARC complex. But both these antibody, ININ and BRG1 positive. So we couldn't demonstrate the loss. Whether this is a true or not, the time will tell. So in the end, now what is recommended, some people are recommending the IDH positive. It is not only the adults. There's another group where there is mismatch repair. That should be separated from the classical IDH mutant tumor. And there's another group where in the infratentorial, we never diagnose grade 2 or these low-grade tumor in the infratentorial unless it is a pilosity. Any tumors, and especially what they are saying that there may be IDH positive, but the other may be negative. And it is IDH variant, not the classical 132, which can be mixed with this antibody. So maybe that some of the tumor, what we call as IDH wild type glioblastoma, based on the morphology, because they are low grade, but molecular is not positive. Some of them are probably IDH positive gliomas. So we should look for in the infratentorial region. The other is oligosarcoma. WHO last time they deleted this entity. They said there is no oligoastrocytoma, but now there are studies which are showing this is IDH positive oligosarcomas. So thank you. So these changes are probably will be incorporated in the next WHO by the time we will learn the 5th edition.
Thank you, Dr. Sharma, for the very informative talk. So we can just take one question, if there are any.
Loss. Then actually those midline is a different class. I am talking of the classical locations. IDH mutant.
So next talk, we'll be having a deep dive into the pathogenesis of pediatric glioma by Dr. Vaishali Suri, who is a professor of neuropathology at All India Institute of Medical Science, New Delhi. Over to you, ma'am.
Before we start with the session, I would like to request all the residents to submit their poster at the adjacent room within 10 to 15 minutes. Please. No, they have to start my topic. यहाँ से स्टार्ट कर दो ना।
A very good afternoon. First of all, I would thank Dr. Anila for giving me opportunity for participating today. I'll be discussing pathogenesis of pediatric gliomas, and I'll be restricting myself to pediatric high-grade gliomas because of time constraints. The WHO 2021 classification has been built upon the 2016 fourth edition and also on the recommendations of C-Impact Group, and it is for the first time that it has introduced major changes which advance the role of molecular diagnosis in the CNS tumor classification. It is for the first time that pediatric gliomas have been completely separated out from adult gliomas. And they have been, I'll talk about diffuse gliomas, especially the high grade, but the diffuse gliomas in the pediatric age group have been divided into two main subtypes: pediatric type diffuse low grade gliomas and high grade gliomas. What is the difference between these two? The difference is pediatric type diffuse low grade gliomas are all WHO grade 1 and high grade gliomas are all WHO grade 4. So there is no, grade 3 pediatric type tumor. So high grade are all grade 4 tumors. This picture has been very well elucidated by Professor Sharma. And it was in 2012 that it was realized that the molecular pathogenesis of pediatric type high-grade gliomas is completely distinct from adults, and they are driven by, most of them are driven by histone mutations. And it is now realized that majority of the midline tumors, they show H3K27M mutations, and the non-midline tumors, that is around 30 to 40% of the non-midline tumors, they harbor G34R or V mutations. And this is actually the new classification, which is there in 2021. The diffuse high-grade gliomas, which are all grade 4, have been divided into 4 main subtypes. That is diffuse midline glioma, H3K27 altered, diffuse hemispheric glioma, H3G34 mutant. These are the most common subtypes. And then there is third category, diffuse pediatric type high-grade glioma, H3 wild type, IDH wild type, and another subtype, infant type hemispheric glioma. I'll touch upon these entities one by one. What is the difference between them? So, diffuse midline glioma, H3K27 altered WHO grade 4 was introduced in 2016 itself. But then it was called as H3K27M mutant. But I'll tell you why this word altered has been put now. So these tumors, they occur in midline and most commonly in the brainstem, thalamus, or spinal cord, and they harbor H3K27M mutations, which can easily be diagnosed by any pathologist using two immunohistochemical stains, namely H3K27M and ME3. So the tumor would be positive for H3K27M and will show loss of ME3. So we recommend that all laboratories must have these two stains in their lab, and they must put, even if the tumor looks low grade, they must use these two immunohistochemical stains to rule out this tumor, because the prognosis is very dismal. Although sometimes they can, look like low grade tumors, but this antibody really helps in making a diagnosis. And, the literature says the prognosis in these tumors is even poorer than the non-midline tumors. But we did a study
in 2019, and where we analyzed all our retrospective data, we did not find any, such difference. The prognosis in non-midline and midline tumors is similar. Now I'll come on to the next point, why, WHO has changed the term from H3K27M mutant to H3K27 altered. So when you, analyze the diffuse midline gliomas, nearly 90% of the tumors will show H3K27M mutation, but it has been realized that it is not only this mutation. All these tumors have H3K27ME3 loss, which can be due to other two alterations, namely AZIP overexpression. So this entity has been introduced. So if a tumor shows, is not positive for M, you can use this antibody and you can diagnose this entity. And the prognosis is little better in these tumors as compared to H3K27M mutant tumors. And the other entity is diffuse midline glioma, EGFR mutant. These are actually the bithalamic tumors which we used to, I mean, we have been seeing them for years, but now it is seen that if you do sequencing in such cases, they show EGFR mutations. Number one, they are bithalamic in nature. And most of these entities have been recognized by methylation profiling. And why it is important, to recognize this entity is, number one, they are not amenable. You are all surgeons, you know that. They're not amenable to surgical resection. The prognosis is very poor, and there is an interest in targeted therapy. So people are using targeted kinase inhibitors, and the clinical trials have shown, good prognosis in patients who have been given targeted therapy. So that is why the term, and in our lab also, in all bithalamic or thalamic tumors in children, we are using all the antibodies first, like we assess them for H3K27M, ME3, and even G34RV. And if they are negative, we are routinely doing sequencing for EGFR mutations, and we have published a paper also, and we have recognized 3 to 4 cases in our center. So this is, about midline tumors, why the term H3K27 altered is used. Why? Because M mutant we recognized in 2016, but after that, 2 other entities, that is the one which show is AZIP expression, and the ones which are bithalamic with poor prognosis and amenable to targeted therapies, have also been recognized. So the terminology has changed from mutant to altered, just to include these 2 subtypes also. Now coming on to hemispheric region, from midline, shifting to hemispheric region. So mainly we subdivide them into diffuse hemispheric gliomas, H3G34 mutant, infant type, and diffuse pediatric type high-grade gliomas, H3 wild type, IDH wild type. So, I'll discuss these 3 subtypes one by one. Coming on to the diffuse hemispheric glioma, H3G34 mutant. Number one, they are seen in the cerebral hemisphere in adolescents or in young adults, and they show mutations in the H3G34 region, and the prognosis is little better than the midline tumors. And they also can be easily recognized by any pathologist using these 2 antibodies, that is H3G34R and V. So we are using these antibodies, and we are recognizing these entities. At least 30% of the hemispheric tumors, they fall in this category. Now coming on to the next subtype, diffuse pediatric type high-grade glioma, H3 wild type, IDH wild type. It has 3 main subtypes, but this entity cannot be recognized using routine immunohistochemical stains or your NGS studies or Sanger sequencing. They have been recognized on methylation profiling, and right now also you need to do methylation profiling to, recognize this entity. Now for clinicians, why it is important to know this entity? Number one, they have low level of MGMT promoter methylation, which suggests low efficacy to temozolomide. Number two, in these 3 subtypes also, there is difference in survival. If you diagnose a case of diffuse pediatric high-grade glioma, MICN, it has the poorest prognosis. So in our lab, we actually took up a study in which we analyzed 50 cases of pediatric high-grade glioma by methylation profiling, and we recognized 7 cases of this subtype. And this subtype is also important because in this there are RTK1, RTK2 subtypes, and one of these subtypes, I don't remember now, is associated with mismatch repair deficiency, and these children, they need immunotherapy. They do not respond to temozolomide. Now coming on to hemispheric type glioma, why they have introduced this term? Because number one, they affect infants and early childhood. The median age is 2.8 months. Sorry, not 2.8 months, it's 2.8 years. And 3 subtypes have been recognized, that is anti-RK altered, ROS altered, ALK altered, and MET altered. For this also, you need NGS studies to recognize. We are although using antibodies, which are available, but I mean, the results are not very satisfactory. Now, again, why we need to recognize this? Because although, on imaging, they are large tumors, they show necrosis and hemorrhage, but targeted kinase inhibitors are available for these tumors also. So the oncologists are very much interested in, recognizing these entities. Now, as sir has said, a small subset of pediatric gliomas can also show BRAF mutations, which is also holds rationale for targeted therapy. But what we advise is, like, if you do not get any, you're not getting onto something, at least do one simple immunohistochemistry for BRAF, you might recognize this entity. A small subset of, adolescents can also show IDH mutation. So in all cases, especially if the child is more than 10 years, we recommend doing IDH IHC. Sir has already shown you one case of a 16-year-old male who was IDH mutant. Then all this entity is also there in WHO. There is a small subset of tumors, pediatric high-grade gliomas, which occur in context of cancer predisposing syndromes like Lynch or CMMRD. So what is, why, they are completely different. I mean, why we have categorized them separately is because these tumors, which are associated with cancer predisposition syndromes like Lynch and CMMRD, they show mismatch repair deficiency, which is because of mutations or epigenetic silencing of mismatch repair genes like MLH1, MSH2, MSH6, and PMS2. It leads to accumulation of mutations, so leading to a hypermutation phenotype. These cases are resistant to temozolomide and need immunotherapy. So again, what we recommend is in all pediatric AYA patients, please do immunohistochemistry for mismatch repair genes, and we are doing with Ventana antibodies, and we are getting excellent results. And we have done, correlation with exome studies also. It has very good concordance. So I would advise the pathologists sitting here, the neurosurgeons here, please ask your pathologist to do immunohistochemistry for these 4 proteins to, catch such kind of patients where, patients can afford and they can be given immunotherapy. So the frequency of mismatch repair deficiency has been, we looked at different studies. The frequency reported from various regions is different. The frequency is high from regions where there is consanguineous marriages are there. Because of consanguinity, the frequency is high. At our center, we looked at 100 of our cases, and we found that 15% cases showed mismatch repair deficiency. So this is the list of our cases. And the age range varied from like 2 to 29 years. So now we are doing it in all cases of high-grade gliomas which come to our institution who are less than 40. So I think it should be made mandatory to do analysis for mismatch repair proteins. So now if we look at this table, you will be able to gauge what we have talked about today. That is, we have diffuse midline gliomas, the H3K27 altered in the midline, H3G34M mutant, then P53, H3 wild type, IDH wild type, which can be recognized only by methylation profiling. Then you have CMMRD associated tumors, BRAF mutant tumors, and also you can have IDH mutant tumors in children. So this is just a simple table for the pathologists. They can follow and recognize at least 60% of the tumors occurring in children. So just, I will take 2 more minutes to let you know where we are going, in which direction we are moving. Now, if you realize DNA methylation profiling has been introduced as a major tool in WHO 2021, and it is either an essential or a desirable criteria for diagnosing most of the CNS tumors. And it has not only improved diagnostic accuracy, but it has helped in refining and reshaping the tumor subtypes. Now the entities which you are now seeing, looking at the new entities which are now being introduced, they have all been introduced by DNA methylation profiling. And there are some entities, like I discussed just now, H3 wild type, IDH wild type tumors can be recognized only by DNA methylation profiling. And in our center, for almost wherever we have fresh tissue, we in all the NOS cases, we are difficult to diagnose cases, we are doing DNA methylation profiling. It's actually a 7 days laborious procedure. You need batched assessment. That is a major this thing disadvantages of this procedure. So the cost is high, like you need, like in our center, we are doing it in bulk. So it is costing us like 50,000 for fresh tissue samples and nearly 70,000 for paraffin block samples. So like once you get your data, so the data anyone gets is in the form of IDET files. You can upload it onto the Heidelberg classifier. They have developed a beautiful classifier. You don't need to be a scientist to analyze. As a surgeon also, you can analyze the data, just put it on their site. Next day, you will get the report. So the report, it gives you the methylation group, subgroup classification. It gives you the MGMT promoter methylation status. The copy number is also given in the report. And this is data I have taken from various studies where they have shown that the diagnosis was either refined or a new diagnosis was obtained in a substantial proportion of cases by using this platform. And in our center, we are regularly now doing methylation profiling, and we have analyzed nearly 50 cases of pediatric high-grade gliomas using this platform. And if you can see from this pie chart, new diagnosis was obtained in nearly 27% of our cases, which we labeled them as pediatric high-grade glioma. Like Professor Sharma has shown you a case, like we labeled it as pediatric high-grade glioma, but it was MPNST. So sometimes we label something as a glioblastoma, it turns out to be PXA. And in some cases, the diagnosis was refined. For example, I call it as pediatric high-grade glioma, NOS, but this is H3 wild type, IDH wild type, as I have shown you those 7 cases. So you can see here how this platform is helping us refining diagnosis, achieving a new diagnosis. So just to conclude, it is very critical not only for the pathologists but for the surgeons also to recognize diversity of molecular testing which is available, and we have to now adapt new technologies. And in cases, in centers where these platforms are not available, WHO allows you to give, NOS label. But I advise, if you have not diagnosed a case properly, if it needs further, testing, please put NOS. For example, if an oligodendroglioma, you've not done 1p19q, please write NOS in the end so that the surgeon knows, the oncologist knows something is missing. The patient needs more testing. So even in our center, for example, we are not doing, we have stopped doing CDKN2A deletion in grade 2, but in the report, we are writing NOS. I feel it should not be done till WHO allows me, okay, not to use it. I have to, say I have not done it, because it gives liberty to the patient to get himself tested. At least he should know that the report is incomplete. So we need to, improve our molecular detection methods and develop clear specific descriptions and algorithms to, use these platforms, the high throughput platforms. Of course, we can use it sparingly. We cannot be using it on all our cases. So we should know, where to begin with high throughput analysis and where to end the single marker testing. Thank you.
Thank you, Dr. Suri, for the very wonderful and informative talk. So we can have just one question.
It can be done on both. Results are comparative.
Dr. Suri, I have a question. Like you have said that there are various immunohistochemistry-based molecular markers. So recently, like you have shown for the CDK N2A homozygous deletion for that.
Yes.
So recently, there has been evidence that MTAP can be utilized as a surrogate for.
We have used MTAP, but MTAP is not working fine. So what we recommend is, as sir has shown, a combination of H3K27Me3, HIP1R, and by maintain 100% concordance. You may not do 1P19Q, but again, WHO has to tell me. So in all our reports, we are at this juncture doing both the Me3, all these three markers, and 1P19Q.
Thank you.
Thank you.
So moving on, as ma'am elucidated that we need to know the molecular targets. They are important, BRAF, MMR status, etc. Not only they are important for diagnosis, but they have implications for the clinicians in the treatment profile also. So moving on, we have next talk on molecular directed therapies in adult gliomas. And the speaker is Dr. Deepam Pushpam. So Dr. Deepam Pushpam, over to you.
Good afternoon, everyone, and I want to thank the organizers for giving me this opportunity. So I will be speaking on molecularly targeted therapies in adult glioma. So the development of treatment modalities in glioblastoma had been a nightmare for medical oncologists because as we can see from the right side, from 2000 to 2019 or till now, therapy has hardly moved from temozolomide and bevacizumab. Of course, we have a lot of targeted therapy which has been developed, that is the protein K, PKC inhibitors, EGFR inhibitors, mTOR, PARP, but till now success has been far and few in between. This is the paradigm of treatment which was published in 2024 in the March or April. So here the treatment paradigm for IDH mutant glioma is surgery followed by radiation or temozolomide depending upon the risk stratification. So on progression, there is a role for second surgery, further chemotherapy, re-radiation, and experimental therapy. Similarly, for IDH wild type, again the treatment paradigm is same, surgery followed by RT with or without temozolomide. And on progression, the role of bevacizumab, experimental therapy, and conventional therapy arises. But this paradigm has been challenged in 2024 itself, and I will be sharing you whatever the recent information we have. So one of the landmark trials in the glioma, low-grade glioma was in 2023 NEGM. They included 12 years or older patient with grade 2 oligodendroglioma or astrocytoma with either IDH1 or IDH2 mutation. Patients had at least one previous surgery and they were treatment naive as far as chemotherapy, radiotherapy, or any targeted therapy was considered. So they were treated with voracidinib, and the other arm received placebo. It was a randomized control trial. The primary outcome was progression-free survival, and we can clearly see that voracidinib has a median progression-free survival of 27.7 months, while the patients who were on placebo, they had only PFS of 11 months, which was clinically as well as statistically significant. The another outcome was what was the time period for probability of receiving the next intervention. So in the voracidinib, the median was not reached, whereas in the patients who had been on placebo, approximately after 18 months of median time, they had to be given a second therapy or some other intervention was required. So on this basis, voracidinib was approved. Coming to the next therapy was the BRAF mutant gliomas. So we had a results from the V basket study, which included basically recurrent disease, glioma of any grade, and they were treated with vemurafenib, given twice daily. So it was a basket study. So it contained the patients had various solid tumors, out of which glioma there were 11 patients, out of which partial and stable response was seen in 6 patients. That is, more than 50% had some response, and 1/3 patients had a confirmed clinical benefit. So in this basket study, the glioma cohort showed a decent response with vemurafenib. Subsequently, we had data from another phase 2 basket trial, that is a ROAR study. It included low-grade and high-grade gliomas. And in this study, the complete response was seen in 2 patients, whereas partial response was seen in 8 patients. So out of 31 patients of glioblastoma, 10 patients, 1/3 had a response rate. And in low-grade glioma, also more than 50% patients had response with the combination of dabrafenib and tramatinib. So in high-grade as well as low-grade progressive disease, or with after receiving standard treatment, this combination of BRAF inhibitors showed a very good outcome in the current context. But the key challenge with the BRAF inhibitors is that it is rare in adult gliomas, BRAF mutation, 1 to 2%, some series mentioned 4 to 5% as well. However, from a clinical point of view, this testing is recommended because if it is positive, we have a drugs which have shown good response in phase 2 trials. So this testing is recommended at least in recurrent setting after treatment with standard therapies. So coming to the TRK inhibitors, larotrectinib. So larotrectinib, it has been, FDA has approved it for tissue agnostic indications. But the original trial which led to FDA approval, it is to be noted that those trials did not include glioma patients, brain tumors. So they included other tumors of a mixed cohort. So in this study, there were 33 patients, out of which objective response rate was seen in 30 patients, and amongst which majority were pediatric glioma patients. However, in adult glioma patients also, there were 7 patients, out of which 4 patients had shown disease control rate, that is stable disease or a partial response. So we have some data from adult glioma if we dissect out this study. Similarly, for entrectinib, this is data for the STAR TRK trials. So in this study, there were 16 tumors out of 16 primary CNS tumors, out of which complete response, partial response, and stable disease were seen in 13 patients out of 16. So almost more than 80% of patients had a response. However, it is to be noted that this study was predominantly done in children and young adults. Adult patients were not there in this study. And this is the latest data from October 2023 ESMO, repotrectinib with NTRK fusion positive advanced solid tumor. It's not a full paper, it's an abstract only. So there are 2 patients of glioblastoma in this waterfall plot highlighted by the red. And 1 patient is having stable disease and another is having partial response, and they were doing well at the time when this poster was presented. So as far as NTRK inhibitors are concerned, it is reported that they are less than 2%. FDA has approved larotrectinib and entrectinib, as I said earlier, for tissue agnostic. And it is, as I had emphasized, that key trials which led to approval of these drugs, their primary CNS tumor were not included. Data from recent published paper suggests that it is more effective in pediatric CNS tumor. However, we have very encouraging data in adult tumor, primary CNS tumors as well. And this mutation should also be tested in relapsed refractory patients. So where do we stand now? So NCCN guidelines in 2024 itself has updated the recommendations. Whereas I had shown you the paper from the Nature Primer in March, that vorasidenib and BRAF inhibitors were not there included. So in this year only we are transiting with incorporation of targeted therapies. So in low-grade glioma, which is circumscribed unresectable, we can consider BRAF inhibitor case to case. Of course, it is pertinent to note that observation and radiotherapy are also alternative options. In oligodendroglioma or astrocytoma, which is grade 2 IDH mutation, and they are unresectable, recurrent, residual, or progressive disease, or patients who have a poor performance status, IDH inhibitor vorasidenib is approved for that. We have some data for ivosidenib, but vorasidenib, we have a phase 3 data. So it should be the preferred out of the two. And if we have a recurrence after standard therapy, we should test for BRAF mutation and NTRK fusions, and we should treat with them if, of course, cost constraints are there. So coming to the future, this is a very busy slide, but the point I want to highlight that we have lot of targeted therapy in development. As we speak, more than 80 targeted therapies are currently in phase 2 and phase 3 trials in primary central nervous system tumors. These are some of the trials which are currently ongoing. Second thing that we know that the conventional immunotherapy, that is nivolumab, pembrolizumab, so for these conventional immunotherapy, adult gliomas has been the Waterloo. They have been defeated in this frontier. But combination of conventional with novel immunotherapies are being tried. So this immune checkpoint inhibitor, this is the new thing that is combination, and they are currently under phase 2 and phase 3 trials. We also have adaptive T cell therapies, that is a CAR T therapies, and they have shown encouraging responses in phase 1. And apart from that, work is going on cancer vaccines and oncolytic viral therapies as well. So there are a lot of these trials going on. And the key thing is that combinatorial approach is being tried. So we think that in 2024, targeted therapies have been incorporated in the treatment algorithm. And in maybe couple of years, we will have an implosion of therapies in gliomas. We hope that. Thank you.
Thank you, Dr. Deepam. That was a wonderful talk. Any questions for Dr. Deepam? If no, Dr. Deepam, I have a question for you.
Yes, sir.
One, at what point in time you ask for these molecular tests? Do we ask for them upfront, or once the patient has progressed on multiple lines and like we have no standard options left?
So, sir, upfront, we don't ask for these tests because still standard therapy is that of care. So once the patient progresses, I work in a government sector, so not all patients can afford that. So if patient progresses, I discuss that I can do this test if you can afford, and they are able to afford, then we go for these tests.
The second question is, like we said, we will do these tests when we have exhausted the standard options.
Yes.
So does it make sense to repeat the biopsy, then do the test, or can we do them on the tissue that we have, like which was taken 2 years, 3 years earlier also?
There is a chance of transformation of histology as the disease progresses. So in an ideal situation, we like to repeat a biopsy. However, in situations where it is not feasible, in that situation, we can do it from the earlier biopsy. I will also like to take opinion of sir and ma'am on this issue.
The next question I was going to ask you, Lisa, the same thing. So if we can do the tissue, like the testing, molecular testing on the tissue, which is available like 2 years, 3 years earlier. So whether doing it, knowing it at the point of presentation, will that make a difference?
At that time, if we have the diagnosis, we can help a patient. For example, now we were doing retrospective analysis, and we have a case of NTRK spectral fusion, and the patient actually lived for 3 years, nearly 3 years, and he could have been given this therapy had the tumor record, and we could not help him.
No, ma'am.
So in the beginning itself, we can do it.
No, but I think there's no need of repeating the biopsy for the sake of because some of the changes are seen in all, whether it is BRAF or those. Only thing is those immune checkpoint inhibitors. There the status changes with time, with the recurrence.
In other cancers, we presume that MMR is like, if it's there, it is there. It is like, it cannot change. It will
No,
not
no,
change.
yes, if it is there, it is there.
Yeah. So,
That's
and
true.
second thing, it brings us to the question that these markers, whether they can get altered during the course of treatment by the resistance
I very few,
resistance
for
mechanisms.
example, the immune checkpoint inhibitors, immune checkpoint, T cell, those can be affected. In the metastasis, for example, HER2 positive become HER2 negative or negative become positive. In the lung adenocarcinoma, there is change. But in the tumor, I don't think there is change in this.
Sir, I will just like to clarify this for a bit further. So there are two situations. If we take gliomas in adult, so currently at present there is no evidence to say that if we do a upfront analysis and say I get anti-RK, they should not be treated with surgery, chemotherapy and RT as per the indication, and they should be straight away treated with anti-RK inhibitor. So in adult context, for upfront, I don't need. It is good if I have that information. In pediatric gliomas, definitely there are groups, as ma'am had said, where this information can change the treatment, and there are a group of pediatric gliomas where chemotherapy doesn't work at all. But if there is a BRAF mutation or anti-RK, it can be game changer. Then that's why I emphasized in my slide also that in pediatric they are very much sensitive to this anti-RK. But in adults, right now we don't have evidence.
Thank you, Dr. Pushpam. It was a wonderful talk and lot of information and take-home points. And thank you, sir and madam, for your inputs. I think there were points to like remember and to take home. Thank you very much. So next, Dr. Piyush Vajpayee, he's a dear friend. So he's head of department at Manipal Hospital. So Dr. Vajpayee will be speaking on targeted therapies for brain metastasis beyond conventional treatment.
Afternoon. I would want to thank the organizers and chairpersons for giving this opportunity. So my topic over here was partly covered by Dr. Rajat Saha in the panel discussion. So targeted therapies for brain metastasis beyond conventional treatment. We have discussed this, that the systemic coverage is improving for brain metastasis. So far, what we have was for brain a major challenge because of the blood-brain barrier. So the flow of my talk would be, I would be covering the basics. Well, that has been covered, so I'll be passing through them fast. Local therapy, well, I'm not an expert, but I would be just touching the basics over there because there would be students in the audience. So my focus would be on the drugs, especially the targeted and the immuno-oncology drugs, which have come primarily in the three subsites: breast, lung, and melanoma, because we understand these are the primary sites for brain mets. And of course, the sequencing of these therapies, the challenges that we have. So this is how it would go. And as I told, that these are the three top sites: the lung, breast, and melanoma. And in the sequence of lung be the most common, 40 to 50%, breast cancer around 15 to 25%, and melanoma, which we do not get to see in our part of the world, around 5 to 20%. The rest is by renal cell carcinoma, colorectal, and sarcoma. So what are the basic challenges unique to brain metastasis? I think so. We have discussed this since morning regarding the drugs. It is blood-brain barrier. And of course, it's not just the anatomical thing. It is also a physiological thing, that is the P glycoprotein, which actually works as the efflux pump, which is present over there. Now, just over here, as you can see in the part C over here, I mean, here, this particular area is one where the immune cells also are in the vicinity of the CNS. So that's just one point I would want to highlight. And probably because of the disruption of blood-brain barrier at post-therapy, we get to see that we are now able to harness some of it with immunotherapy. So as we understand how the evolution of metastasis take place, it is basically from the stem cell, which actually gives rise to the extracranial disease. But the brain metastases are a bit more smart than the usual extracranial metastasis, and therefore they have different molecular profile. And that's what we have known for the past more than 10 years now. For breast, if we look at these each subsites, so there is, there are studies which have shown that, they have done the molecular profiling of the extracranial disease pattern as well as the intracranial disease pattern, and they found that the HER2 gets more prevalence. So the HER2 plus positivity is the one which actually increases in brain metastasis. There is a loss of the estrogen receptor in the brain metastasis. So this is actually, you can clearly see there is a flux of the purple line growing larger in the brain, as well as the orange line on the extreme side growing larger, because these are the receptors which are the predominant one. For the lung, again, the CDK and the PI3 kinase pathway alteration in brain metastasis is more florid as compared to the extracranial. Likewise, for melanoma, the PI3 kinase pathway is actually the more predominant one after a proteomic analysis, which shows this. Now, you cannot biopsy every time, but of course, we have now ctDNA. So which is the best method to actually detect it? The blood. Sometimes the burden of disease extracranially might not be robust enough where the ctDNA would be, captured. So CSF is probably the way to go. Not every patient we do it, but at least in a clinical trial, this has been realized that with the CSF ctDNA, the molecular profiling is actually different, and it might help in the way, if in case you want to titrate your treatment as per, you want to follow your treatment, because the ctDNA levels do fluctuate with treatment. Today, how do we prognosticate our patient with brain metastasis? Earlier, it was recursive partitioning analysis. But now, because things have changed molecularly, so there is this graded prognostic index where it is aligned to the molecular thing for various subsites. For lung, there is different. So you have this website of GPA index. You can go on that. You have a calculator, you have an app. You can download this and you can actually get insight. So for example, over here, you can see the RPA would have predicted in a KPS of less than 70, overall survival of around 2.7 months. But if in case this patient has a EGFR or a ALK positivity in a molecular subtyping, it clearly goes almost 3 times the median. So it's approximately 6 months as a median percentile over there. So what are the therapies, local and systemic? I would not go in the depth of it, but we need to understand, because we all sit together when such difficult patients come. The MDT is important because each therapy has to be sequenced at some point of time. And therefore, we must realize, because there would be toxicity if a recurrent metastasis is taking place, and we need to understand that. So the usual biomarkers, whenever we get the initial diagnosis, we ask for are these, and we have been discussing them, that HER2 is the one which is one of the most impressive treatment which has evolved over time for the intracranial metastasis. Of course, the lung, we have a gamut of them, EGFR, ROS, NTRK. So the list is growing longer for lung over there. For melanoma also, there has been rescue with the immuno-oncological drugs and the BRAF. So just one particular point over here. This slide is basically for the students. We need to understand the surgery should be considered in certain subset of patients where, of course, there is a doubt in the neoplastic brain lesion. We want the molecular genetic workup to be done, especially if we do not have any other target subsite elsewhere. So we can consider this. And of course, needless to say, in acute symptoms, in cystic largish lesion, for the radiation oncologist to be comfortable in giving radiation. One particular point I would want to bring over here, and surgery may be considered if the patient is requiring a rapid steroid tapering. if you want to use immuno-oncology drugs and you want a rapid steroid tapering, probably you can consider using, surgical, you can speak to your surgical, neurosurgical colleague. So what about the radiation therapy aspect? Again, I would be briefly touching upon this. Stereotactic radiosurgery has come as a mainstay. Whole brain RT is something that we want to avoid. That's the whole paradigm based on which the targeted therapies are being spoken on. So we understand that SRS post surgery has a place, and whole brain RT can wait if in case, of course, it's not a generic statement, but we would want, in the presence of better systemic treatment, probably to avoid whole brain RT. So these are the guidelines for, the stereotactic radiosurgery. Comfortably, you have data for up to 10 brain metastasis. But as rightly was pointed out in the previous talk, it is not about the number of metastasis that you are irradiating. It is all about the volume, because you have the radionecrosis basically building up, because the more volume of brain you are radiating, the chances after 8.5 centimeter cube, the radionecrosis goes above 10%. Gradually the shift will go once you radiate more. So here comes the point of combining systemic therapy, where you can combine in these particular cancers which are actually throwing the most of the brain metastasis. So talking about the lung cancer, you can see clearly the extracranial response rates all above 70 or 80%, right from the EGFR to the ALK to the ROS1 and NTRK. The intracranial response rates are nonetheless not behind. So almost like in the tune of 91%, as you can see in the FLORA trial. And similarly, these are not just the response rates, they're also converting, in terms of the survival. So a positive survival, a very clinically meaningful survival is being looked upon over there. So likewise for ALK, I mean, it's pretty much impressive. As we look upon the third generation of these TKIs, the more advanced TKIs, we see that the response rates are getting better. Likewise for ROS1, the RET, for the MET, I would say tepotinib has a better intracranial penetration as compared to capmatinib. But we have good data in terms of survival for intracranial disease for both the drugs. So in a nutshell, in minimally symptomatic or asymptomatic patient, better CNS penetrant TKI, which have a robust data to postpone, obviate the need for whole brain RT, is something that we need to adopt. And we are adopting towards that. So questions which need to be answered are about the sequencing of SBRT and TKI in a minimally asymptomatic patient. Shall we give or reserve SBRT on progression is something which needs to be really answered. We really do not have clear answers on that. But yes, it looks like that we can actually harness the potential of these TKIs upfront. Talking about the breast cancer trial, that was the lung, and now breast cancer trial have been defining the brain metastasis slightly differently. It is whether it is active brain metastasis, and what are these? These are untreated or treated and progressing, and new brain metastasis where local therapy cannot be given. So you have this basically. So again, untreated brain metastasis or active brain metastasis in the background that they have already been treated with the SRS and now they are progressing. So here you would want to, again, postpone your whole brain RT and you would want to position in your TDXDs to avoid a whole brain. So there, these trials have taken such patients, and though the data for TDXD is not so robust in terms of phase 3, but in phase 2, we have a good data in terms of response rate for TDXD for brain metastasis to the tune of from 40% to 70% response rates. And also, of course, the survival as well. Another drug which we have is tucatinib, which has taken active brain metastasis, untreated active brain metastasis, which were in a tune of around 21% somewhere. And it again showed that it's translating into a PFS from 21 months versus 12 months nearly. So this was about the TDXD and tucatinib. Now the thing is where to position tucatinib and where to position TDXD. So tucatinib is somewhere, if you have an intracranial progression only and not much of an extracranial disease, I would prefer tucatinib rather TDXD. If in case there is both extracranial and intracranial progression, I would rather prefer TDXD. Intrathecal trastuzumab, especially in leptomeningeal disease pattern, is now an accepted thing, and the dose stated is around 150 mg and is well tolerated with the clinical meaningful response again over there. For the ER positive, there has been some hope for abemaciclib in particular, but eventually the phase 2 trial did not meet its real primary endpoint of a great overall response rate. So I would say, I would take it with a pinch of salt over there, that I would definitely want to use the local therapy if in case there is a patient which is a ER positive disease pattern and a HER2 negative one. For melanoma, immunotherapy, as we understand, we have two options, BRAF and IO. Now, IO basically has always been the preferred in the extracranial pattern. Likewise, for the intracranial pattern, immuno-oncology drugs are the preferred one, especially the combination, both the CTLA-4 and the PD-L1 inhibitor, not in isolation the PD-L1 inhibitor only. So best results are with the doublet, and patients not in need of steroids fare better. So here again, we have to decide whether better to do a surgery and then immediately start with the immunotherapy. And of course, sustainable remissions could be achieved. TKI naive patients preferably had a better response rate. For the BRAF V600E, yes, you have an option of using, the combination therapy. There are overall response rates, but as compared to the IO, they are slightly lesser sustained. So what is probably the future is a combination of IO and a BRAF combination, because that could probably lead to more deeper responses. And this is what the world is looking at. So this is the treatment algorithm, preferably to consider a IO in a intracranial metastasis, especially the combination. Now, how about the sequencing, the combination of the local therapy and the targeted therapy? This is where the debates mostly come. Of course, I would not go into the depth of that, but just we need to be sure we are using a lot of ADCs now, TDXD, TDM1. We have to be pretty sure that it's at least a month away from the SRS being used, because then the radionecrosis chances really go up high. So if in case you are giving it within a month, you could probably be actually acting concurrent with the radiation and could end up with a high radionecrosis. So there are certain agents which you can safely give along with the radiation, and those are listed over here. No break is required, but certain break is required if in case you're talking about BRAF inhibitor, you're talking about TDXD, definitely you need a good break if you are giving radiation as well. So to conclude, brain mets, definitely they are a unique challenge, genomically different. ctDNA, CSF is an evolving tool, and prognostication has evolved. So it's no more RPA, it has gone to molecular GPA, and it's a mobile app which is present. And local therapy and systemic therapy have to be, sequenced at some point of time. Processes are evolving. We are understanding now better. So thank you.
Thank you, Dr. Piyush. Any questions from the audience? I have a question for you, sir. Sorry, I'm a radiation oncologist listening to your talk. Very interesting. So first question to you, in your practice, how do you define asymptomatic brain mets in the lung cancer context? Do you define them as those patients who were detected at workup without any symptoms? Or do you define them as symptomatic patients with a little bit of headache, let's say a little bit of dizziness, who then became asymptomatic with steroids?
I think so. The option A would be the ones. The option B, sometimes it again depends on the molecular aspect of where you're looking at. And again, where the disease location is. If it's the posterior fossa, I would not, wait to call you before I call you for a cup of tea over there in the tumor board. So it's absolutely the location of the tumor, posterior fossa tumor, temporal, something which can make the patient symptomatic quickly, I would want to get the SRS or the local therapy done first. Yeah.
So whenever we have this sort of discussion, we look at basically the brainstem, whether the brainstem is involved.
Yes, of
If the
course.
brainstem is involved, we'd like to proceed with radiation.
Yeah.
If it's the posterior fossa or part of the or adjacent to the motor cortex, that is what. So second follow-up question for you, sir. Then, for patients who are symptomatic with brain mets, is there ever a situation in which you consider the extracranial burden of disease to take over, to start the systemic treatment first, and then hold radiation to the brain later when the burden is high, let's say liver involvement or extensive distribution of mets? What do you do in your practice, sir?
I would say that if in case we are talking about the local therapy being SRS, it gets over very fast. And you can execute your systemic therapies quite soon. So the challenge is not there. You would be, medical oncologist would be working the next Monday only. So, I mean, you would be finishing your SRS, you would ask us to wait for a couple of days. So it really does not make a difference over there. But a whole brain RT, of course, probably if the burden of disease is too much extra cranially, and you have to consider whole brain RT also because of the florid brain mets, especially, let's say, a common scenario, small cell lung carcinoma, I would say that you can probably proceed with the systemic treatment initially and wait and watch, because otherwise the disease pattern is very bad, biology looks very bad. So otherwise, if it's SRS, short therapy, I don't think so there is much of a debate over there.
Sir. Absolutely right. One last question before you leave, sir. On which drugs do you absolutely do not refer to your radiation oncologist at all? Is it osimertinib, third gen, or is it, so what do you do in your practice, sir?
So there's no absoluteness in anything, actually. So of course, in ALK positivity, because most of the times we find that the brain metastases are very small and cystic. Actually, they're subcentimetric brain metastases. So patients are not very symptomatic. And we then discuss, of course, and take it accordingly, start with the TKIs first. Especially with SALC, I would be very comfortable in starting the TKI.
Thank you, sir. Thank you for a very informative talk.
Thank you, everyone, for the insightful words. Thank you, chairpersons. Now we would be moving ahead with the next session to update our knowledge about onco spine surgery. I request Dr. Prakash Singh, Unit Head, Neurosurgery, Max Hospital, to come on the stage. Dr. Satya Shiv Manjul, Associate Professor at RML Hospital. Dr. Ellen Gupta, Neurosurgeon, to join the stage. It's just a small reminder, as we are running short of time, so we will need to move forward quickly. Okay, thank you.
Hello. Good afternoon, ladies and gentlemen. We are, I think, running short of time.
First, Dr. Deepak Bangale, second, Dr.
कौन से?
Docs नहीं है.
पहले. पहले नहीं है. Good afternoon, ladies and gentlemen. We are already behind time, so without much ado, I call upon Dr. Harsha Agarwal. Okay, sorry, Dr. Deepak Bangale, to present his paper. This is an interesting session on
spinal metastasis and sacral tumors. So he will be talking on surgical management of spinal metastasis.
Thank you, Chairperson. Thank you, Dr. Prem Sagar and Kaviraj, for giving me opportunity. So since morning, we are talking about the brain. Now coming to the spinal mets. So surgical management of spinal metastasis. You can see in the your daily OPD practices some. You can see there's a pictures of cervical compression sometimes because of cervical compression, extradural metastasis. Sometimes there is a epidural spinal cord compressions. Sometimes there is only fractures of the vertebra because of the metastasis and all these pictures. You can each spectrum you can see in the OPD. So I'm from Dr. Deepak. I'm from greetings from the Medanta, the Medicity. This is my team. Dr. Sujit Dubey is my mentor in the spine surgery. Especially this is my team of Dr. Sohit, Dr. Tanmay, Dr. Mohit, and Mayank. And this is our setup of OT OR suit with OARM with intraop neural monitoring and navigations. So what talking about metastatic spine tumor. So 20% of cancer patients develop spine metastasis. These numbers is increases because of the definitely upgradation of the PET scans and PET scan and detection of the early recognition of the mets. So there is a definitely systemic treatment is available in form of major treatments, immunotherapies and chemotherapy definitely play greater role. Along with the SBRT have improved the survival till now as compared to the other trials. So these you can see the picture of osteoblastic and osteosclerotic lesions in your OPDs. So evaluation of treatment for spinal metastasis since 1970, there are three eras from 1970 to 1990, one era, 1990 to 2010 era, and from 20 to 10 today. So previously in 1970, this is the most common operation done for is laminectomy without instrumentation. So what happened without just laminectomy leads to post-laminectomy kyphosis. So it leads to the disability, instability, deformity. Sometimes there is a progressive pain. Sometimes there is neurological deficit. And there is only other option is conventional extra beam radiotherapy. So there is laminectomy. When you compare the laminectomy and external beam decompressive laminectomy and external beam radiotherapy, the result is comparables. Means because of if you go for laminectomy, otherwise radiotherapy is same. So at that time, laminectomy has definitely a major impact, and but definitely there is list, but it's without instrumentation. After the era of 1990 to 2010, there is come the segmental instrumentation. Means there is some hooks, rod system come in pictures, titanium rods, pick lateral mass, pedicle screws that gives the stability to the spine. Along with the 1990, there is definitely transarterial embolization. This decreases the vascular supply and definitely it helps in the surgical principles. And 2005, a landmark article by Patchell suggests that surgery is definitely better than external beam radiotherapy for solid tumor malignancies. And then after this, there is aggressive approaches by some surgeons for the metastasis like anterior transcavitary approach, then posteriorly lateral extracavitary of LECA approach, costotransversative approach, en-bloc spondylectomy for the primary tumors of the spine. And definitely that era is our treatment algorithm is surgical base. Previously is radiological base. After one is come as surgical base. Now in after 2010, there is again shift to the surgery. Again shift to the radiation, SRS. SRS changed the paradigm of this. SRS definitely have a greater role to shift from the surgery to radiotherapy. Definitely, SRS gives single fraction, 16 and 24 gray in single fraction. Definitely, SRS have greater indication. In surgical techniques, hybrid surgery, like first start with separation surgery, means surgery followed by SRS is a definitely greater role. Along with there is MISS, minimal invasive spine instrumentation. Definitely there is a increased impact like kyphoplasty, vertebroplasty, and the most important is the norms. Means neurological, oncological, instability, and systemic framework is important. Is better landmark in the treatment of the metastasis. So surgical strategy of spinal metastasis in 2001 paper also suggests that spinal tumor classified into intracompartmental, extracompartmental, and multiple. The management is according to this in 2001 era. After in 2010, they definitely change in paradigm, which shows that if there is epidural spinal cord compression, if there is low grade and high grade, there is a Bilski scale. This is a Bilski scale. It shows that grade 0 only bone is involved, grade 1A only epidural impingement, grade 1B deformation of thecal sac without spinal cord involvement. 1C, spinal cord abutment without cord compression. Definitely this is a low grade. And if you are going to the high grade, definitely the spinal cord compression without CS oblique involvement. I mean, there is CS oblique can seen and no CS oblique visible around the cord. This is the, if there is grade tumor is between 0 to 1B, then definitely you can go for primarily stereotactic SBRT. But if the grade tumor is 1C to the grade 3, there is increased risk of spinal cord injury because of the radiation. That's the time when you go for the separation surgery and surgical. In another recent article of NSC, Neurological Stability Score, 2020 article, so there is a new score combining the neurology, stability, and epidural compression in a one era. And this is called a NSC score. It suggests that when his NSC score is 0 to 2, no surgery, 3 to 4, gray zone, and more than 5 surgery. So these are the nowadays norms and NSE. They are the two skills most of the times we use in the practice. So norms framework is the most important approach for the treatment of the spinal metastatic tumor. This approach is first is neurological assessment, second is oncological, third is mechanical stability, instability, and fourth is systemic. What is neurological? Neurological, you can check for radiculopathy, myelopathic symptoms, or some cord equina syndromes and all for neurology. You can check. B is degree of epidural spinal cord compression. According to Bilski scale, already we'll saw in the first slide. Second is oncological. Oncological assessment, you can see whether the tumor is from the histology of the primary tumor, whether there is systemic spread of the spinal tumor is or there. May you go for whether there is a knowledge regarding prior treatment or response of the treatment. This is an oncological assessment. And third is mechanical instability. It's called a SINS score. Is the most important component in which this scale is tell you whether spine is stable or unstable. Means you require fusion or not fusion. So this score is location, pain, bone lesion, radial alignment, vertebral collapse, and postural involvement. And this, according to that, if the stable, if it's 0 to 6, then the spine is stable. Intermediate, if it is in between 7 to 12. And unstable, if more than 13, then it's called as unstable. So systemic assessment, this is Karnofsky scales and Tokayoshi scale is called as, in this Tokayoshi scale, we go for Karnofsky scale, extra spinal bony mates, number of spinal mates, major internal organ involved or not, any complete, incomplete injury of the Frankel's grade or primary set of cancers. According to that, predicts the survival. If 0 to 8, if there is less than 6 months survival, so 9 to 11, definitely 1 year survival, and more than 12, there is more than 1 year survivals. So management of the spinal mates is systemic control is already, chemotherapy, hormonal therapy, immunotherapy, steroids, bisphosphonates. For palliation, pain control. For local, you have radiotherapy, conventional or SBR stereotactic, and surgery. You go for details in surgery. So norms approach definitely helpful. This neurological oncological approach definitely help in recommendation for surgical decompression and stabilization followed by radiotherapy for high grade, at least high grade extra epidural spinal cord compression with radio-resistant tumor. Radiotherapy definitely have limitation is definitely they do not relieve the mechanical pain. Definitely there is no help in due to the retroposed bone fragment causing the compression over the bones. There is no useful in pain with the help of radiotherapy. So that's why radiotherapy has revolution. Conventional external beam radiotherapy definitely only short-term control. Some tumors are radio resistant, so you can't go for directly conventional beam radiotherapy. So SBRT definitely tightly focus high dose radiation to tumor tissue with limited spread to adjacent structure. So SBRT have a greater role in case of all this. So norms framework neurological, low-grade myelopathy, high-grade myelopathy. With low-grade compression or high-grade compression. Second is oncological, radio-resistant or radio-sensitive. Mechanical, whether it's stable spine, unstable spine. Or systemic, able to tolerate surgery, unable to. If the patient have high-grade compression along with myelopathy, along with there is radio-resistant tumor, directly separation surgery have a greater role. Otherwise, you have go for SRS or EBRT. And if there is unstable spine, along with separation surgery, you go for stabilization. These are the simple framework for this already. So why surgery is required? To control the local tumor, to control the pain and improve the neurology. So how do you can control the local tumor? You could resect the tumor. Definitely surgery plus radiotherapy will improve outcome. Control pain, obviously you stabilize the spine, there is improvement of the pain with neural decompression. And improved neurology in between, because when you do decompression with spine fusion, along with definitely there is improved neurology. So who needs the surgery? If there is metastatic infiltration, patient have night pain, rest pain, pathological fractures, along with metastatic compression, neurological deficit definitely requires surgery. So what is there's a good article from 2019 of AO Spine said that essential concept of the management of metaspine, what the surgeon should know and practice. So major surgical indication already discussed mechanical instability and high spinal cord compression. Definitely, these are the two most important issues where you go for the surgery. So surgery plus radiotherapy. If you go for high grade extracellular, compare between surgeon radiation, definitely surgery have greater advantage as compared to. But surgery is not easy. Definitely there is a lot of complexities. Patient morbidity, neurological deficit, previous radiotherapy, some brain mets if there is disease preserval. You have to be consider all the factors when you are going for the surgery. So previously, spinal metastasis, laminectomy was the only option, is the tumor and go for laminectomy. But nowadays, laminectomy doesn't have any role. You have to go anteriorly and you remove the tumor. Not just posterior decompression is not helpful for the tumor, because you have to go for radiotherapy. So that's why the comparison between surgery, radiotherapy alone is suggests that circumferential decompression plus stabilization, surprisingly, is a high chance to reestablish the ambulation. The patient can ambulate, as well as there is more aggressive approach to ventral approach. Means you have to go for anteriorly, anterior to the cord, ventral compression. If there is ventral compression, you have to remove that compression also. This is the most important. But what is about invasiveness? So if what a tumor invasiveness, if there is only stabilization only, you do mechanical stability. If there is a posterior decompression, go for posterior decompression. Like if there is a posterior base mesh, just posterior compression, but laterally do some anterior decompression along with, and separation surgery talking with lateral. So what are the steps? Embolize the vascular tumor. So first is embolization. Second is excision. You can do the en bloc embolectomy. Third is reconstruction of defect. Fourth is restoration of the spinal stiffness and radiotherapy. There are the surgical options followed by SRS by radiotherapy. So embolization definitely reduces the intraoperative blood loss by 1/3 to 2/3 by improved tumor resectability. Hypervascular tumor like RCC, thyroids, neuroendocrine tumors definitely. Embolization should be 24 hours prior to surgery. What about the excision? You can go for piecemeal along with marginal. Sometimes with the en bloc you can do also. Piecemeal tumor excision, definitely the intralesional migraine, but definite chances of recurrence is there. En bloc, definitely wide margin, but there is complete excision of the tumor. Reconstruction though differed, 90% of the tumor involve the vertebral body. So 80% load by anterior column, you should require autograft, P-graft, spacers, vertebral body replacement cages or carbon fiber cages for this. So nowadays there is a carbon fiber reinforced PICC material has came. This is a very good material in which there is a, you can't see anything on those films. There is a, here is an artifact you can see artifact in the carbon film implants. So carbon fiber screws are reduce the artifact and enhance easy planning. So newer implants like radiolucent pedicle screws and carbon fibers are definitely more. Transpedial corpectomy, highly morbid surgery, but definitely required in case of instability. Restoring the spinal stiffness, we require the percutaneous screws and all stabilization like fenestrated screws, augmented screws, and newer implants of carbon fiber definitely. So reconstruction, anterior column, posterior column, pedicle screws and the rods. These are the case, sometimes require the osseous case or sometimes require the metallic case. And the radiotherapy definitely have, but radiotherapy preparatory started only after complete healing of the wound healing. Otherwise, wound healing is a major problem. So wound healing is the significant perioperative morbidity after if you give early radiotherapy for this. So to avoid this problem, there is a MIS is coming concern. What is MIS? To smallest possible surgical footprint while achieving the goal of traditional open surgery. So you can use microscope, endoscope, you can use 2D, 3D, you can use go for mini open or percute approach, or you can use instrumentation. You also use mini open or percutaneous. So definitely it reduces the surgical morbidity, faster wound healing, like and early administration to the post-op RT means as compared to the open surgeries. So what are the procedures? Vertebroplasty, PPF screws, separation surgery, cryo, and RF. So MIS is percutaneous screws, vertebroplasty, kyphoplasties, and tubes and pores. Previously, just surgical treatment not considered because of unfavorable survival, technical difficulty, then physically not fit. But MIS changed this goal. In MIS, the small incisions, so less blood loss, and easily you can do the procedure with the help of tubes and endoscope. And these are the MIS algorithms. Vertebroplasty, I think, vertebroplasty definitely great role in MIS is reduce the risk of vertebral body collapse, reduce the risk of compression fractures, and prevention of junction pelvic. So there are some augmented screws also there, so that with the help of time completely. So separation surgery, some separation surgery definitely this is the more important role. Is important to decompress the surgery that provides the foundation for concomitant SBRT. So debulking the tumor with the zone of separation wide between the dural sac and the tumor, so that the separate admission of SBRT happens. So separation surgery have get a role. Is a spacer surgery. You can remove the tumor and you just make a space or use a put a spacer there or some surgical gel foam, so that there's radiotherapy can be easily go over there.
Dr. Deva, can you
Yes, I'm then going. So I'm concluding with the help of this. So a lot of cases are there, but MISS is there. This framework is there. So these are our cases. I'm showing corpectomies and thoracic MISS approaches for these spinal metastasis. This already one published MISS approaches for this. I'm videos also that I'm concluding. I'm going to directly on conclusion slides. There are MISS photos with the endoscope. You can, this is separation surgery pictures. These are the MISS treatments, pancreas tumors, surgeries. These are incisions, and I'm going for the conclusion. Sorry. So why you surgery? Alleviate the pain and improve function. Definitely when already talk, who already talk, and what already talk. Thank you. So definitely time is a spine when there is a compression is there, epidural compression.
Thank you, Dr. Deepak. It's a very exhaustive talk and very elucidative. Technology has made it so much easier now to take care of these unfortunate patients who suffer with spinal metastasis, but things are much better. Any question, any comments?
Just one comment. Deepak's talk may be long, but in case these cases, keep the surgery short. You know?
Surgery short.
One question, how you select the patients? Most patients are having distant metastasis, also lung, and but patient present with spinal metastasis with neurological deficit.
So same framework I already told you,
advise
NOMS,
it
neurological,
surgery.
oncological, and if it is a score is more than this, then you go for surgery. Otherwise, the score is not this, then we go for
That is right. Okay. Thank you.
Some of these patients come with the sudden deterioration with the bowel bladder involvement.
Yes.
How do you go about that?
Depend upon same NOMS. First follow that score framework, NOMS. Neurological, oncological, and systemic assessment, that scores. If it is scores suggests that there is a definitely you patient have higher survival, less than more than 3 months also.
Fine.
See, if
you have got a lot of time in case patient bladder bowel is not involved.
Then definitely
patient has got some neurological paralysis only.
Dexamethasone.
Some people come with total paraplegia.
Yeah. So see, everything depends upon the Karnofsky means Tokoishu score. It's called as Tokoishu scores. This score depends upon, we tell you whether is the prognosis survival is 3 months, 2 months, 1 month, or more than that. Okay. Thank you.
Next speaker, I call upon Dr. Ashok Karwal. He will speak on neuro monitoring and brain and spinal tumor surgery.
Thank you, Chairpersons. I'll be sharing a different area for neurosurgeons, and is the intraoperative neuromonitoring. When surgery is required for whatever reasons the surgeons have decided, then we as a neurophysiologist come in to ensure that there are no neurological deficits as a consequence of surgery. And in some ways, we help in becoming the GPS for the surgeon, and in some cases, helping them to prevent neurological deficits as it's loading up. So I work at AIIMS New Delhi and in the Department of Physiology. So we began doing intraoperative neuromonitoring in 2008. Initially, we began with helping out the spine surgeons for deformity corrective surgeries. Later on, we sort of jumped into neurosurgery as well. So the goal of intraoperative neurophysiology is very straightforward. To prevent any neural injury during the course of surgery. That's the primary goal. Two components are identified: mapping and monitoring. Mapping refers to identify the brain structures, spinal roots, whatever. And monitoring would mean as surgery is occurring, you monitor the whatever neurological function that you can monitor. The neurosurgeon's goal is maximal safe resection, and the orthopedician's goal is maximal safe correction. Our goal is to identify the neural element, get a good baseline, and no false positives, no false negatives, basically, which means that we don't stop the surgeons before they have to be stopped, or we don't give them false security that everything is fine and patient wakes up with paraplegia or any other deficit. So that's the challenge for Golem. This is we took about 15, 16 years we've been developing, and we have added each technique by technique over a period of time. From our perspective, we look at the surgeries in terms of supratentorial, skull base, brachial plexus, cauda equina, and cord. That's from our perspective, neurophysiology. And I'll just focus on the supratentorial and bit of brainstem and spine, not on the brachial plexus and cauda equina. There are a huge list of technologies available. Initially, the world began with SSCPs only, about 40, 50 years ago. And today we can think about 30, 40 ways by which we can do this kind of monitoring. So I'll take you for largely a couple of them, the essential ones for supratentorial. The first one is the easiest to grasp and is the Penfield's technique. So that's how we came to know about the motor homunculus. Penfield would stimulate the cortex in awake patients, but it took a very long time before we could do the same in an under GA. So what we now can do is patient under GA, the cortex is exposed, a probe is given to the surgeon. Surgeon will go around poking at different places. We give a way of stimulation, and this white kind of, so there's a left side, right side, various muscles have been images put in, and we get a response. So they just show you one small video where you can just have a look at it. So
Nothing, sir.
So there's a talk between
Nothing,
the surgeon and the neurophysiologist.
Nothing, sir.
So we just
Yes, sir. Hand area.
So that's how we go. So the surgeon is operating, we are looking at the monitors, and we tell surgeon, now that area where you are is the hand area. Of late, we started also getting back onto awake craniotomy for motor mapping. The reason is that the M1 area can be easily stimulated intraoperatively, but when looking at supplementary motor area or the associated motor cognition, it's very difficult. So now what the idea is coming back is that you make the patient do some motor cognitive activity, not just simple tapping, but maybe playing something. And then you stimulate the area. If by stimulation the activity stops, then we know that that area is serving that function. For example, hand-eye coordination. Now, hand-eye coordination is multiple cortices. So if you're looking at posterior parietal cortex, you stimulate the posterior parietal cortex, and then the function will be stopped. So this is the sort of looking at the higher cognitive function, motor function, rather than just the motor response, say M1 area. The other technology which we started with was the phase reversal, and which is nothing but simple SSCP. This helps in identifying the sensory cortex from the motor cortex in case it is distorted. So what we do is we do the SSCP. What we find is there is a shift in the phase of the waveform. As you can see, the red area marked. So there's a shift in the waveform up and down. So you look at those pointers, and you can guide surgeon that these are the location where the sensory sulcus is becoming the motor cortex, because the anatomical differentiation is not that appropriate, especially when the tumor is there. Additionally, we have also started doing what is called subcortical dynamic mapping. After the motor cortex has been identified, the tumor is getting removed. But what we may also remember that the cortical fibers are still there. So we may have saved the cortex, but we may cut the subcortical fiber. Therefore, largely, many of surgeons now prefer to have subcortical mapping, no matter where they're entering from. So they may be entering from in front of the motor cortex, but the tumor is big, and then they have to remove. They inadvertently may cut the subcortical fibers or even the insular glioma. As such, there is no motor symptom, but as you're removing the tumor, you may still reach the internal capsule. So this technology is again very recent. Basically, the suction probe acts as the stimulator. So there's a small device with the tip exposed and the other part is covered. And on the right side, you can see the diagram that if the farther the suction probe is away from the fiber, you need more current. As you keep coming closer and closer, you need less and less current. There's a way of threshold mapping. I'll show you a video to highlight how we do it. So on this video, on the left side is the running EMG, in the middle is the subcortical mapping. Various muscles have been being monitored. So what we're going to do is we'll start with giving some amount of current into the suction probe. Surgeon is operating at their own speed. We don't stop them. So as they're operating, and the video will run. So this continuous monitoring.
जैसे ये सारा जो एरिया है ना, यहाँ पर बहुत अच्छे से लेग रीजन का आ रहा है.
So
वहाँ पर होल्ड करना इसी एरिया में प्लीज.
So we've set at 10 milliamperes and we get a response.
जहाँ आ रहा है ना वहाँ पर, अब बस यहीं पर ही होल्ड करना. इसको मैं 5 पे कर दिया हूँ.
So then now we decrease the current.
5 पे कम हो गया. 3 पे कर दिया हूँ.
So
3 पे we are not getting.
So at 3 milliamps we are not getting a response, which basically means that the surgeon is at least 3 millimeter away from the fibers. So the lesser and lesser, so you start at 10, that means you are at 10 millimeters away. Then you decrease the current. You should not get any response. Start getting a response, that means you come closer. You drop the current further, 3 milliamperes. So they know that they're about 2 to 3 millimeters away from the signal. Okay. So let me just again. We keep going further. Things stunk. And just see that. Okay. File is big. That's okay. Wait. It's taking loading time. So basically, what we will keep doing is decrease the current till it reaches 3 milliamperes, and surgeon may then go to different areas, and then we can identify that which fibers you're close to. The next, apart from motor functions, sensory functions, the other area that surgeon want to have is the language function. So primary two areas are recognized, Broca's areas and Wernicke area. From the cortical aspect, also the subcortical fiber which connect them. So we are also capable of doing that. The technique is that the patient is of course awake. We make them do some activity, and surgeon will get a probe, generally a bipolar, which is placed on the cortex, and we give a current stimulus against a negative mapping. So if the patient is speaking, say 1, 2, 3, 4, there will be you give a stimulus, patient will stop. So that's called, we will induce an aphasia. So if you are in the Broca's area, will cause Broca's aphasia. Or if you are in the Wernicke side, then the anomias can be seen. So I'll just show you those couple of videos, short videos. So this is regarding the language mapping. So largely these 4 areas are utilized. As of now, we don't do much of cognitive function mapping, wherein that whether can we also map higher mental functions. For example, mathematics, ability to speak, ability to give a lecture. Now, increasingly, the goal of surgeries and the patient care has been shifting from just having the ambulation to back to work. So can we make a person go back to work? And for that, the technology remains the same. However, the test that we can do intraoperatively, that's being developed. Thank you very much. So I'll shift to the language area. So in the language area, this is a traditional language area. So we give a lot of tasks to the patient, many of these, depending on what we are looking for. Dr. Ali Asgar is leaving. So I thought, Dr. Ali, I'll show the video that was taken in one of the patients which was operated here, Dr. Prem Sagar, and so I got that video also, so I'll just show him that video. So this was the white matter tracking. So
चलो शुभारा शुरू एक
asked to speak.
2 3 4 5
This is simulation was done. This arthria and slight change of the position of the electrodes.
12
This is pure aphasia. So, and the I asked her that how far there's few fibers up and down you can get. So apart from doing the cortical mapping, cortical mapping can also be easily done. Thank you, sir, for holding up because he has to leave for the airport. Okay. So similar thing we can do for other mapping. Now let me show you, give an example of anomia. When the patient is awake, what we're doing is for the patient, we're showing them images one after another. Generally 3 images are shown. And so we see what happens. So they need a lot of communication with the patient.
Kukur. Biral.
I had learned words in Bengali because she speaks Bengali.
Kukur. Biral. निकाल शाबाश तो ये एरिया है दोबारा से शाबाश.
So we keep showing them and the surgeon will keep stimulating. And she can't speak. So more importantly is when you ask the patient whether they can't understand or whether they can't speak, they are very clear. It's at back of my tongue.
तो बच्चे बोलो बोल नहीं पा रहे थे अच्छा समझ नहीं पा रहे थे नाम याद नहीं आ रहा था
नहीं बोल नहीं पा रहे थे जीभ में
अच्छा जीभ में बोल नहीं पा रहे क्या है उसको बचाना है
So what we have really back of our tongue, that kind of feeling that patient has. I know about it, but I can't. And many times patient will describe the object without able to tell.
शाबाश बताओ गाड़ी very good plane very good.
So in this manner, we can do the function mapping. Now let's come to the brainstem and skull base. Here, the major focus is on the tracts which are going through it and the various cranial nerves going through. If you're going, let's take the example of pons, glioma and pons. The approach is posterior, so you have to identify the facial colliculus. That's the primary goal. So the trick is same that we put in EMGs in various muscles and give a small amount of current. As we're giving current, we see on the left side we get a nice response from the facial muscle. You don't get on the right side. 1 milliampere is a high current. So you identify initial, then you drop the current. Because please remember that large enough current can stimulate even surgeon's muscles. So we have to be very careful that you can stimulate, you can discord from any muscle if you give large enough current. The trick is to get the right amount of current, that you don't have a false positive or a false negative. So we get this later on because the fiber tracts are also there, the corticospinal tracts. So we can also do MEP simultaneously to show that pathway is fine. We can also do SSCP simultaneously. And in this particular scale, you can see that the red one is the old SSCP, the amplitudes have dropped and shifted to right. That means when the surgeons are operating, the sensory tracts are getting affected. We can just tell them that, and then they can take a decision on that. This is, I'll show you hemifacial spasm and how we do technology. So what we do is stimulate one of the nerves and record from all the muscle fibers. Normally, you stimulate this nerve, only upper face should get twitches. But if it's a hemifacial spasm, the lower ones also get after a long latency, as you can see in the lower graph. On the stimulation is given, no response in the lower muscles, given more response in the lower muscles. Intraoperatively, we can pick this up very easily. I'll show you that. So this is the initial response.
We've kept the stimulus at 7 milliamperes.
A very long.
All are coming.
All are coming. And after some time, as we keep operating, those responses. So if you can see this intraoperatively, you're very sure that patient will wake up without hemifacial spasm. So it's a very good indicator intraoperatively for this purpose. Let's take a couple of half a minute, sir, and then finish off. This is the endotracheal tube that we've been trying for vagus nerve. So this is taken from the Inomed. This is how it's put over the endotracheal tube. We had to do a case. Sorry. So it was a small tube, a small baby with three number tubes. So we had to cut. We cut a couple of the electrodes and re-put because otherwise it become too big. So it was easily doable, and we were very happy to be able to do this. I think this again got stuck. Okay. Close the program. Loading it up. Maybe I will have to. I should have decreased the file size. Gotcha. All right. Saying not to move too fast on the videos. Okay. This. So I'll run the video here itself. Yeah. So this is the response that we can get by putting the electrode responses in the vocal cords. So as the muscle contract, intralaryngeal muscles on stimulation, we can pick with the vagus nerve. If we give a single stimulus, it doesn't also affect the heart rate. It doesn't. We have to give a rate, so not to worry on that aspect. So largely, sir, this is about the brain cell, and I'll skip the other part because as MEPs and SSPs are run-of-the-mill recordings for us. Thank you very much for your time. Thank you.
Thank you, Professor Jarial, for very nicely demonstrating the importance and different techniques of neurophysiological monitoring. On the one hand, the imaging and navigation helps in anatomical localization, but this physiological monitoring definitely works as a safeguard from any functional loss during surgery.
Yes.
So I think it should be an integral part of spine and brain surgery.
So,
thank you.
thank
Any
you.
question or comment?
Thank you very much, sir.
Thank you, Professor Jarial. Now I will call upon our Professor Ashish Suri, and he will speak on surgical management of craniopharyngiomas. Professor Suri, please.
Good afternoon. I thank the Rajiv Gandhi Cancer Institute and Dr. Prem Sagar for the kind invitation. I've been asked to talk about a big topic in a short time. So, craniopharyngiomas. These are very challenging, respected chairpersons. Craniopharyngiomas are funny tumors. They can be very small, they can be huge, they can be very huge. So, and they are most challenging. I've been serving their teams for the last 31 years now. So craniopharyngiomas, rare tumors, 1 to 4% of benign intracranial tumors, benign, slow-growing, remains of Rathke's pouch, standard location, cellar, supracellular, and third ventricle, and bimodal distribution, childhood 5 to 14, and adulthood 50 to 74 years. Very challenging tumors. I find craniopharyngiomas and petroclival meningiomas to be one of the most challenging among all the whole Onco setup. Symptoms, visual deficits, as bitemporal hemianopia, endocrine dysfunctions, we can have the hypopituitary function, or diabetes insipidus, neurological symptoms like headaches and hydrocephalus, growth delay with common in pediatric cases. Radiological features, CT scan may show calcifications, and MRI solid cystic masses with contrast enhancement. They can be difficult to differentiate from radiologically from pituitary adenomas, Rathke's cleft cysts, or germ cell tumors. Surgical management, the goal of surgery is the maximum resection. This is the gold standard of treatment, while preserving all neurological and vascular structures. Approaches are two. There have been some controversies. I'll talk about them. Transcranial for large complex lesions and endoscopic endonasal for minimal invasive selected lesions. Challenges, what are the challenges here? The most important challenge is the hypothalamic involvement. They can infiltrate or be stuck to the hypothalamus. Dissection can be difficult. And they can be stuck to the chiasm or the optic apparatus. The visual and hormonal dysfunction can happen. Histology in modern children usually have adamantium which are more of calcified with multiple cystic. Adults usually have papillary craniopharyngiomas, but they can have both, can spreading into each other, and without calcifications. Molecular insights, the papillary are more of BRAF positive and the CTNNB1. This is more important now because of the targeted therapies. This is my personal series. Till 2 years ago, I think 3 years ago, 22 years, 76 cases, not a very huge one, but that is the number of craniopharyngiomas that we get, and both in pediatric as well as adult population, mean age being 23 years. I've been operating more because of the endonasal as well. In my series, cystic components were there in nearly 3/4, calcification nearly half. Gross total excision I performed in 54%. As becoming older, gross total excision became better. Near total excision in 25%. In the earlier cases or in redo and post-radiotherapy cases, the extent of resection is less. So in all my subtotal resection, they were either post-operated elsewhere or given radiotherapy, and they have adhesions to the hypothalamus optic apparatus. Need for a Maya placement, this decision is in shop. I hardly put in them now. Most important surgical morbidity is a transient diabetes insipidus, which can become permanent, and you need if you're sacrificing the optic, the pituitary stalk. And the paresis of the loculomotor nerves, if you are doing a third nerve handling, it's a multi-compartmental, which is like going lateral. 20% of the patients may require repeat surgery for residual recurrent or for CSF drainage, like either VP shunt or an Maya. Radiotherapy, I gave for nearly 6 out of 76 of my patients. And histopathology, more common were adamantinomatosis because the pediatric were higher than papillary. We are doing BRAF and beta-catenin for all. Regarding the controversy, whether they should be operated through the nose, endoscopically, or from the head, microsurgically. 39 cohort series, more than 3,000 patients, no significant difference in hypopituitarism or pan-hypopituitarism after surgery between both approaches. Both are the same. Similar recurrence rate in both groups, significant. Similar proportion of endocrine outcomes and recurrence in both endoscopy as well as craniotomy. Another meta-analysis, 48 articles, 1,186 patients, both techniques are comparable. And sorry. Yeah. Another series, it said that the post-op visual deterioration only happened in the craniotomy series. The endonasal endoscopic group, the visual improvement was better. And now we can actually say that you're operating bigger tumors with craniotomy if you go for this. So some cases regarding the so extended endonasal endoscopy I've been doing for the last now, for craniopharyngioma, 7-8 years. Done around about 15 now. In this series, there were 10. The standard small midline tumors, not infiltrating the hypothalamus and not going beyond the carotids. They can be cystic or solid, not very much calcified. So these are the steps. You do a lateralization of middle turbinate. You harvest ADAD nasoseptal flap. You do a posterior septostomy. A middle turbinectomy may be required. And that is how you harvest the nasoseptal flap. This is a horizontal cut inferior, a superior one, and then a vertical anterior cut. And then you take it, bring it down in the choana, and you have a good exposure of the cellar as well as the tuberculum cellae and the plenum. Sorry. Once you get this exposure, this is the exposure of the cellar floor. This is the plenum also being drilled, the cellar stage. And you have a dural exposure right from the cellar, the two carotids, cavernous sinuses, and the tuberculum cellae and the plenum. Then you make an incision. The dural incision is not standard for a pituitary. It covers the pituitary. Actually, it saves the pituitary gland like this, 5 o'clock, 7 o'clock. Then it goes up like an inverted T, and then it goes like an H up over the optic nerves. So you're actually seeing the face of the tumor. Then you can, so it's like an inverted T or a lying down H exposure. So this is the pituitary gland, which is pressed down. That is the diaphragma cell. This is the exposure of the gland of the tumor. Then you can go around the tumor, you can decompress it, and you can dissect it from the hypothalamus. And then you need a multi-layered skull base repair. That's most important. The most important thing in this surgery is endonasal, is the repair. So you need a fat path because there's a big hollow space there right into the third ventricle. You put a small fat plug there. Then you inlay of a facial lata and a hadad flap or a nasoseptal flap goes over it, and then some more packing of the sphenoid sinus with fat, and then reinforced with some gel foam and fibrin glue. So this is how you take it. And so I'm not able to scroll here. So this is the harvesting of the nasal septal flap. Oops. Sure. Not able to scroll it. I'll just maybe skip a couple of buildings. The video is edited, but I can't scroll. I think something wrong in the. Maybe I don't. And then this is how you take off the flap, the nasoseptal flap. That was the the vertical cut, that is the horizontal cut, and then you leave some mucosa at the upper edge of, bordering the upper edge of the middle turbinate. That is where the olfactory mucosa is there. And you bring it down right to the sphenoid ostium. You should not go beyond the upper border of the middle turbinate because otherwise you'll damage the olfactory mucosa. That's the posterior septostomy. Still now we are on the right side or the more sizable nostril. Then you do a sphenoidotomy. And that's a posterior septostomy being taken off with the wormer. Till now I'm in one nostril, and then we go to the opposite side nostril. Again, there's a posterior septostomy there. That is the antrum punch. We take off the backbiter, and then we drill off the take off the septa and drill the sphenoid sinus. That is the cellar floor being drilled. That is the tuberculum. That's very important because you are actually going to drill it here. That is tuberculum cerebri. So you have taken off some part of the plane. You must use a Doppler for the carotids just to have a look, and navigation is important. So this is a 5 o'clock to 7 o'clock incision. This is just where the pituitary gland would be. Just below that would be the pituitary gland. Bring it up like an H, a T going up. That is above is the anterior intercalated sinus that you. Sorry, I can't scroll this. Something wrong. And then you take it up like a T over the optic nerves, and then you take off the arachnoid. Visualize the front of the tumor. That's a complete tumor. Minimum coagulation. Dissect, decompress, again dissect, and then mobilize. Dissect it from the undersurface of the chiasm and the hypothalamus. This is an area which you should take time, and then it just rolls back. Once you have make it free from the chiasm as well as the hypothalamus. Regarding the stalk, if the stalk is thin, it usually comes off with the tumor. If it is nice and placed there, you can preserve it. That is the third ventricle. Put a fat plug there so that all your graft doesn't plop into the third ventricle. Do an inlay repair of the fascia lata, and then you put the nasoseptal flap over that. So it's a 3-layer repair. And then again, you put fat over the borders of the nasoseptal flap. And then gel foam and glue is more of a tamponade rather than a sealant there. And then we are lateralizing the middle. This is no residual tumor in the postoperative MRI. So now they're 15. So a gross total in most of them except one, and another one that was near total because of this calcium. That was the early experience. We didn't want to take care of this calcium from below. Surgical outcomes, all of them had either the vision improved in all of them or remained the same. Transcranial microsurgery, these are the tumors in which this tumor is going behind the dorsum sellae, if you can see that. I cannot scroll it, so I'll just rapidly show the steps. A standard cranial craniotomy. The only difference is I open the anterior clinoid process so I can take off the falciform ligament. That helps to actually go and see where your stalk is coming into the hypothalamus. You can go down because the opticocarotid window increases. The opticocarotid window is very small. So if you cut the falciform ligament, which I'll be doing after this, I'll just show this part of it so that then we can come back. So this anticlinoid clinoidectomy can be done intradural or extradural, anywhere. But the good thing about extradural is you can do, if there is a pneumatized ACP, you can actually plug with fat. And that is the ACP being drilled. That's the anticlinoid process completely being drilled off. I'm sorry, I cannot forward this, so I something wrong. So then a standard dural opening. Open the Silvan fissure wide. This is standard trigonal approach. The only difference with the ACP removal is you can actually cut this dura, the falciform ligament, and you widen the opticocarotid cistern. Then you can actually see the pituitary stalk right to the hypothalamus and completely take out the tumor. That is the place where it becomes blind, and you actually have to unnecessarily use a lamina terminalis approach, which actually causes handling of the hypothalamus or the optic tracts. So that is the opticocarotid cistern. If you see, it's pretty small. You cannot take out the whole tumor out of that. But the moment you take off the falciform ligament, it becomes very big. I'll skip the video after that, then we can go back to the slides. But there's something very important. Then, because people say that they do a standard trigonal, but the tumor is not coming out. The tumor cannot come out because the opticocarotid cistern is small. And then you open the falciform ligament wide. The moment you open this, because the ACP is not there, you see, you're actually widened the opticocarotid cistern by nearly 3 times. And then you can actually decompress this tumor, dissect this tumor, preserve all the perforators. That's the key. Low CUSA and keep on decompressing. And you keep on mobilizing, and then it keeps on, like, this is the portion which is coming out of from the hypothalamus. I can actually skip this video now. We can come back to the slides. So these are giant tumors. You cannot do them endoscopically, and these are published already in the standard trigonal approach with the same ACP drilling. This was published last year in operative neurosurgery. I'll not go into the details of that. So adjuvant therapy, radiotherapy for residual and recurrent tumors. Modalities can be conventional RT, can be stereotactic. You have a cyber knife, gamma knife can be used. Targeted therapy, BRAF inhibitors for the papillary ones, and lifelong hormonal. What SRS and SRT, well, both are not so good. So if you, radiotherapy is an evil, is a needed evil, but you see, if you do give IMRT, the hormonal deficits will become 85 to 95%. And that's the literature. Which is a better knife? None is better. But among all of them, probably gamma knife is the best. But still, if you see the gamma knife results, cyst enlargement 30%, new visual onsets 20%. That's world series. Another paper 42%. So in BRAF inhibitors, they're coming in targeted therapy. They're coming in a big way. But still, a combination of BRAF along with RT is. So the main treatment protocol that we use, already published, is that the medically operative surgery is the mainstay. Go for a gross total resection. If it is near total, follow them up. If it is the subtotal, you can give radiation therapy. Medically unfit, either cyst aspiration or radiation therapy. Survival rates, high survival, but significant morbidity. Recurrence rates, high with incomplete excision. The visual, endocrine, and neurocognitive effects can be there. So what is the the surgical conclusion? The surgical conclusion is, if you have a pure midline tumor, an epicenter above the cella, very minimal to nil calcification with minimal to nil hypothalamic infiltration. The best approach is the endonasal transsphenoidal extended approach. It can ensure you complete ensure complete excision with preservation of the hormonal function, except your patient may be on vasopressin lifelong. And transcranial, if you have a tumor which is more lateral extension, heavy calcification, hypothalamic infiltration, a standard therional craniotomy with an OZ, you can just lower down the zygoma, and that you can complete excision. And if you have tumors going behind the dorsum cellae or in the posterior fossa, then you need to do an anterior transpetrous. I skipped that video because of time. And there the epicenter is behind the dorsum cellae. There is posterior fossa extension. Thank you. Thank you.
Thank you, Professor Suri, for very nicely depicting both the techniques. In multi-compartmental large craniopharyngioma, can it be taken out through transcranial anterior approach, or do you require separate posterior fossa approach?
Same approach, sir. Same sitting.
The
only difference is in that we take off along with the anterior clinoid process. I also do anterior petersectomy. So I have an exposure in front of the brainstem and behind the brainstem.
And secondly, what is your experience about the physical growth outcome in these children? Because they have short height, so do they need depot preparation, hormonal replacement therapy?
Hormone replacement as well as growth hormone replacement. That is something that our pediatric endocrinology is looking after. And
lifelong or for how many years?
So growth hormone replacement is still puberty, is still mid-teenage. That's what they give. But thyroxine, especially in pediatric, they will be on thyroxine replacement and on cortisol lifelong.
Or do they have some improvement in height also?
Some height, more than the height is usually not a problem. It is obesity which is a problem. Obesity, even with low dose of corticosteroids, they keep on becoming obese. They say that's because of the hypothalamic invasion.
And regarding this Omaya replacement, Omaya reservoir, so in cystic craniopharyngioma, I think you must be leaving the Omaya reservoir, I think, for future.
So I reserve the Omaya and the shunt for hydrocephalus, yes. Omaya only when the patient has already been given radiotherapy. I'm sure that even with the best surgery, I cannot completely take it out. I tried for a gross total excision because I think that's the best for the patient. But after radiation therapy, you cannot achieve a gross total excision. There, Omaya also helps.
Sometimes cystic craniopharyngioma, they recur. And after every 6 months, and they used to have fluid collection there. In such cases, I think better to leave Omaya.
Better to leave an Omaya, sir.
Because I have experienced that patient used to come after every 6 months.
You have to keep on aspirating.
Just tapping it and putting bleomycin.
Yes, sir.
Intracystic bleomycin.
We've given bleomycin, but we have realized that the only thing that helps is radiation therapy and repeat tapping of the Omaya. Bleomycin also really doesn't really help.
Thank you. Any comment or question?
Thank you, sir.
Along with my co-chairperson, I close this session. Thank you.
Thank you, speakers, for the informative session. And thank you, chairpersons. Now we will be moving ahead with our next competition, that is quiz competition. So I request our judges to come on the stage. Dr. Rajat Saha and Dr. Wazid Nazir, professor at GP Pant Hospital. I request judges to come on the stage. And I request all the resident participants to come in the front line as a team. Please have a seat.
Good evening, everyone.
Let it be a multidisciplinary quiz. Are there any pathology residents or radiation onco residents?
The faculty can stay back and encourage the residents, and we'll have some audience questions also if the faculty is around.
Each having neurosurgeon, medical oncology, neuro surgery.
Okay, are we ready? The teams are ready?
So Dr. Lakshya will be marking the marks. Each answer directly from the team who has been asked. If they are saying it correct, so 4 marks. And if they are passing it on, no negative marking. And the team which will answer 1 mark to that, bonus mark.
Passing रखने, passing रखने.
Passing. Okay, so we are not having passing marks. Okay, we will just have direct questions.
If a team is not able to answer, it goes to the audience. So do we have a multidisciplinary team here? Okay. Quick introduction while we are setting up. Team A. This is team A.
Sir, I'm Dr. Munira from GB Pant.
Okay. Neurosurgery?
Yes.
Very good.
Sir, I'm Akshay from GB Pant Neurosurgery, sir.
Okay.
Sir, I'm Dr. Bhumi Agarwal from Medical Oncology, RGCI.
Okay. Good.
So, Dr. Shilpa, RGCI.
Radiation.
Sir, I'm Percy, Pathology, RGCI.
Very good. So good balanced team there. Team A. Team B. Who's team B?
C से start कर. Team B. We are team B. We are team B or team C? Team B. Team B.
No one wants to be team B, huh?
We are team B. I'm Dr. Azhar, radiation onco resident, RGCI.
Very.
Dr. Shreyas from Medical Oncology, RGCI.
Dr. Sandeep from RML Neurosurgery.
Dr. Sampad from RML Neurosurgery.
Dr. Gagan from Vedanta Neurosurgery.
Okay, so 3 neurosurgeons, 1 medical and 1 radiation oncology there. Okay. Team C.
Dr. Charishma from RML Neurosurgeries.
I'm Dr. Anurag from RML Neurosurgery.
RML neurosurgery.
Neurosurgery.
Okay.
Dr. Rajpal, Neurosurgery from BLK.
Neurosurgery, BLK. Okay.
Dr. Krunal, Medical Oncology, RGCI.
Medical oncology. So we don't have pathologists there. We don't have a pathologist here. Okay.
Myself, Dr. Deepika, Radiation Oncology, RGCI.
Excellent. Good. So it's the questions are pretty simple. If you have heard the conference, I think so most of the answers would be ready by now. ऐसा है?
Basics.
Yes. Okay. So please, आप न्यूमेरोलॉजी के हिसाब से बी या सी चूज कर सकते हैं जो आपको ठीक लगे. जो आपको ठीक लगे.
So we'll be starting from team A.
So what are we doing? 10 marks for correct answer, no passing. 10 marks for correct answer, no passing, and the learned audience can answer if the questions are not. आपको छोड़ के किसी को भी ले सकता हूँ. Team B. Okay, medical onc. Okay, team B. Okay.
Team B.
Fair enough. So हमारे टीम में सिर्फ न्यूरोसर्जन्स, रेडिएशन, मेडिकल, पैथोलॉजिस्ट हो सकते हैं. गूगल बाबा नहीं हो सकता है. So please refrain from using your phones. अभी तो खुला था. I think so. Most of the questions are arranged in an MCQ format. So I think so. We'll keep around 20 seconds to 25 seconds. I need one timekeeper. One timekeeper. So all the
बंद कराना सर वो.
So let me just ask our quiz masters of the day, Dr. Wajid Nazir from GB Pant. He has formulated the questions. Dr. Kaviraj Kaushik from our own institute, neurosurgery, has formulated the question. Dr. Anila and Dr. Garima from pathology have formulated the question. I've just assimilated the questions. So any correct, wrong, or discrepancies, they are the ones to answer.
Goes to the moderator.
So we have arranged the quiz into six rounds?
Yes. Headings.
Six rounds. One will be a neuroanatomy round, basic neurosurgery round, radiology round, radiation onco round, med onc round, and genetics and pathology round. Okay. अगर ऑडियंस में कोई है तो एक ऑडियंस क्वेश्चन पूछ सकते हैं तब तक.
Lot of audience there.
Huh? Okay. 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 So the first very simple audience question: meningiomas generally arise from which cell of origin? What is the cell of origin of a meningioma? Not you. You are one of the quiz masters. Meningiomas arise from which cell of origin? What is the cell of origin of meningioma?
No, you can answer without options.
It's for the audience. इसमें अगर इस क्वेश्चन में पैसे नहीं हैं तो don't waste your time and energy and stamina in answering that question. No? For the पैसे की बात आई तो we have got prizes for the team first, second and third. हाँ? वैसे भी प्राइज? हाँ? प्राइज तो मिल ही जाएगा. प्राइज तो मिल ही जाएगा. There are no losers here. Okay, answer. Okay, none from the audience. You can get it. Arachnoid, dry cells, villi, cap cells. आपका गूगल मेरे गूगल से अलग है क्या? मेरा गूगल arachnoid cap cells दिखा रहा था. आजकल जेमिनी, चैट जीपीटी बहुत कुछ आ गया है. Yeah, first time CNS.
Almost there.
So pretty enriching talks today. Means I learned a lot today. A lot of new topics, lot of dynamic topics. Very, very interesting today's conference.
Okay, I think we can start with the first from, this is a visual round.
Visual round, team A.
Team A.
You have a mic? You have a mic? You have a mic.
You have to identify. Identify this most accomplished doctor of the 20th century. There is no negative marking.
Time up. You can start with Donald Trump, Joe Biden. कुछ भी कर सकते हैं.
Is he Lars Lexel, sir?
Huh?
Lars Lexel.
No.
Okay.
No. Open to the audience. Open to the audience. नहीं? Open to other teams? Without. Harvey Cushing is the answer. Father of neurosurgery. Oh.
There was no negative marking. So but you can make only one attempt. There's no two attempts. So think now team B.
Team B.
Identify
Team B. This is team B. Identify this renowned physician.
Igas Moniz.
Huh?
Igas Moniz.
No. No.
It goes to the audience.
It goes to the audience. Goes to the audience. See, it is definitely not film industry. It is connected to neurosurgery and neurosurgical or neuro-oncology. So you have to make guesses according to that. Anybody else?
No guesses there?
No guesses? Okay. It's Roger Stoop. So Stoop's protocol comes from Roger Stoop. Okay? From Switzerland.
We are at 0.
Yeah.
Team C.
Team C. Identify this another
one
pioneer. Rest of the quiz is easy. ये tough round था.
It was to just make you concentrate for the subsequent rounds.
Anybody else from the audience? Or from other teams? Huh? So this is Claudius Rigord. Claudius Rigord is the father of radiobiology and radiotherapy. So very
The end of
accomplished.
round 1, it's simple. We are
So this is round 1. Starter round. How's the Josh?
Now,
how's the Josh?
You got your attention now, huh? Now, good. Now, let's go to basics.
Round 2
Team
starts again from
A.
team A.
Incongruous field effects are due to lesions of optic nerve, optic tract, optic radiation, or occipital visual areas.
There is it is optic radiation.
आप लोग आपस में डिसाइड करके एक आंसर बोलेंगे और वही आंसर होगा.
They answer 2.
Optic nerve.
Wrong answer passes to the audience and or other teams without any marks. Optic tract.
Optic tract.
Optic tract is the right answer. So you have to make the job of the scorekeeper a little bit more tough. अभी तक बहुत आसान काम कर रहे हैं. उनको इस चीज के पैसे नहीं मिल रहे कि सबको 0-0-0 मिले. कुछ तो काम कराना पड़ेगा ना उनको.
Team B. In percutaneous radiofrequency retrograde rhizotomy, which division of trigeminal nerve is likely to be stimulated? Tip of electrode is at the level of clivus. V1, V1, V2, both, or only V2 or only V3?
V2. V2.
Your answer?
Yeah.
Good. Correct.
Okay.
Started.
So Khata Khula, Team B.
So team C. No. In spinal metastasis, which of the following is the most common site of epidural tumor extension? Metastasis, remember. Anterior epidural space, posterior epidural space, lateral epidural space, or centrally located epidural space. There's no negative marking.
C.
Audience goes to the audience.
So, posterior epidural space.
Metastasis. Made emphasis on metastasis.
Dr.
Not-
Kaviraj, are they right?
Yeah, that's infective and all. They'll be posted. It's anterior.
Anterior epidural space is
Okay,
the
we
right
are-
answer.
The second round is over.
So second round is over. I think so. Dr. Lakshay, scorecard till now? Yet to open the count. Okay. Lot of more rounds. और भी 5 rounds हैं. आराम से खेलेंगे.
Okay. Now it's for genetics and pathology.
Okay. So genetics and pathology, team A. Which spinal tumor is most commonly associated with von Hippel-Lindau disease? मैं choices दूं कि रहने दूं? देना है. अच्छा मैं सोचा नहीं.
Sir, it is B hemangioblastoma.
हाँ तो इसलिए मैं choice नहीं दे रहा था. Come on. Okay. 10 marks, straight points to team A. So von Hippel-Lindau, I just picked up. It is basically hemangioblastomas, renal cyst, pheochromocytoma, leiomyosarcomas, and just an extra information, which drug has recently been approved for renal cell carcinoma arising secondary to von Hippel-Lindau syndrome for medical oncologists in the team? It's a very recent drug.
Consolation prize.
It's Besultifan. So it'll come in our textbooks in a few months. It has been recently. So direct question to team B. Subependymal giant cell astrocytomas are associated with which of the following disorders?
Tuberous sclerosis.
Tuberous sclerosis is the right answer. Good. Easy question को लोग ताली भी नहीं मारते हैं. Come on. So it is tuberous sclerosis is the right answer. And it is basically an autosomal dominant disorder. And generally the first manifestation in the young children is epilepsy. Direct question to team C. Optic gliomas associated with which of the following disorders? NF1 is the right answer. Is the right answer. ये वाला first round रखना चाहिए था हमको. Everybody has got it right and all the teams have got straight 10 marks. So and NF1 is the right answer. So moving on to the next round, again, it is from pathology mainly. Which is the best combination? Now, अभी आपको कमी महसूस पड़ेगी pathologist की. कौन सा group को? इस वाला को अच्छा. Which is the best combination of immunohistochemical markers to be applied? So 10 direct points to team A. Team B. Ependymomas would commonly accept.
S100. S100.
S100.
Sir, it is OLIC 2.
Audience, na? It's OLIC 2.
We have
There's
not
no
kept-
pass on marks in a multiple choice question, madam. A, B, C आप कर लेंगे, आप D करके क्या कर लेंगे आप? ठीक है? So it's OLIC 2. So they don't get any marks. Team C. नहीं. आप अपना पूरा लीजिए ना 10. Team C. Which of the following is the most common molecular alteration in glioblastoma that is associated with a poor prognosis?
Think answer. Give your final answer.
IDH1.
IDH1, poor prognosis, is the wrong answer.
It is EGFR amplification.
EGFR amplification
You
also.
cannot use so many answers. This, MGMT.
नहीं, गलत आंसर बोल दिया. गलत आंसर बोल दिया. So answer is
to discuss
TERT.
TERT is
TERT.
correct.
So TERT. It's a multidisciplinary board. Please discuss
okay.
amongst each other. That is the whole purpose of the quiz. So I think so this round is finished. So at the end of this round, if we have the score.
Third, huh? Okay, we'll start with round 4.
Round 4.
Based neurosurgery again. Okay. Which classification or scoring system is commonly used to assess the spinal instability in metastatic spinal tumors? SINS, KPS, McCormick, or the Takahashi score?
Sir, SINS.
Final answer?
Final answer.
Correct.
Is the right answer.
Team B. Spinal navigation system in spine tumor surgery is mainly helpful in
Team B.
Team B. Enhancing hemostasis, reducing operative time, the tissue trauma, precise
reducing
localization of
operative
spinal-
time and tissue trauma.
Consult among
Consult
yourself,
karo.
don't rush. I have not read the
Precise
full
localization of the spinal level.
precise localization of the spinal cell. Okay. It is the answer. Audience, do you want to check? You should at least take time to read the 4. You did not let me read out the 4th one.
The answer is D. Please don't jump. You have got 20 seconds. Timekeeper is giving you 10 seconds extra also. आपको पता भी नहीं चलेगा. लेकिन please discuss.
Okay, now team C.
Direct question.
In spinal oncologic surgery, what is the primary purpose of using expandable titanium cages in reconstructive procedures? Is it to enhance spinal flexibility, to provide immediate stability and support, to reduce the surgical time, or to prevent infection?
Is the right answer. Good. So at the end of round 4, this is the total score or total?
30, which is 30 is B. Oh, A has
30
taken
is
lead.
A. Okay. So 30A hai. Acha. So that's why we are reversing the round order now. ताकि bias ना बोलें आप लोग. Team C gets the first direct question now.
But
Okay.
we have many-
Doesn't matter. हम करें. So Team C gets the first. Radiation oncology. What is the rationale for using proton beam therapy over conventional photon therapy in the treatment of pediatric CNS tumors? Dr. Jalali has spoken on it today morning. No, it's not yours. It's Team C.
Better sparing of healthy tissue due to Bragg peak effect.
Yes, perfect, perfect. So that is a good straight answer. Very good. So the Bragg peak effect is there, rapid downfall of the energy of the ray just after a certain depth. Next question, please. Team B. In the context of re-irradiation for recurrent glioblastoma, what is considered a safe cumulative dose limit to critical structures such as optic chiasm when using stereotactic radiosurgery or fractionated radiosurgery? Re-irradiation for recurrent glioblastoma. Dr. Parveen Ehlawat had given the first talk in the morning on re-irradiation in recurrent glioblastomas. What is the safe cumulative dose?
C.
Option C is the right answer. Team A. Which of the following is the primary advantage of using IMRT in CNS malignancies?
B.
Option B is the right answer. Very good, very good. So this is called multidisciplinary action. पहले न्यूरोसर्जन्स ने क्वेश्चन पढ़ा, समझ नहीं आया, फिर फटाफट माइक रेडिएशन ऑन्कोलॉजिस्ट को पकड़ा दिया. अच्छा, you already said we. So there are always intelligent neurosurgeons who know a lot of things apart from their own branch. Okay, so this round is, I think, finished.
No, I think it has more.
No, I think so. नहीं, हो गया. ठीक है. Okay. So round 6 is.
कैसे चले? BAC, CAB,
कैसे भी चल सकते हैं. बस आपको स्कोर कीपर को कंफ्यूज नहीं करना है, बाकी सब कंफ्यूज हो सकते हैं. So team B, direct question to team B. Okay, BAC ऐसे जाएगा. Which drug in recent studies has been shown to act as a radiosensitizer along with temozolomide in brain tumors? It is still in the phase 1-2 studies, but it is a very good proof of concept that it can be used as a radiosensitizer along with temozolomide in brain tumors. इसमें ऑप्शन नहीं है. ऑप्शंस की इतनी आदत नहीं पड़नी चाहिए कि हर चीज में ऑप्शन मांगो.
The brain teaser round.
Any wild guesses? Huh?
You can say there is no negative mark.
There is no negative marking.
Devasi ji, ma'am.
Is not the right answer. Anybody else?
Metformin?
No. Anybody else? No. So it is actually olaparib. Olaparib is a PARP inhibitor. It causes synthetic lethality. It causes DNA damage, and it can potentiate the DNA damaging effect of radiation therapy. Has been tried in phase 1, phase 2 studies of the operatic trial and the paradigm 2 trial. They are yet to find the perfect dose, and then probably it will be launched into a phase 3 trial. Direct question to team A. Team A, huh? Recently developed a drug specific to the H3K27M midline diffuse midline gliomas. It has been recently approved. FDA approval मिल गया है. Options नहीं है. This is a deadly midline glioma. This is the importance of doing nowadays NGS on our tissue samples, because we tend to get certain markers which can be targeted.
Bevacizumab.
No. Bevacizumab, no. Bevacizumab is a generic drug, anti-angiogenic drug. It is not a targeted drug. Anybody else? Anybody else? No. Okay. So this is Onc 201. The chemical name is Onc. It is dordavipiron. It is a dopamine antagonist, and it has been approved for use in H3K27M midline gliomas, and also they are also trying to use it in recurrent glioblastomas also. Tough question ho gaya na? Team C. Which drug has been approved for IDH mutation gliomas?
Team C is looking in Google, Baba.
ये भी आंसर अभी डॉक्टर पीयूष वाजपेयी ने अपने टॉक में दिया था. नहीं, डॉक्टर दीपम पुष्पम ने दिया था. So all the questions basically are revolving around the topics which have been discussed here. This is a targeted therapy. Yes. So that is the importance.
Loracetinib.
हाँ, बताओ. Vorasidenib, I can give it to you. Vorasidenib is the right answer. Vorasidenib, very good. So vorasidenib is the right answer. Ivosidenib is another answer. So these are the family of drugs which help in IDH mutation tumors. R132H tumors में बहुत अच्छा काम करता है. So this ends the next round, and we have the scores after round 6. Do we have? Or okay. So I think so that's the end of the quiz. So we had 6 rounds, simple questions.
इसमें टाइम लिमिट हो गया था.
किसमें? हाँ, इसमें टाइम लिमिट हो गया था।
मैं गूगल कर लेता हूँ।
आपके चिप में है क्या गूगल?
That is not yet.
अच्छा, ओके ओके ओके।
Can we have the
चलो।
scores, please?
बट ये टंग ट्विस्टर भी तो था ना, इसको बोलने में भी तो टाइम लगता है। ओ, टीम ए एंड टीम सी आर सिटिंग एट 40। तो डॉक्टर वाजिद, हमने तो टाई ब्रेकर क्वेश्चन भी तो है हमारे पास। वी हैव लॉट ऑफ क्वेश्चंस। सो वी हैव गॉट टाई ब्रेकर क्वेश्चंस, हमें पता था ये होने वाला था। सो ओके, सो इसमें इट क्लियर का टाई ब्रेकर, whoever answers first wins. ओके,
नहीं, we are asking A and C.
हमने क्विज फ्लैश कर दिया, क्वेश्चन फ्लैश कर दिया, आप आंसर करिए। आएगा ये ऑडियंस में, बट लेट अस सी। एक बार हम लोग डिसाइड कर ले कौन सा पूछना है। हाँ, एस्केप करने से
Let it be now.
नहीं, टाइम कंस्ट्रेंट है there.
A sudden death.
आईटी
हम चाह रहे थे
इससे चल रहा है। हाँ हाँ, बिल्कुल ऐसे ही पूछ लो। तो इनाम सबके लिए है। अगर मानो टाई ब्रेकर क्वेश्चन हमें नहीं मिलता है तो इनाम भी बढ़ जाएगा।
हम दो हटा दीजिए,
वैसे ही दिखा दो,
हटा के प्राइस भी हटा दीजिए, सेकंड पे ही हम लोग संतोष कर
राइट शो में डाल दो बस। ओके, ये क्वेश्चन ही नहीं था। ये हमारे लिए था।
मिलने चाहिए सर,
ये हमारे लिए था।
मिलने चाहिए।
दिस क्वेश्चन इज फॉर आवर आईज ओनली। आपके आईज के लिए है ही नहीं। ये हमारे इंटेलिजेंस लेवल का क्वेश्चन है, आपके इंटेलिजेंस लेवल का नहीं है। आप लोग टॉपर्स हैं।
Let that be blank.
ओके, हाँ।
वरना वो फास्टेस्ट फिंगर नहीं हो पाएगा ना। हाँ, ऊपर है। ये हो गया।
ये ओके ओके, ये फ्लैश करें। ओके, नहीं ये नहीं रुको। क्वेश्चन वैसे ही पूछूंगा। पहले बिना चॉइस के पूछूंगा, फिर चॉइस दूंगा। Which of the following is the most common site for leptomeningeal dissemination in spinal in the spinal tract? Which of the following is the most common site for leptomeningeal dissemination in spinal tumors? Most common site, region wise.
Oh, no. Everywhere, brain also.
ऑप्शंस वही है सर।
Options दे दें। अच्छा,
The leptomeningeal dissemination, it can be distant also. Yes.
which
Craniospinal
commonest part of the
axis,
same?
all craniospinal axis.
Option दे दें। Ready? Cerebellum, basal cisterns, cauda equina, frontal lobe.
Cauda equina.
Cauda equina is the right answer. Basal cisterns wrong answer. Cauda equina is the right answer. So I think so that was the tiebreaker question. It was only one question. And I think so Team C is the overall winner of this neuro-oncology quiz.
Okay. Oh, right. Thank you.
Thank you. Thank you.
Thank you, everyone, judges and participants. Let's move towards the next session. I request Dr. Prakash Singh, Unit Head Neurosurgery, Max Hospital, to come on stage. Sorry, Dr. Anil Kansal, Principal Director, HOD, PLK Hospital, to come on the stage. Dr. P.N. Pandey, Professor and Head of the Department of Neurosurgery, LNJP Hospital. Aram. I request Dr. Puneet Kant Arora, Consultant at Manipal Hospital, to come on the stage. And Dr. Rahul Vashane, Associate Professor at RML Hospital. I request all the chairperson to come on the stage.
Last session. Yes. Okay.
उसमें जो ऑप्टिक इनकॉन्ग्रुएंस लीशन था वो also because of optic radiation
आता है बट मेनली ट्रैक्ट से
radiation option
ठीक है फिर गूगल लेके आगे तुम I believe that we are for the last session for the day. Okay. We'll be beginning this session with the talk of Professor Anita Jagitia, who is Director Professor and Head of Department of GB Pant Hospital. So she'll be talking on insular gliomas, surgical approaches.
Good evening, all. And thank you, Dr. Prem Sagar and chairpersons for giving me opportunity to talk on this. And we all know that there have been many changes and even surgical strategies in insular glioma since last 2 decades and now. When during my residency period, I used to think very difficult tumor, not all cases get good excision, not very good surgical outcome. But over last 2 decades, please change कर दीजिए इसको. अच्छा मुझे खुद ही करना है. इंसुलर ग्लैमा, हाँ यही वाला. ऊपर ऊपर ऊपर. So one need to know the surgical anatomy well to understand the insular glioma. It's not very difficult actually once you know the surgical anatomy. This mouse is running anywhere. Can I use the pointer from the, no, it is running away. Yeah, it is pointer is here, no? Laser point. Yeah. So, we all know that insular cortex was named by a neurologist, German neurologist J.C. Riehl. And this is the area which is very deeply located and covered by frontal, temporal, and parietal lobes. And it starts from the 5th week of gestation, and by the end of gestation, it is covered by all the opercula. So it becomes very deep-seated region in the brain. If we see as a surgeon's perspective, this is the after the opening of the Sylvian fissure. If you imagine when you are doing any aneurysm surgery, we see many structures at the base, especially the IC aneurysm. You see the internal carotid artery, and when we open this Sylvian fissure, the whole Sylvian fissure, we reach in the area which is where in the base of that area we find many vessels. So this is the triangular area which is insula. It is not at the surface. It is deep inside the Sylvian fissure. So if you see, there is one central sulcus which divides this area into posterior and anterior. Then you have the periinsular sulcus. One is anterior periinsular sulcus. Anterior to periinsular sulcus is a short gyri. Then you have another periinsular sulcus, which is superior and inferior. And between the superior and inferior peninsular sulcus and the central sulcus, we have the long gyri. So they are around 4 to 6 gyri in this insular region, and it is supplied by mainly the branches of the M2, and we have many small perforators which are supplying in this area. And since it is deep to the Sylvian veins, it is drained by the Sylvian fissure. So you need to understand this anatomy, because the surgical approaches are based on many things, and one of the surgical approaches transsylvian. So you need to understand this whole anatomy. And when we are seeing internal carotid artery, we are seeing the optic nerve somewhere here, and in the basifrontal area we have the olfactory tract. So this is the surgical anatomy. And if we see, the insular cortex is connected with many areas in the brain, and this is highly connected with many cortical and subcortical structures, and that is the reason insula is the structure which is involved in many functions like sensory, emotional, motivational, reward, defensive, then cognitive functions, and neuromodulation. So if you see, insula is involved in sensory information, integration, brain network switch, risk assessment, outcome prediction, emotion, decision making, interoception, autonomic control, and behavior is also controlled by this structure. So if we are managing or finding the which approach is best, how to choose the approach, and how much resection is actually going to give you good outcome. So you have many parameters: is anatomical dissection, structural and functional imaging analysis, language, motor, cognitive mapping, use of navigation in the form of ultrasound or navigation itself, and high field intraoperative MRI. So standard imaging sequences which we get are T1, T2, and contrast. But actually, FLAIR is equally important. We'll get to know why. Diffusion tensor imaging is very essential. In fact, for all glioma patients, you should have all these images. And in DTI, you may get displaced, involved, or distorted tracks. And these images are to be incorporated in neuronavigation to assess the resection and to actually sometimes to get where the tumor is. So when we see the tractography, we see so many tracks, and especially in this area, this is insula. So you have one tract, inferior orbital occipital fasciculus. This is from anterior to the posterior right up to the occipital area. So we have three main functions which are related to these fascicles, white matter tracts. One is corticospinal, that is motor, that we all know. But there are two special things. One is ventral language pathway and one is dorsal language pathway. So it is not only that left side of insula is responsible for the speech. It is the right side as well. If we see, the ventral language pathway is controlled by the inferior frontal occipital fasciculus and inferior longitudinal fasciculus. Then dorsal language pathway, they are under the control of arcuate fasciculus and in superior longitudinal fasciculus. So this is superior longitudinal and this is arcuate fasciculus over the parietal area, arcuate area. So we need to understand this anatomy and we need to see where are they displaced. Are they displaced or they are infiltrated? Initially, this classification of the insular gliomas, it was proposed by S.R. Gill, and it was actually given along with the limbic and paralimbic tumors. The Sylvian was one of the part, and we all know that this insular part is in connection with many adjacent structures like orbitofrontal, temporal pole, medial parahippocampal and hippocampal gyrus, amygdala, and so many structures, they are involved. And in type 5, S.R. Gill's classification, these structures may be involved, although that classification is not very routinely used. This is insula, and medial to the insula, we have all important structures, especially the corticospinal tract and related gray matter nuclei. So if we see the S.R.Gill's classification, it is type 3 and type 5, which are actually talking about insula. Other types are about the other paralimbic system lesions. Type 3's A is isolated, involving only the insula, and 3B is involving the other opercula also. 5B is, it is going into the temporal area, then temporal frontal, and type 5A not going into the paralimbic system, whereas 5B is involving the limbic system. It is infiltrating the hippocampus and other structures. But this classification is not very routinely used because it doesn't talk about based on this classification, what approach is to be used, what is the outcome. So this classification is not very routinely used. However, as a surgeon, we need to know this, that what all structures are involved. If paralimbic structure is involved, how your strategy to remove the tumor will be changed. Then came the Burgess and I classification, which is in sedge cut, that is not midline, it is a paramedian cut. You see that you'll draw a line from foramen Monroe to the Sylvian fissure, and it divides this area into superior, inferior, anterior, and posterior. So we have zone 1, zone 2, zone 3, zone 4. It goes in the anti-clockwise direction. So zone 1 and 3, they are the language network area. Then we have primary motor area, which is motor and sensory area, which is zone 2 and zone 3. So these are motor sensory area, and this is speech language area. And this is the area where that is 4 zone, lenticulostriate arteries are there. So when we are seeing the tumor, majority of cases, what we in government setup, we get the diffuse tumors. So if a patient is having involvement of all 3 zones, they are diffuse or the giant gliomas, and you may have all this kind of either one zone is involved or all the zones are involved. So what is the goal of surgery? Goal of surgery is maximal safe resection. As even the low-grade glioma, if you are aggressively resecting, the seizure, patient gets seizure freedom, there is decreased malignant transformation, and there is improved overall survival. And there are reports which say that up to 98% patients get seizure-free by the surgery. And of course, this all depends upon the extent of resection. What about high-grade tumors? There also the survival is improved, and FLAIR is essential because if you are thinking that this is high-grade tumor based upon the radiological picture, the resection of this FLAIR area, up to 53% of the FLAIR abnormal area, that will increase the survival. So if more than 90% excision is there, then it leads to 100% 5-year survival. And when it is less than 90% resection, then it is 84%. And for high-grade tumors, the more than 90% excision gives 2-year survival of 91% versus 75% if it is less than 90%. So cytoreduction is the main goal. That should be the main goal. This is an example. If you see, this is tractography, and here this is screen, which is displaced medially, that is corticospinal tract. Here is the inferior frontal occipital gyrus, which is displaced downwards. It is not infiltrated. And this is the arcuate fasciculus. Then you need to have the complementary technologies available to you, as were discussed in the previous talks. The suction stimulator, Dr. Ashok talked about the intraoperative monitoring. That is very, very essential. And the Cadwell and Inomate has this suction stimulator cannula, which has got both suction and stimulator, and adjuncts which are essential and that should be actually used is ultrasound, ALA, and of course TTI. So what are the predictors of outcome? Poor outcome is grade 4 glioblastoma, advanced aged, and low KPS score. Favorable outcome, less age, less than 40, grade 1, 2, 3 WHO, yes, Argil, 5AB, 5B tumors, they have better outcome than 3, because there you go inside the, at the level of tent, and you can cut and can remove the tumor. So there are two approaches which are described, transsylvian and transcortical. We all know that transsylvian approach is like any other Sylvian fissure opening, but here, in these cases, the Sylvian fissure may not be so good. It may be wide at certain areas, and it may be infiltrated with the tumor at certain areas. Awake craniotomy and cortical subcortical mapping is, if you have, that is nothing like that. And meticulous supraciliary dissection is important to avoid injury to the lenticulostriate vessels, which are supplying this area. Awake craniotomy definitely gives you added advantage if your patient is cooperative, and there from 19% to 19% impairment, that decreases to less than 4% when you are using mapping. There can be complications, and complications they have been reported as up to 20 to 26% for 3 months. However, with supraresection, patients may improve with time if they are having deficit during surgery. So one thing is very important. Don't give any dehydrants when you are removing these tumors, because when they are low grade, you will not be able to differentiate them with the normal brain. You dehydrate the brain. One thing. And second thing is, the distinct beige color of the striatal nuclei is your limit. That will tell you the medial limit. So if you are not able to open up the Sylvian fissure, you go to the base of the brain, open the cisterns, carotid, optic, and other cisterns, and then you can relax the brain. And thereafter, you can go superiorly to follow the MCA and dissect. And transcortical approach, best is, there are two approaches, transcortical. And nowadays, people are saying transcortical approach is better, but provided you have the mapping during transcortical. And there you open different opercula and then remove the tumor. And then you go inside the insula. So these are few examples. This was a 12-year-old boy who presented to us with some neurological deficit, 3/5 power. And this was the MRI of this child. And you can see this is so extensive tumor. It doesn't fit into any grade except the Yesargel's grade 5, where it is going everywhere, medial, lateral. And if you see the Sinai classification, Burgess Sinai, this falls in, it is involving all four parts of the insular area. And so this is kind of giant insular glioma. You should use intraoperative ultrasound. This delineates your tumor, because you'll not be able to remove the whole tumor. That is not the aim for this kind of tumor, at least. And navigation, of course. कैसे चलेगा वीडियो? हाँ, okay, I can't control the video speed and forward backward. नहीं होगा, escape करके. Escape करके without this we can do that, na? Sure. So this is you're seeing that there is this tumor is coming on the surface. You can make out this brain when we compared with this part of the brain, and this is transcortical approach where you are directly attacking the cortex. You have to do this in this case because the tumor is coming on the surface. Otherwise, you should do ideally the mapping if you are doing transcortical and if the tumor is not coming onto the surface. This is whole tumor which is there. इसको forward नहीं ले जा सकते. Yeah. You're seeing the temporal base. It was going into the the limbic area. So you reach to the base of the brain. You learn this, removing opening the tent and all when you're doing the epilepsy surgery, because this is a routine area where you go in the epilepsy surgery. This is the tentorial margin. Here is the fourth nerve which is running. This is the fourth nerve. Here, yeah, medial to the tent. This whole is tumor. This is the fourth nerve under the tent. And you have to cut the tent. This is the area which is cut usually when you are you want to release the uncus in the tentorial herniation behind the fourth nerve. This area, this tent is very vascular, so you should do cautery, and rest of the bleeding can be stopped with a Surgicel. So this is one of the transcortical approach. This is another case where the tumor is diffuse, it is large, but not coming onto the surface. And this is MRI FLAIR image. This is Transylvian, opening the Sylvian fissure. Can use sharp dissection, needle, scissors. Thereafter, you have to be very careful that don't coagulate any vessel perforator which is coming in the way. Finding the plane of the tumor. Use CUSA if available to you. This is the edematous part. You'll see that the tumor part is usually grayish. You can remove this edematous part in the high, if you feel that your radiology is showing high grade or your frozen is showing high grade tumor. This will give you better survival. And you can use fluorescein or ALA that helps you in identifying the tumor. Of course, not for the low-grade tumors. This is a post-operative scan. So there is some residual left here. So these are the giant tumors where the tumor is coming onto the surface. And these are the tumors where transcortical approaches are good. And if these are where there's too much edema, you can't open, you can directly go to the basal cistern, open these optic cistern, carotid cistern. There you can drain the CSF and you can get better brain to remove these tumors. These are the tumors where you are seeing you are seeing good sylvian fissure, and you can approach directly through the transsylvian. This is a tumor which was again giant, and transcortical route was taken. And this is pre-operative. Here is the post-operative. Patient has no deficit. So to conclude, transsylvian and transcortical approaches or the combined approaches are there for the insular glioma, but you need to master them. You need to understand where is the lesion, what the DTI is cause DTI, what is the finding in DTI. Use adjuncts for safe resection. Try to get safe and maximal excision, and definitely follow-up has to be done to see the recurrence. And even the recurrent tumors, excision gives you better survival than leaving them behind. Thank you.
Thank you, ma'am, for taking us through the basics of the insular area, the anatomy, classification systems, the adjuvants available, surgical approaches, and even the prognostication. Any questions or comments?
Ma'am, when you're dissecting the zone 4 tumor away from the lenticular stride, do you employ any specific surgical strategies to avoid, because that is something that we cannot map, and it can be almost catastrophic to damage those lenticular stride vessels. And even after taking out a large tumor, giving the patient decent survival, giving hemiplegia will cause a very significant morbidity. Is there a way to surgically dissect those vessels away, or to know where we are, or is it just neuroanatomy based, or just an instinct?
Yes, you're right. That is the reason the zone 4 involvement tumors have got the worst prognosis if they're in the zone 4. So of course, surgical skills, strategies, not very great. It's like any other Sylvian fissure opening. So try to avoid coagulation as much as possible. You can keep the cotton patties. Rather than that, you can keep the gel foam where there is not much rubbing of this, and or the glove cut pieces. They're they are the better way. Definitely, you're right that type 4 has got the worst prognosis because of the same reason. But don't afraid of not removing the tumor, because even if they get some deficit, that may be transient, because you're not going to cut all the lenticular stride. There are 20-30 vessels perforators which are supplying that area. Yes, sir. CT angiography will not give much information about perforators. Yes, yes. Yeah, but for smaller vessels, CT angio will not give so much information. Not even the DSA can give that much information. So small perforators are there.
Ma'am, what is your comment on role of awake craniotomy in a high-grade glioma in an insular region, ma'am?
High-grade glioma?
High-grade glioma in an insular region, the role of awake craniotomy, ma'am.
Yeah, that is best, no doubt about that. If your patient is conscious enough and cooperative enough with awake and with neuro monitoring, that is ultimate. But of course, the problem with that, sometimes you leave so much of the tumor when you are doing awake and using the monitoring. You are afraid of small deficits also which are happening in TROP, but that is a risk associated with that.
The balance between that awake craniotomy and deficit versus leaving behind a high-grade tumor, where do you keep the balance, ma'am?
Definitely, you can do not awake, but with monitoring, and you can, or you can do one thing that small deficits which you are getting, then you can avoid that. Use the DTI, and proceed your excisions based on the DTI.
Thank you, madam, for the beautiful talk. Now I would like to invite Dr. Harsha Agarwal to speak on neuropsychological evaluation in brain tumors. Neuropsychology is an integral part nowadays. Apart from evaluating in neuropsychology, the goal is to preserve the psychological aspect of any tumor. So, madam, please speak on it. Thank you.
Thank you so much, sir. Uh, After having a very good, enriching talk since morning, so though I have prepared a very short slides, still if we are running short of time, I still have a shorter version which I can go for. So, as neuropsychological evaluations in brain and tumor patients, as sir said, it is a very important aspect uh, for seeing patients and crucial insights into cognitive functions and help tailor treatment strategies to optimize the outcomes. So first, we have known and have been studying about the brain and behavior relationship. First, about the cognitive functions. So, neuropsychological evaluations assess a wide range of cognitive abilities, including memory, attention, language, executive functions. Related to brain regions, these evaluations help identify the specific brain region involved in the cognitive processes, which is crucial for understanding the potential impact of that tumor in the particular region. The tumor location depends, depending on the tumor location, different cognitive functions may be affected, requiring tailored intervention strategies later on in the rehabilitation phase. And patient's life, regarding patient's life, these evaluations, neuropsychological evaluations help understand how the tumor affects patient's daily life, providing a holistic view of their needs. Now, so it is like a baseline assessment. The role of baseline assessment, or I would say the role of neuropsychological assessments, are critical across all phases of brain tumors, pre-surgery, during surgery, and post-surgery to ensure comprehensive care and optimal outcomes. So, when we are talking about pre-surgery, the baseline evaluations establishes a detailed baseline of a patient's cognitive and psychological status. Majorly components which we look out in the pre-surgery phase to establish the baseline are, for example, memory, attention, executive function test, emotional and psychological well-being assessments. What is the importance of doing such tests are, it provides a reference point for detecting changes post-surgery, inform surgical planning by identifying cognitive areas at risk, and perhaps patients and families are for potential, it prepares patients and families for potential cognitive and psychological impacts of surgery, and which helps in making the right kind of decision for the what kind of treatment a patient and the family would like to choose for. During surgery, when we have already done the baseline assessments, during surgery, the intraoperative monitoring real-time assessments to monitor cognitive function during awake brain surgeries really helps in guiding the surgeon to preserve essential cognitive functions, minimize the risk of post-surgical cognitive deficits. For the techniques which are usually used are language and motor function tests while the patient is awake, and continuous feedback from the patient to avoid damage to the critical brain areas. Now, tailoring the surgical approach and rehabilitation surgery. So, pre-surgery and post-surgery phases. In pre-surgery phases, as we have used the baseline assessments, these identify the cognitive strengths and weakness to help the planned surgery. In the post-surgery phase, provides individualized rehabilitation plans based on the patient's specific cognitive needs, which we have done in the baseline tests. In the pre-surgery phase, the assessment guides decisions about potential surgical risks which can be there, which we can map during the awake chronotomy phases, having the neuropsychological evaluation and assessments during the procedure. Post-surgery, this helps track the patient's progress during rehabilitation phase and adjust the plan as needed. Informed in the pre-surgery phase, when the patients are known about the potential cognitive changes, they are more informed about what can be there and what currently are there and what we can look out for in the future. And for the post-surgery phases, provide support and guidance to the patient and the family to navigate the cognitive challenges which the patient is going to face, and which are really potential, and the rehabilitation course can be dependent on that, and individualized tailored plan can be made for that. Monitoring cognitive changes pre and post surgery really helps in For example, in pre-surgery monitoring, it can help track cognitive changes, and post-surgery phases, it can help in evaluating what the crucial decline in cognitive abilities are there, which were not determined in the baseline testing. It also helps in tracking the prognosis by tracking cognitive functions over time. Neuropsychologists can assess the long-term prognosis and provide personalized support and guidance to the patient and family, which also has a critical impact on the quality of life of, and patient-centered care. Now, when I'm talking about improving quality of life, it how it helps, how neuropsychological assessment or evaluations can help. First is with the emotional well-being. Neuropsychological evaluations help identify and address any emotional difficulties arising from the diagnosis and treatment process. It supports and provide guidance to patients and the families as they navigate the challenges of brain tumor treatment, what the treatment is all about, what they have to look out for, how they can go about for it, what all the challenges they are going to face, and how they can deal with them. A proper neuropsychologist play a key role in educating patients and their families about cognitive changes and potential challenges which are going to be faced by them. Patient-centered care, by understanding the patient's unique needs. Every individual is different. We cannot generalize even with the same diagnosis, same kind of age, same kind of procedure which a patient has to undergo. We cannot generalize that every one individual is going to proceed in the same manner, every individual is going to recover in the same manner or will respond to the situation in the same manner. Thus, neuropsychological evaluations of every individual, rightly done at the right time, promotes a patient-centered approach. When I'm talking about a case study now, let's take an example of a patient G. I have just anonymized the thing. This patient is a female, 25-year-old. I have not kept it here. So the diagnosis for this patient was temporal region tumor and was scheduled for awake craniotomy. For the baseline evaluation, some cognitive tests, majorly for the memory assessment, short-term memory and long-term memory, because it was for the temporal region tumor. Language function test for naming fluency and comprehensions, and attention and executive function tests were planned for this patient. In addition to that, I have also planned psychological screening, for example, anxiety and depression, and emotional well-being assessments were done for that patient. The findings suggested that mid deficits in verbal memory and language fluency were there, and elevated anxiety levels due to the upcoming surgery were there. During the surgery assessment, during the awake craniotomy, intra-op monitoring was done. Real-time cognitive testing was done using continuous verbal memory and language function test was done. Patient asked to name objects, repeat words, and perform simple cognitive tasks. The role why it was done was to provide immediate feedback to the surgical team to avoid damage to the critical language areas, ensuring patient remains cognitively engaged and responsive. Post-surgery assessments, re-evaluation of the verbal memory and language functions were done, comparison with the baseline to detect the immediate changes in the pre-surgery and post-surgery timelines were done, and follow-up assessments of 1 month, 3 months, and 6 months of the post-surgery were done. Findings stated immediate postoperative temporal decline in verbal memory and language fluency was seen, but with the follow-up assessments, it was seen that there was a gradual improvement in the cognitive functions returning to the baseline by 6 months. So when in postoperative phase, when a family or caregivers or the patient sees that they were good enough before the surgery and now they are not able to do as good as they were doing pre-surgery, they get fearful, they get anxious that we wanted to get the surgery done because we wanted to improve, but we are seeing the decline in our face. Then was my decision to go for the surgery was right or not? But when they see the improvement and when it was told to them that this is the challenge which they have to undergo, that this will be the challenge, they may find some decline in their processes and in their functions, but over the period of time, it can be gradually improved. So there wasn't that kind of fear and anxiety in the patients and the caregivers. For this patient, the interventions and outcomes which were planned were cognitive rehabilitation, including the memory training exercise and language and speech therapy, psychological support in terms of CBT, uh, for the patient to address the anxiety, and participation in support groups for young adults and brain tumor patients. The patient was actively engaged with other patients as well, and the outcome for this intervention which was planned for the patient was significant improvement in verbal memory and language function, reduced anxiety level and improved emotional well-being, successful return to the academic pursuits and social activities, and increase in the confidence, and the patient got motivated enough to talk to other patients as well in order to motivate them. Now, integrating neuropsychology into multidisciplinary care, neuropsychological evaluations are a vital components of a multidisciplinary team approach to brain tumor care. They contribute to accurate diagnosis, treatment planning, and improve patient outcomes, which I hope you guys would have understood by the case which I have discussed. And basically, neuropsychological evaluations provide critical insights for surgical planning and intraoperative trainings, monitoring, guided the development of personalized rehabilitation and psychological support plans, which we can plan, which are tailored one from individual to individual. And neuropsychological evaluations contribute to significant improvements in cognitive functions and quality of life by enabling a neuropsychologist and the treating team to individualize and tailor the treatment plans for them. Thank you so much. It was a short one. I hope that.
Any questions from the audience? Thank you, madam, for the beautiful talk.
Thank you, sir.
I now invite Dr. Lakshya Raheja for his talk on navigation-guided stereotactic biopsy for deep-seated brain lesions.
Okay, good evening, everyone. I think this is the last talk or the second last talk that we have for today. And seeing as everyone is kind of spent, this is a relatively simpler topic considering all the complicated surgeries that we've discussed so far. So stereotactic biopsy for deep-seated brain lesions. Well, first we need to understand why we need brain biopsy, mainly for histopathological characterization. We have a plethora of neoplastic and non-neoplastic pathologies that can exist in the brain, including post-radiation changes, and sometimes it's difficult to differentiate it from recurrent or progressive disease. So all these changes need to be differentiated in the minimally invasive way by drawing small biopsy cores. So why we need stereotaxy is because it allows for the guidance of biopsy instruments in a very precise manner in the variable three-dimensional space of the brain. Now, this brain space is already changed. The anatomy is very different. It's entirely modified because of the edema as well, and that leads us into anatomical variations. Open biopsies can be difficult, and stereotaxy allows for guiding instruments precisely. So because of the recent advancement in all the imaging and stereotaxy techniques, precision of these techniques have increased. Minimal trauma, length of stay is very short, and there is a very short duration of procedure also. Mainly thalamic, capsuloganglionic, deep white matter, brainstem lesions, and multiple lesions are the appropriate candidates to undergo stereotactic brain surgery. To avoid any sort of vascular malformation, we have to pre-operatively rule out vascular malformations and superficial lesions, because we don't really need stereotactic surgery in superficial lesion. So broadly, there are two types. One is frame-based and the other one is frameless stereotaxy. In frame-based, we know that we fix the patient's head in a immobilized position, and with that we get excellent accuracy. So frame-based stereotaxy, basically the instruments that we need are the primary and secondary frame, the stereotactic arch that allows us different degrees of freedom for the biopsy instruments to go into the skull, and then the biopsy instruments themselves. The popular frames that are being used are Lexel frame and CRW frame. Now, why we need frameless stereotaxy is because it saves us a lot of time. In frame-based stereotaxy, we have to fix the head. We have to get the patient to a CT scanner or to the CT scanner, and then reacquire the image, decide the trajectory preoperatively, and then do the procedure. The image-guided neurosurgery, everything can be done preoperatively itself within the preoperative phase, 2 to 7 days before the surgery. And then we can take the patient on table and set up over there and plan before the surgery itself. So the working principle here is that we have to teach a neuronavigation system the physical space of the patient's brain and its correspondence to a neuroimaging that has been acquired preoperatively. This is done with the help of a trackable markers that are attached to the instruments that we are using. The positioning is usually done with the head fixed in a head clamp to immobilize the head. The position preferred is the one that the image was acquired in to allow to minimize the effect of gravity. We have the Mayfield head clamp here. You can see the dual Mayfield attachment and the registration frame. The registration requires two main principles. One is the point pair registration, where a set of 3 or more non-collinear points are acquired on the patient's head. It could be fiducial markers or bony landmarks, and then we check on the system whether that is corresponding to the neuroimaging. Then the surface contour registration allows us to capture a bunch of cloud of points on the patient's skull and helps the neuronavigation system learn the anatomy of the patient. So after registering the neuronavigation system, we have to plan. And for that, what we need to do is set the entry point. So for example, here we have 2 discernible lesions in one patient, which we required to take stereotactic biopsy in. And we set the entry points around the coronal fissure and directed 2 different trajectories. One was close to the splenium. The other one was adjacent to the corpus callosum along the body. Painting and draping is done, and then you make a small burr hole at the entry point. Then the articulating arm of the navigation system is fixed. We use a planar probe to align to the pre-planned trajectory, and we fix the precision aiming device there. And then from there, we take the we allow for the fixation of the precision aiming device and the reducing tube that allows for a biopsy needle to pass through and take multiple cores. Now it's supposed to be a blunt tip with the side cutting needle that is calibrated to a certain depth according to the neuronavigation system, and then we get live feedback while we pass the navigated biopsy needle into the tumor. Once we get there, we have to take multiple cores and send them for frozen section and allow for the frozen section report to be turned out positive. So how we can improve the accuracy of this procedure is, first, we have to get the navigation sequence imaging to be as per the specification. They have to be thin cut. They have to be contrast images. And additional imaging can be added to this, to the standard navigation sequences to allow for targeting of the hotspots like MR perfusion, then PET scan can be added. We must do an accuracy check at the beginning, at the time of the registration. There should be a correct fixation of the connectors in the frame. Any loose points can cause significant shift, and we have to avoid any undue traction or movement on the during painting and draping. So one of the main problems that we have with stereotactic biopsies, considering it's a blind procedure and the imaging has been acquired preoperatively, is that we need to improve the yield of the tumor tissue. So first thing that we can do is improve the accuracy, as I spoke about in the previous slide. Then we have to draw multiple cores. So once you get to a point, we have to take around the clock. So 12, 3, 6, and 9 o'clock cores. And after that, we withdraw the needle a little bit and draw more cores from the same lesion. Then frozen section helps. And of course, lately there have been a number of studies with experimenting with the fluorescence. And with that, the accuracy has been determined to be increased. The complications that we can expect, the most dreaded complication here would be a hematoma, and that around 1% of the patients end up developing this. So for that, immediate post-operative CT scan is suggested. Infection rate is usually low, less than 1%. There can be neurological deficits that the patient can develop, but with the addition of adjuncts like DTI, we can reduce the possibility of neurological deficits. So here in RGCI, we have the institutional experience of 52 cases over the last over the last 3 years. Locations that we have predominantly done biopsies from are the periventricular region, brainstem, and deep white matter biopsies. The histopathology involved glial tumors, predominantly high-grade, lymphomas, metastases, and other miscellaneous tumors. So we got frozen section positive in 51 cases, with one case giving us a negative yield. This is around less than 2% negativity, which is significantly lesser than the quoted than what we have found in the literature review. It's around 3 to 7%. So one of the tumors that we took biopsy was this lesion that we saw in the pontine region. The patients, this is a frame-based that we had done, and you can see the post-operative scan showing a very small air bubbles over there with the hyperdense lesion in the aqueductal region. So this turned out to be a lymphoma. Similarly, we had multicentric lesion that was there in the cingulate of the left side, and apart from that, it was also there in the middle frontal gyrus. And biopsy was taken from both the lesions. It turned out to be a higher grade lesion, higher grade glial lesion. Similarly, this cerebellar lesion along the right side, we had taken biopsy from, with the track being made in the posterior fossa in the prone position. So the one case where we did not get positive yield was a patient, 16-year-old female who complained of headache, and irritability and generalized weakness. On examination, she was intact neurologically, but had wound facies. She had been treated with steroids and other chemotherapeutic agents for lymphoma without any biopsy. We saw a perisylvian lesion, contrast enhancing, that we tried to obtain a biopsy core from. But on attempting the biopsy, we could not get any specific cores, and we kept having the feeling that it's a rubbery consistency. So in this case, an open craniotomy and neuronavigation guided open biopsy was done. The lesion was removed in toto. It was a rubbery lesion, as you can see here. It turned out to be tuberculosis, and which is entirely different management line, and so the patient improved significantly after that. Now there's some honorable mentions about different other methods of doing biopsy, within the frame of frameless frameless stereotaxy, we have a passive skull mount disposable trajectory guide, which provides access through a small burr hole. It gets attached to the burr hole, and then you can guide your precision instruments through that in the very similar way. It does not, it removes the hassle of having to connect the entire precision guide. Then we've all heard of the robotic arm that has been launched lately, and there is a targeting unit which is mounted, and then once you fixed it into the connectors, then it auto aligns to a pre-planned trajectory, and then you can allow the robot to take over, and the drilling can be done in a controlled manner, and then followed by that, the biopsy course can be drawn, without any significant, damage to the normal brain. One last modality is ultrasound guided biopsy. Of course, it involves a larger craniotomy, so that's a major disadvantage here. The one advantage here is that we have a live feedback from the brain tissue. We know where we are going into the tumor, what sample we are drawing, and if you can discern the tumor on ultrasound, then you can take the biopsy from that with the live image. Thank you.
Any questions?
What is your experience regarding the metastatic tumors when you do the stereotactic biopsy? I mean, do you find the complication rates different from the rest of the other pathologies?
Sir, they're comparable, but every now and then, if you get more vascular, let's say RCC mets, and in those cases, you can probably theoretically think that we'll have a higher rate of hematoma formation post-operatively. But apart from that, I don't think there is any.
Rest of the things are pretty same in both the sides.
Similar, yes, sir.
Nice talk, sir. I would want to know the additional advantage of usage of neuro navigation apart rather than just put a Lexel frame, get an MRI, and based on the coordinates, take a biopsy. With a error of less than 5 mm.
Yes. So
additional advantage of neuro navigation in your deep-seated biopsies.
So look, it again depends on who is doing the biopsy. So if you've got enough experience on Lexel frame, then you'll have very low error. At the same time, same thing applies to neuro navigation guided biopsies as well. So if you've done it long enough, you've got a workflow set up, then even that will yield comparable results, if not better. The big advantage is that you don't have to add the time of putting the frame, taking the patient to the imaging suite, and getting that MRI or CT, and then bringing the patient back, and then planning and doing that. So that is one major difference.
And what was the trajectory used for the pontine lesion which you had mentioned?
Precoronal.
Coronal.
Through the
So you have passed through the thalamus or through the ventricle?
Through the peduncle, yeah.
Through the thalamic peduncle.
Yeah.
Quite risky.
They're doing the biopsies in a GA or in the scalp blocks?
Mostly awake, sir. So
Awake.
yeah, not always, but every now and then. Yes, sir. Yeah. Asleep, yeah.
Nowadays, when people are doing the scalp block also, the biopsies.
Yeah.
There are many papers published with the scalp block biopsies.
I think we can close this session and hand over the proceedings to the organizers. Thank you. Thank you much.
It was quite an informative session. Thank you, chairpersons and speakers. Now I call upon stage Dr. Anila and Dr. Kaviraj to announce the results of poster competition.
Thank you, Duti. First, we will be announcing the prizes for the poster competition. First, I would like to call Dr. Prakash Singh, sir, and IC Prem Sagar, sir, to give away the prize for the poster presentation. And Dr. Anita, ma'am, please come on stage. So all the posters presentations were very good, and it was very difficult for the judges to decide amongst 6 people. Yeah. So I will start from the third position. Third position goes to Dr. Gagandeep Gupta. He must see that. Congratulations. From Medanta Hospital. Second prize goes to Dr. Sampath Dash. He is third year resident from RML Hospital. Thank you. So the first prize, any guesses? Dr. Akshay Rajput from GB Pant Hospital. Congratulations. So congratulations to all the people who have won the poster competition. All the work gone into the poster presentation was very, I mean, they were very good posters. Now we will start with the quiz competition results. And so there was a tie between 2 teams. So I will start first with the team B, which has got the second prize. So I'm starting the names. You can come on the stage. Dr. Azhar Muhammad. Dr. Kaushalya Kumari. Dr. Shreyas Badolia. Dr. Sandeep Yadav. Dr. Sampath Dash. And Dr. Gagandeep Gupta. Congratulations to all. So you can divide the prize amongst yourselves. all the participants have done very well in the quiz. So we are giving equal cash prizes. And what matters is the spirit of participation. Thank you so much, Team B. Now I will call upon stage Team C, Dr. Charishma, Dr. Anurag Anand, Dr. Rajpal Kori, Dr. Palak Mayer, Dr. Deepika Sharma, first prize, and Dr. Vachuni Konal, first prize. Congratulations on winning the first prize. सर आ गया फोटो में Okay. So now we will call upon stage Team A. Dr. Percy, Dr. Shilpa Pati, Dr. Monira Meya, Dr. Bhumi Agarwal, and Dr. Abhay Rajput.
For the first right only.
Though, yeah, there was a tie on. We have maintained. ये जो लेडी उनके people हैं। First.
Thank you, Dr. Anila and Dr. Kaviraj. I know. Thank you, participants. As we come close to this conference, I would thank each and every one of you for your time, engagement, and contribution, and the insights we have shared will undoubtedly drive progress in our field. And I look forward to seeing how we all put these efforts into action moving forward. I request Dr. Kaviraj to please come on the stage.
Good evening, everyone. This is my proud privilege to give vote of thanks. At the onset, I will thank our chairman and CEO, sir, to spare their valuable time for inaugurating the conference. And I would like to thank our director, sir, Dr. S.K. Rawal, to give the initiative and full support for organizing this update. I want to thank Dr. A.K. Diwan, our Director of Surgical Oncology, for their full support. And I'm definitely very thankful to our mentor, Dr. I.C. Prem Sagar, sir, who, as this meet is a brainchild of this our sir only. I would like to say special thanks to Dr. V.S. Mehta, sir, and General Prakash Singh for coming as a chief guest and to grace this conference. And I'm also thankful to our medical superintendent, Dr. Pinky, and her team for continuous support during preparation of the conference. I am also very thankful to all our speakers to spare their time and present their valuable insights on various topics. I will specially mention Dr. Ali Asgar sir, Dr. Sushant Chahu, Dr. Rakesh Jalali, Dr. Carlos Serra. I'm also very thankful to all chairpersons to spare their time and gracing the dais. I would like to extend thanks to all the delegates, particularly the resident doctors who eagerly participated in quiz and poster presentations and who made this conference a live conference. I'm also thankful to all the members of organizing team, that is our Dr. Rajat Saha sir, Dr. Anila Sharma, Dr. Garima, Dr. Sarthak, Dr. Anjali, for taking pain and active participation since the beginning of the idea. I'm also thankful to all my colleagues, Dr. Lakshay, Dr. M.S. Chobe, Dr. Satyavrat, Mr. Bhagwan Das, and Sister Sashi, who put extra efforts during the preparation and during execution of this conference. I'm also thankful to all my colleagues of RGCI, including both seniors and juniors, without whom this presence, this meet would not have been possible. I'm thankful to Mr. Manoj Mahajan, Mr. Manish, Mr. Pinky, Pragati, Pallavi, and other staff of marketing team for continuous hard work. And again, I am thankful to Mr. Dwivedi, Vinay, Rahul, Pradeep, and other support staff of IT. I'm also thankful to Mr. Rajesh Thakkar and other finance team. I'm thankful to Mrs. Megha for brilliant performance for Ganesh Vandana, and special thanks to our sponsors, Fusion Med Devices, MS Surgical, Medtronics, Cure Surgical, Intas Pharma, Sun Pharma. I'm also thankful to our F&B manager, Mrs. Poonam, and her department for the tasty food and services. I'm thankful to Rudra Events for a nice tents, and I'm thankful to Mr. DP Tyagi and his team for arranging security and transport facilities. I'm also very thankful to all the supporting staff in the hall. And last but not the least, I'm thankful to sanitary staff. And I'm also very thankful to any other whom I must have forgot the name to mention. Thank you, everyone. Thank you.